practical consequence of this is simply to aim for 30% platelet inhibition by whatever means you can. Is that correct?
Correct.
Okay. So how would you do that? How are you going to do that in your practice?
So we have a step-up approach right now. Because there's more questions, right? How many patients are actually resistant to Plavix? And you have to think about other things as well. Like I can't just put everyone on Brilinta, for example, because that's not generic, right? So then they're going to have to pay for it, and then patients can't pay for it. Or Xarelto, for example. So what we're currently doing is patients come in on aspirin monotherapy, for example. We do a TEG. If they've hit 30%, you're done. You're treated. If they don't, we add Plavix. Check again in 7 days, platelet lifespan. If the number doesn't hit 30% at that point, we send them for resistance testing and add Brilinta or ticagrelor in place of Plavix. And I hypothesize that Brilinta is going to replace Plavix as the mainstay in dual antiplatelet therapy.
Okay. And then my second question is this. I am perhaps a little bit of a crackpot in that I do believe in weight-based aspirin dosing. Do you have an opinion about that?
Actually, funny enough, I worked in Dr. Holcomb's lab when I was a baby. And one of the things that we did on the side was actually test different doses of aspirin to see what it did to platelets. And at least in that short experiment, it didn't seem to make a difference. So it seemed like the aspirin dosing didn't matter at all.
Okay.
But who knows? And the 325/81 comes from just tradition. The cardiologists use 325 and the cardiac surgeon, and we do 81.
Okay. All right. Any other questions, please?
Brilliant as always, Dr. Dua. Just curious about some logistics of the TEG itself. I just put the machines into all 6 of our trauma centers in New York. Well, Bellevue's giving me trouble. So which platform was this? Was this the platform?
6S.
6S. So which is for folks to know, it's no longer the actual cup and it's let's just call it an ultrasound cartridge, which is pretty cool, but it's a point of care gizmo, right? I have a feeling though at MGH, the docs aren't running the thing, even though it's point of care, or are the docs running it?
No, not at all. So they're not, MGH is pretty, we're not allowed to do any, it's all research currently.
Right.
And this is also a different cartridge because it's the TEG platelet mapping one.
Yes.
And so right now, all these machines are in my lab.
Oh.
And but the beauty of it is that we do have time. So if you do the platelet mapping, you have like an hour and a half to do it. So what we set it up such that the patients have their blood drawn, or if they're coming to clinic, they have their blood drawn in clinic, and then we just run it to the lab and run it there. But ultimately, if I was going to put this in practice, to your point, it would have to be something that would be a lab test, which could be run by the techs. So we would be sending the blood the same way you send CBC, BMP, that sort of thing.
Right. And, for us now, we're doing it with the lab, but, with the new, it's called the TEG manager, you could see within 5 minutes, the art time develop out on the software. So, it's not this thing where you have to call the lab and wait for the result. During a trauma case, you can literally see where your patient is in 5 minutes by looking at the software.
Thank you.
Dr. Moore.
Yeah, very interesting work. I would suggest in the vascular community that you may be missing a component of thrombotic events, and that is resistance to fibrinolysis, as you know. And we learned this in COVID, that the combination of a prothrombotic state and an inhibited fibrinolytic state led to all these microthrombi. And we have found that in both trauma and in renal failure, that the TPA challenge TEG predicts clotting better than any other measure. There are ways to mitigate that. As you know, there are PI1 inhibitors. And I think what happens in many of these vascular patients is they're hyperinflammatory. They get extremely high fibrinogen levels. Their PI1 levels are up. Mm-hmm. Yeah, they form clot, but I think the problem is they don't break them down like most of the rest of us do.
Right. No, most definitely. When we originally started this study, Haemonetics was so used to sending the bleeding cartridges and the lysis cartridges that they actually sent us all that initially, and then we had to course correct it, but then we just started including it. You're completely correct. I'm sure that there are other things. And not only that, but within the TEG itself, like we're starting to see signals in MA and other things. We just don't have the numbers. So we're hoping when it's actually powered properly that we'll be able to pick up other things beyond, like what you just described, and potentially the MA, and see if platelets are something that we can do in conjunction with that to stop clotting.
All right. With that, thank you very much. Thank you all for being accommodating with the change in schedule. I would ask Dr. Coimbra and Dr. Efron to come up, and we'll go ahead and start with our first session, Specialties in Education 1.
Good morning, everyone. We are going to start the Specialties in Education 1 session. Number of exciting talks here. The first is Coordinating Vascular Trauma Surgical Care with Primary Trauma Service. Presenter is Christopher Ramos.
Good morning. I hope I can make this exciting. I'd like to thank the EVTM for allowing me to talk here to you guys. I'm one of the vascular surgeons at Grady Memorial Hospital in Atlanta. I have no disclosures. I will briefly review the key aspects in coordination of vascular trauma, in which include hemorrhage control, followed by the multidisciplinary approach to polytrauma, which in order to be successful requires clear communication amongst teams. And we'll finish with a case review to highlight these points. The primary goal in trauma care is hemorrhage control, followed by damage control interventions in the setting of non-compressible torsal trauma, a thoracotomy, or laparotomy may be necessary for hemorrhage control, followed by adjunctive measures such as REBOA and endovascular interventions, which have been covered at length here. These would need to be performed expeditiously for life-saving maneuvers. Direct communication between the primary trauma team and the vascular service is required for immediate response. Also, peripheral trauma may be compressible and controlled by tourniquet in the pre-hospital setting and requires immediate revascularization upon arrival to the trauma hospital. Similarly, peripheral trauma requires coordination by the primary trauma service with a consulting vascular surgery service if there is a vascular injury requiring specialized care, or the orthopedic service if there is a fracture that's associated. The evolution of trauma management has led to a team approach to deal with complex injury patterns that are encountered. The multidisciplinary approach requires the primary trauma service to perform the initial primary and secondary service in the trauma bay, followed by coordinating care with these subspecialty services, amongst others. Following the index intervention, the trauma critical care team takes over and continues communication and coordination with all these specialty services for successful management of the patient. Here we present a case of a 71-year-old male who presented after being crushed between two cars. He initially presented hypotensive with tourniquets in place and responded to a blood transfusion. Initial exam revealed no evidence of torsal trauma with only complex fractures of his lower extremities. FAST was negative, chest and pelvic x-rays were negative. The tourniquets were removed without evidence of external bleeding and also without pedal signals. Despite attempts at fracture reduction, there was no return of signals in his lower extremities. This is an image of the patient's lower extremities at presentation. Due to stabilization of the patient's blood pressure after transfusion and the nature of his complex fractures, the patient underwent CT imaging of his lower extremities. Here we found that the patient had transection of bilateral popliteal arteries, multiple fractures including the proximal left femur, bilateral distal femurs, and bilateral tibial plateau fractures. The patient was taken to the trauma team consulted the orthopedics and vascular surgery services, while the anesthesia team resuscitated the patient. The trauma and vascular teams simultaneously worked on exposing the popliteal arteries to obtain control of the injuries. The orthopedics team was also present to start getting the extremities to length. Following an embolectomy, shunts were placed. The orthopedics placed external fixators, and we get signals back, high fives all around. At this point, we turn to our anesthesia team and ask, how's the patient doing? To which they replied, fine. Is the patient on pressors? No. What's the patient's pH and deficit? 735 and -2. Since the patient seemed to be doing well, the trauma and vascular teams decided to proceed with definitive repair of his vascular injuries. Here's lesson number one. We had a failure in communication, and we failed to realize that the patient had an ongoing transfusion requirement to maintain homeostasis. Obviously, the anesthesia team wasn't hiding anything from us, but they answered our questions that we asked. So regardless, the left popliteal artery was repaired end to end. We repaired the left popliteal vein with a lateral venopathy. The right popliteal artery was repaired with a saphenous vein interposition. Due to the extent of the soft tissue injury, and fractures and combined arterial and venous injury, we performed 2 incision 4 compartment fasciotomies of the left lower extremity. Unfortunately, at this point, we were unable to close the skin over the popliteal exposures due to soft tissue edema from massive resuscitation. Now we were left with 2 medial popliteal exposure wounds and associated Morel-Lavallée lesions, fasciotomy wounds, and fractures requiring definitive repair. While the first 2 can be managed by the trauma, vascular, and orthopedics teams, the latter can only be addressed by the orthopedics team. Here's the key to this case and all other cases where multiple teams are involved. There needs to be direct attending communication regarding ongoing surgical management. There must be clear coordination between teams with a plan of when to return to the operating room and with which service. There should also be a plan B if for some reason the original plan is not complete. In this case, the primary trauma team was responsible to bring the patient back in 48 hours for wound washout and debridement. Unfortunately, a plan was not made about who would manage the patient's wounds in the meantime. Despite multiple teams being involved, the index dressing was not changed until hospital day number 3. The patient's wounds started showing signs of infection by hospital day number 4. Also, due to a busy trauma service and lack of OR availability, the patient was not taken to the operating room until hospital day number 5 by the vascular team, where the patient required excision of the skin of the leg due to the Morel-Lavallée lesions and debridement of necrotic muscle. Clearly, there could have been better communication, coordination of care of this patient by the trauma, vascular, and orthopedics teams, particularly when teams become busy or the OR has limited availability. To summarize, the primary trauma service is not only charged with hemorrhage control, but also with coordinating care with other surgical services. This obviates a best practice which requires clear identification and coordination at the index procedure regarding which service is primarily responsible for any residual surgical interventions required. This requires an early attending communication in circumstances when the primarily responsible service is unable to return to the operating room in the appropriate time frame. This is a two-way street in that if the primarily responsible service cannot provide timely intervention, assistance by other services should be available to assist. Ultimately, success in trauma management can only be achieved with clear communication between the trauma service and all the consulting specialty services. Thank you.
Questions from the audience?
Dr. Ramos, I would say I feel your pain because I'm sure lots of folks in the audience who are in leadership, are thinking about their recent case where the same thing happens. So, and I think one of the summary points you said is so important is don't do this to your residents, right? This kind of stuff, and that's where it gets lost. Even if they're very well-meaning, they just don't have the chops to, make these kinds of things happen. And so just the other day I had, it was a bad pelvis, we couldn't get the kid because ARDS back to the operating room for the screws in the back. And it was just circling nowhere because no communication. So I sort of called an emergency meeting at the bedside with the chief of ortho, us, the head of the guy that's working critical care for me. And within 2 seconds at the bedside, the decisions were made. So I don't, maybe folks in the audience have a better way of doing this. Maybe it's the morning report. Maybe it's a multidisciplinary round, but this is not well figured out in my place either.
Yeah, it's what I've learned from this case and earlier in my career is when you round, I go and find the ICU team, let's say, and tell them this is my plan for the day. Do you have my contact information? Please reach out if you need anything. Who's your attending rounding today, so I can reach out to them. With the implementation of shift work and multiple teams changing, the trauma attending that was on the night before isn't on the next day. You have to rely on the ICU team to really be the ongoing care team, and direct communication with them is key, obviously.
Other questions?
As much as I, and I'm sure other people, really hate the secure text messaging apps that they make us all download, one of the nice benefits is that for a given patient, you can create a group between you and the other attendings. and just be in communication about this. So it's like a meeting at the bedside, except it's on your phone. And I found that to be extremely helpful when the residents are either uninformed, they don't take ownership of the patient, or increasingly they're scared of their attendings and they don't want to wake them up in the middle of the night.
I think there's a layer to this that we sort of don't often talk about, that I experienced a great deal at my previous institution that I don't experience where I am now at Shock Trauma. A lot of the consultants that are invited are incredibly valuable, but are what I would call trauma hobbyists. And so you sit them down in a room and everybody agrees in an M&M that these are the steps for limb salvage and this is what we should do and this is how we should have done it. And at 3 a.m, all of a sudden, all concept of time goes away and I can just, and we can just. And I think, this goes to reinforce how important a trauma specialist leader is. Same thing happens if you ask for a hepatopancreatobiliary person because a young trauma surgeon is not comfortable in that area. You ask them to come and you will get a cancer operation, which is usually the wrong thing and sometimes deadly. And so, you have to not, and you really want champions in that situation.
Question?
It's not a question, it's a comment. I'm Devorah Weinberg from Johannesburg. We obviously do things a little bit differently, but one of the issues seems to be communication. And what we do is in our morning round, every new patient is reviewed by the entire team. We then have an overall plan for that patient. So everyone's on the same page. And every morning, every ICU patient is reviewed by the entire team. So that way we don't miss any patients. The on-call attending and the on-call resident is responsible for following up these patients. And then there's a direct handover of concerning patients between attendings. And that way, we still sometimes have, problems along the way, but generally our patients, especially problematic patients, are handed over directly. There's a sense of responsibility. Also, the trauma team is always in charge of the patient's care. So even if the vascular surgeon did the surgery, unless they've taken over the patient completely, the trauma team will take over the patient's management, will manage the dressings, et cetera, et cetera. And that way we don't have these kind of problems where nobody owns the patient.
Yeah, as a vascular surgeon, having done some trauma training in my residency, it's always hard for me just to say it's the trauma team's responsibility. Obviously, I own my patients, but when it comes to a trauma team, it's this very specialized group. Has been shown that trauma teams provide better outcomes than other services. So the patient should go back to the trauma service for sure. I agree.
Thank you.
Sure. Our next talk will be country-specific pre-hospital or interfacility transfer logistics. What only works here? Dr. Kassim.
Great, thanks. Thanks to EVTM for the invitation to be here. It's always a great conference to be at. I'm Zach Kassim. I work in the ED and the SICU in Philly, and I'll be many of you will know me as kind of looking at systems and systems approaches to things. So let's look at the systems approach to pre-hospital and interfacility logistics for here in the U.S. So the real crux of EVTM is that time to meaningful intervention really does matter, right? And we know that for some interventions, for example, REBOA, requires some specific expertise, and that needs to be deployed as soon as possible. And certainly yesterday we heard a little bit about our colleagues in UK, as well as our colleagues in Paris who have deployed this successfully in the pre-hospital setting within their system. And it makes sense because if you look at Holcomb's paper that described trauma systems in the U.S., there's a significant amount of time that passes from the injury phase to definitive hemorrhage control. And certainly just by bringing REBOA closer to the point of injury, we're shortening that time significantly and potentially improving outcomes significantly as well. But of course, when you talk about all that fancy stuff that happens in London over here, you get some raised eyebrows. And, there's certainly some challenges here as opposed to the relatively homogenous kind of approach to pre-hospital care in the UK and Europe. In the US, you can be working in a city that has a fantastic advanced pre-hospital care system, and the next county over, you might be working with a volunteer team that's really just struggling to meet their everyday needs. And so how do you kind of address that here, especially with the additional element that, pre-hospital teams in the US rarely have physicians. Although that is changing, we are seeing some evolution with, for example, the Maryland Shock Trauma Go team. We have the LA County HURT team, and in Philly, we're working on developing our Penn Halo team as well. But what can you do today? And when you look at different systems, you really just have to look at what you have available to you and leverage that. And that I really recommend that you read this paper that came out of Minneapolis, where they realized for out of hospital medical cardiac arrest that in hospital putting them on ECMO early really improved their outcomes. And this group felt that the hospital was not early enough, and so they worked across their entire system to work with different pre-hospital agencies and different hospitals to be able to identify these patients much more rapidly and shorten the time to meaningful intervention by having an advanced clinical team coordinate and receive these patients very quickly from the pre-hospital setting. And so that kind of leveraging of the system can work in your areas too. And that really starts with empowering the public. And so whether you're looking at an incident like this, the Boston Marathon bombing, or have even a single casualty that's exsanguinating on scene, remember, there is a time period that passes from the incident happening to the arrival of the first professional response unit. And so that has led to the development of courses from the American College of Surgeons and the American College of Emergency Physicians to develop what some term the spontaneous responder, the person who's able to provide some life-saving intervention on scene until professional help arrives. And certainly if you leverage existing apps that have shown benefit in out-of-hospital cardiac arrest, these are geolocation apps that can bring these responders to an incident. They can certainly rapidly attend to these and potentially improve outcomes. And if you further then co-locate bleeding control kits next to public access defibrillators, as is happening more and more in public spaces around the US, you then give them the tools to be able to deliver that care until professional help arrives. Next is train your experienced non-physician clinicians. So since you primarily have non-physician clinicians in the EMS systems in the US, leverage them. And these can include your senior EMS personnel, the EMS supervisor, could include your experienced flight nurses, flight medics. And the benefit of having these small skilled teams is that you can kind of maintain your quality there. You can focus your training, you can adhere to your standardized procedures, and importantly, you need to adjust your logistics with them as well. If they're a finite resource, they need to be dispatched appropriately so that they're not wasted for low-level cases. And the goal really should change from transport to shortening the time to meaningful intervention. And those meaningful interventions could be delivering blood on scene. They could be utilizing ultrasound, like we heard a little bit yesterday, doing a fast exam, but also, and this has been shown in some teams, to be able to obtain early arterial access. And that could shorten the time to placement of a REBOA once they arrive to hospital. Or you can train your interfacility teams to manage a REBOA catheter that's been placed at, say, a level 2 or 3 facility while they're managing this patient transporting en route to a level 1 facility. And this is what this team in Colorado has published on. So just by using those non-physician senior clinicians, you can provide them the tools to deliver blood on scene, maybe some hemostatic techniques on scene. You can have them do ultrasound and identify bleeding, maybe place an arterial line, but then what? And then finally, I think you should, in select cases, certainly think about bypassing the emergency department. Like we heard a little bit about yesterday as well, this direct to the operating room approach can be significantly beneficial. It's been shown to be a benefit from the military and has been translated into civilian centers as well, both in adult and pediatric studies. This has been shown to be of most benefit in penetrating trauma, shortening the time to intervention and lowering mortality than predicted. So essentially, you can stand there and essentially do nothing, or you can see what you have available to you and leverage the system. And this was really the premise of our paper that we published, myself and several colleagues who are in this room as well, to change this paradigm of scoop and run, which they were talking about endlessly, to this scoop and control approach, where we're providing early point of care, critical care intervention, and maintaining that momentum and care en route to the hospital. So I'll finish with this quote by Dr. McSwain. You can either whine about it that we just can't do this in our system, or you can just get the job done. Thank you very much.
Questions from the audience?
Good morning. Thanks for that. I've actually been looking forward to your talk.
Appreciate it.
So a couple of things are going to be statements and a couple of questions, and I'd love to get audience participation as well. As I wanted to pick your brain on this. We've been looking, my whole passion is pre-hospital care, tactical intervention as well for our tactical divisions. You've got this idea of where is this X, where can we intervene on these patients, and where we're going to make the biggest difference in hemorrhage control. Scoop and run versus scoop and treat, where's the best thing, and how best do we do this? Yesterday, a question was brought up, and unfortunately, I was online listening. I couldn't raise my hand, but are paramedics trainable? And I'm the first person to say absolutely yes, and I know there's going to be a little pushback on that. I was a paramedic, now trauma surgeon. Devorah Weinberg from Johannesburg was my instructor. This is something with brevity and repetition, I feel like we can make a difference. Arterial access, it is easy. Right, we can teach a paramedic, a very, mid-level paramedic to the advanced guys, how to do that for us, and we can at least have that stage done. We've timed it. We've said that a robo deployment takes about 6 minutes. All right, a lot of people are going to say, yeah, it takes me 3 minutes. No, so that arterial access is probably the longest period of time, especially if we're trying to train a second or third year resident. So I think these are things that we can do. I think it's going to be an important phase for the rural setting. I would love to pick your brain more about, should we be intervening on these patients on the scene? Should we get them to a facility that we can intervene at that point and then get them transferred across? And then just the one more thing for Minnesota, these guys have this amazing access because they got an $18 million grant. That seems to be our biggest holdback here in Maryland. So appreciate your thoughts.
Great. Thanks for your comments. No, I agree. I think, we're clearly seeing that there's a group of patients, especially with exsanguinating torso hemorrhage, that needs intervention earlier. And I think if you select within your system the right group of people, and that could be your paramedics, very, very rightly so, to be able to do at least steps of this, you achieve what are called marginal gains. And so, you shorten that time to, say, the next person doing the next step of the procedure. And as you say, arterial access is certainly one of the most challenging things. And number two is, having a pit stop kind of model has been seen in some systems. So Cleveland, for example, does that kind of thing where if a significant trauma victim shows up at one of their level 3 centers, they auto launch their critical care transport team to shorten the time to get there. Plus that team can potentially assist on scene with the clinical team that's on site. So there's different ways to do it in different systems that can shorten the time.
So we should just real quick. One of the things that makes me nervous is about this kind of stuff and the teaching is the success that we've had with tourniquets-ish. Yes, they come with them on, but so many of them are not on properly. And we have set such a focus on that. And it makes me worried that it's no longer sexy enough to sort of keep going with the turnover and the everlasting education before we sort of jump to the next most invasive thing that sort of occurs.
Yeah, it's a good point, and you give somebody something new and shiny, and they'll want to use it. And so, interestingly, just a few days ago, I was down in New Orleans speaking to a group out of Baton Rouge who just introduced open thoracostomy for tension pneumothorax for their medics, and they had the same fear that initially there was going to be an overuse of this unnecessarily in the wrong patient, and it really boiled down to a good QI process. and education and medical director involvement. And I think, at the same time, communication, as we heard in the last talk, between the trauma service and the pre-hospital service and the medical director in particular can ameliorate some of those issues. And in addition, kind of considering who's doing it, should all the medics do it or should the senior medics do it? Because a lot of times, an EMS supervisor might arrive on scene for these complex cases anyway, and so perhaps they have the tools to do it.
So one of the discrepancies that I think exists not only between the United States and other countries, but even within the United States regionally, is that whereas in London, there is an entity that controls all of pre-hospital care, in the US, that's not the case. And in Colorado, that's one service, right? At Shock Trauma, we have upwards of 15 different EMS companies who bring patients to us, and trying to standardize practices among all of them. And if you can tell me that a Baltimore City paramedic is as capable of being trained as a Butler ambulance service paramedic, I mean, that's an enormous gulf in where they're starting from, what their availability is for training, the standards to which they're held, the resource availability. And if we're going to introduce a new standard of pre-hospital care, I think that needs to be addressed, because otherwise you end up with a massive disparity in what different teams are capable of. And that's going to be linked to socioeconomic status of the various communities, right? So if you're rich, you're out in Harford County, sure, you'll get pre-REBOA or pre-hospital REBOA, you'll get the ECMO mobile. But if you're in Baltimore City, best of luck, pal. So how do we get over that?
Yeah, it is a big challenge, and I think that's why it's extremely challenging to provide a one-size-fits-all approach to this. And I think the answer to that is that you probably achieve a kind of a base level of maybe slightly more advanced skills that can be easily attainable for systems across, and maybe you do have some systems that are providing more. And you reference the UK, but the reality is that London is probably the only service that's providing pre-hospital REBOA, and if you're not living in London, you're probably not going to get that intervention in some of the other services. So there is that what they call postcode lottery for what you end up getting in some ways. And maybe the answer is just time. And you start with one, you show success, and then eventually people adopt that. And we've seen that with other interventions in medicine as well.
So I'm just going to make a comment more than a question. And this is a caution thing. Every time we are talking about this sexy pre-hospital stuff, we are talking in areas that probably don't need it. Like in Philadelphia, your numbers are clear that the police can transport the patient and they have better outcomes. And Philadelphia, Maryland, they go into this thing that, we're going to have this pre-hospital where it's not needed. Whereas in the rural areas where it's needed, there are no champions for this. So this is more of a word of caution that I don't think those places that want to do this, like London, I don't think that's where it's needed. It's probably needed more in the rural areas, but still, that's a London area that gets this. So this is more of a word of caution. Who is going to do this where? And it's not in the urban areas where we have, like in Philadelphia, I was visiting you have 3 level 1 trauma centers just next door to each other.
So I'll be devil's advocate and say, how do you know without looking at the data? So if you look at the data for example, you say it does not need it in London. So they did look at the data for pelvic fracture mortality, and they showed that almost 2/3 of their patients were dying from that injury pattern within London. And even dense urban environments have challenges in terms of transporting patients. If you're ever on the wrong side of town trying to get to the trauma center, trying to go through, say, Houston traffic or something like that, then that time adds up. And so some of these interventions might well be needed. So I would say you're right in some ways that some cities or some systems may not need it, but I would say be cautious about that and look at your data first and prove that you haven't lost patients significantly that are potentially savable.
All right, thank you very much. Next talk is optimizing REBOA education in the ED. Dr. Moore.
Good morning, and thank you, Ralph. And I want to thank Chuck and Ricci for the kind invitation to join this wonderful forum. I have the pleasure of working with a number of industry partners, and don't think any of these will materially affect what I'm going to say. I also want to recognize our fearless leader that inspired this meeting, and I think this has been a wonderful session, and we look forward to the next one. Congratulations, Tom. Well, I was asked to speak on the topic of optimizing the use of REBOA in the emergency department, and I'll continue on the theme of time. And I think that to educate the emergency department environment, we need to practice the techniques before the patient arrives and be prepared. We were fortunate to have Chuck Fox join us after his tenure in the military and his vascular training. And he came to Denver, and shortly after his arrival, he took me down to San Antonio to show me this shiny new toy. And that's how we implemented the REBOA program in our institution. Well, we recognized early on that one of the first problems in emergency department use of REBOA is equipment's all over the place. And when the patient's in distress, it's impossible to find the needed equipment. So we generated a mobile REBOA cart that stands outside of the two major trauma resuscitation bays, but can be taken to all other rooms within the emergency department. And on the top of that has salient facts you need to remember if you haven't put a REBOA in for a while, where it goes, how much volume in the balloon, and the anatomy relevant to the balloon position. Now, this cart is organized so it is developed as an efficient manner. The first tray is access, and no one's allowed to touch the next tray until that tray is used. So you bring the first tray out, get the access equipment. The next tray is the contrast with the saline. The next one then is a REBOA, and then you start putting the cables, and I always use a pen to mark the timing. And at the bottom are other features you may need. But the card is arranged in a time sequence fashion. And I think one of the most important things, and we're lucky in our environment to have EMS embedded with our hospital. So it's rare for us not to have 5 or 10 minute warning of a patient that's in shock arriving at our institution. So what I do is go to the emergency department, pull out a tray, and prepare access like this before the patient arrives. Because once the patient arrives and the nurse says, this patient, I can't obtain a blood pressure, then the whole room is chaos. No one listens to you. No one can find equipment. Everybody's trying to do their job, and it's impossible. So if you're going to put a REBOA in efficiently, you got to be independent in the emergency department. The first thing is access. As we all know, that's the key to REBOA is access. So having this equipment on a tray next to you with the resident facilitates rapid access. The other problem is, frankly, most trauma residents don't have the needle and wire skills required for REBOA. We all know that. We've talked about that. But if we're going to learn to be efficient with a REBOA, then we have to place catheters in patients who aren't dying, so we learn the technique. In our institution, any patient with sustained systolic pressure less than 100, we place a 5 French arterial catheter. Last week, I placed 2 of them, as well as a REBOA. But the 5 French is a nice practice. You're using the 0.018 iron and a 21 gauge needle, so it's a little more difficult actually than the 18 and 0.035, but it's great practice for the residents to put in a 5 French catheter. And then again, if we're going to use REBOA in a timely fashion, we have to place a sheath preemptively. At our institution, we place sheaths for a systolic pressure of 90. We all know the problems with the common femoral artery, and we always place REBOA with ultrasound, and even in CPR we do it. And I keep telling the residents it's all about pattern recognition. The femoral artery is anterior and lateral to the vein. So it doesn't matter if they're undergoing CPR. I put a Reboa in the patient a couple of nights ago undergoing CPR. You can do it easily. And the blood comes out. It looks like you hit the vein because that's what it looks like when you're having CPR. But again, it's important that we get this within the common femoral, not too high into the external iliac. So it's critical that when we use the ultrasound that we follow forth in the follow the anatomy into the pelvis and back. And then the most recent thing we've done, which is probably about a year now, is we have a dedicated ultrasound for the Reboa cart. Now that may sound crazy, but I'm telling you that the problem is when these patients are dying, everybody wants to grab the ultrasound probe and look somewhere where they're interested. And they look at the heart 15 times. I don't think there's fluid there. They look there right up a quadrant. Well, maybe there's fluid there, and you can't get the probe when you need it. So we have a dedicated ultrasound, and it sticks with the cart. It's in the hallway outside, again, the resuscitation base. Now, the other thing about the ultrasound is a simple one. It's already preset the gain and the distance. Sometimes, of course, based on habits, you have to change the depth, but basically it's set up. You grab the probe and you're ready to go. Compared to the 787 back there that our emergency medicine colleagues use that have 85 different knobs on it, and you're looking at M mode, we don't need that fancy little machine for putting in Reboa. You need a straightforward, simple ultrasound that when the residents see it, they see the same machine every time. And then I think it's critical that we get plain films and make sure we have the balloon position. And it's a simple thing. You put a little contrast in. As you know, we mix the contrast 1:4, so it's not too viscous to place in. And we debate about the balloon positions, the distance, and now all the Reboas are marked, so we don't have to think. But the fact is that almost invariably 28 works perfectly. If you get someone like David here, you may have to go up to 30. But nonetheless, it's a pretty guaranteed position for the zone 3 and 48 for that. Now, as I alluded to yesterday, I think the thing we need to be careful with the Reboa is not to be overzealous with augmenting pressure. And we are particularly concerned about hypertension and brain injury and torn aorta. And if the patient has signs suspicious of a TBI, we don't allow the systolic pressure above 120. And if they have a mechanism that is consistent with a torn aorta, we don't exceed 100 until we get the CT and confirm they don't have a torn aorta. And as you all know, 7% of chest x-rays are absolutely normal in patients with torn aorta. So just even though you have an x-ray that doesn't show a mediastinal shadow, it doesn't mean they don't have a torn aorta. And I learned this from our military colleagues. It's critical that we document what we're doing with Reboa. You look at the literature and no one can tell you why they put it in, what the pressure was. And so what we do in our institution is use a blue pen and mark every time we alter the Reboa. So you see here a patient of mine a while ago. This is a zone 1 placed at 1420. I don't know how we had a trauma patient during daylight, but it was a rare one. We were positioned at 45 centimeters and we put 13 cc's in the balloon. And then at 1430, keeping the pressure at 100, we dropped 2 cc's and so on until it came out at 1503. And then at the end of the operation, I get my old iPhone out and take a picture of this because I guarantee you go looking through the records and it's, Reboa's put in. Well, that was a sheath actually. And then, you can never document the volume in the balloon unless you do it yourself. Now, the partial Reboa, we talked about this, and this may attenuate some of our concerns about prolonged ischemia. And the trial now, I think, will substantiate that the Reboa, partial Reboa concept is real, and it's certainly a facilitator with this device. One of the other challenges we have, as you all know as vascular surgeons, that sometimes your body size doesn't correlate with your vascular size. And this was a patient I ultrasounded the other day and said, whoa, I'm not putting 7 French in that one. And as you know, now we do have smaller catheters that can be used not only in this condition, but certainly in adolescents that will facilitate the use of Reboa in the emergency department. So in sum, to optimize Reboa in the trauma, we need to establish a collaboration, train entires, acquire the skills, and the skills are acquired real time in real patients. So you are ready when the patient arrives, preemptive sheath, and then monitor your results and refine your indications. Thank you very much.
Questions?
Great talk as always. As Dr. Efron said, so there was a something shiny thing that was going on with Reboa, let's say 5 years ago. And, at that point, in New York, I had a routine training program with my faculty on our Monday morning report. Every 3 months, we'd bring the little simulator in and we'd all go through it. But, COVID hit and we're not doing that anymore. The question is, how are you keeping your people sharp for Reboa?
Well, exactly this. I preach to our attendings. You got to do preemptive sheath placement. You got to get down to the resonance.
I mean,
Do
the
the
training,
ultrasound.
routine training.
Well, we do routine because we use Reboa routinely.
I see.
And again, we place 5 French for 100, sheaths for 90. And so all the attendings and residents go through it. Now, one of the problems is we do have rapid rotation in residents. You look up in the schedule, all of a sudden there's 8 new residents. You don't even know what their name is. So I have now a standing committee with the APPs in which I go through Reboa, which Ryan used to do at our institution. And the APPs want me to do this every month. So when the new residents come in, I'm going to go through this exact talk with them. But I really think to implement this, it's got to be in the ED training real time. That's the only way we're going to get shorten the time to Reboa access.
Very good.
I just wanted to say, during my time in Denver, because we had a very big GME program, that we did every Friday about 10 varicose veins. And if with vein ablation, access can be challenging because you're using a small needle and cannulating the saphenous, and all the residents got extremely good using ultrasound and also cannulating the saphenous vein. And I think then they go on to trauma call. Then using that ultrasound and getting femoral access was a bit familiar for them. So you have to sort of tailor the resources of your own institution, but the vein program we had was very helpful.
Yeah, you're absolutely right. That's an area we look on for collaboration from the vascular team. And if the residents feel, quote, uncomfortable in their anatomy, then we send them to the vascular clinic. You're absolutely correct. And as you know, I do all the AV access. And so we do a lot of ultrasound duplex with the access. So they get familiar with the equipment. But it's just a matter of repeated training.
Gene, congratulations again. I think the last couple talks have just been excellent. So thank you. I love the idea about the Reboa cart. I think you probably have the leverage at your institution to make that happen. Maybe not everybody does. So that's super cool. And having a dedicated ultrasound to do that is also like awesome. My question in the cart, because the other piece of the puzzle is closure or removal, is do you have the bottom drawer, the bottom drawer, which is like, get the damn sheath out. Don't go to the OR, don't go to the ICU, or if you go to the ICU, make sure somebody knows how to take the sheath out. And we haven't really figured out a good closure system other than holding pressure for a long time. And if somebody's cold and coagulopathic and they've lost a bunch of blood, closure is going to be harder than you think. So I'm curious what your thoughts are on putting the bottom drawer as closure so that there's not a complication related to getting the sheath and the Reboa out.
Well, I think you're correct. And we're aware of the need to remove both the Reboa and sheath promptly to avoid thromboembolic complications. But frankly, in this scenario, when we put a Reboa in, that cart's out of sight and we're in the operating room. And so in the operating room is, I think, where we need to focus it. And again, it has to be the attendings that drive this. But I personally, when we have a Reboa in, I put betadine on the syringe and put it in the field. And I manage the balloon volume and I manage the level myself. I have great respect for anesthesia and we have great relationship, but they don't understand physiology of Reboa. And only the attending surgeon does. And they should be managing where that is and where it is. And so we typically try to get that Reboa out as soon as possible. And if the tag is normal, then I take the medical students falling asleep over there at 3 in the morning. And I said, put your hand here. And I pull the sheath out and say, look at the clot. Don't move your hand for 30 minutes. And Chuck knows, he was there, and Ryan knows, we'd never seen a pseudoaneurysm from a 7 French. Now, back in the days when we were using Coda, we did have some, but not with the 7 French. We've not, and we don't use fancy closures. We just put our hand down there. Maybe we're lucky.
Hey, so
Sometimes.
Ryan Fransman from Shock Trauma again. I'm going to piggyback on that. I actually could have just sat down because that was my exact question. But, the vascular surgeons that are pulling Reboa, they're using the different closure techniques, which I find to be the hardest part of the entire Reboa process, is just trying to memorize the 4 steps of the closures. But you guys are probably putting as many sheaths, if not more, than we are at Shock Trauma. Half of us are holding pressure, half of us are using closure devices. You guys seem to only be using pressure. Are you doing follow-up duplexes? And if so, when and how often?
Well, we do a duplex within 24 hours on every patient that gets a Reboa. And then in the clinic, we examine them. And if there's any issues, we repeat it. But the duplex, that first 24 hours is the last time we really evaluate them. And again, with the 7 French, we just haven't seen any problems. And Ryan's published our data on sheath access, and we virtually have no complications from the sheath itself. Now, the problems we have had with Reboa, frankly, have been because the Reboa has been in for extended period, and people don't examine the extremity in the intensive care unit. So we now have set protocols that the attendings called if the sheath's been in more than 4 hours and so on. But I try to get those devices out as soon as possible, because these patients often go, as we all know, from this hypocoagulable state to a phenomenally hypercoagulable and fibrinolytic resistant within hours. And that's when I think we form the clot. The most dangerous part, I think, is about 6 hours after you arrive in shock, you convert totally to a hypercoagulable state.
Thanks.
One last question. I worry less about our trauma residents, our surgical residents, than the emergency department folks, trainees, especially if we're going to ask them vis-a-vis our previous talk to consider doing these things in the very rural areas and stuff. How do you incorporate them into this training?
Well, as mentioned, the insinuation of the carton and the ultrasound was easy in our emergency department. We have a great relationship with emergency medicine. Of course, they want to do it, and I can sympathize with them, but I got to train the trauma surgeons first. But they're very into it. They're very excited. They watch the Reboa going in. They're excited to see the films. And I think, again, if we're going to insinuate this into other environments, then we're going to have to do similar a process of continued training.
Thank you, Gene.
Thank you.
Our last talk for this session is Development of Reboa Teleeducation Amid the Pandemic by Dr. Matsumoto.
Good morning, everyone, and thank you for inviting me. I am very honored to present my topic here in Baltimore. Simulation education is essential to acquire knowledge and skill sets of Reboa, such as direct or the best course or EVTM. But COVID pandemic has made it difficult to continue on-site group training. We aim to improve the Reboa simulation with the tele-education program and try to advance the standardization and sustainability. We have developed a Reboa education program that consists of didactic lecture and skill set simulation. The lecture was converted to the online program first, and the effectiveness and sustainability were evaluated. And then we started trial of the web-based skill simulation. And this is a traditional, the conventional style of the simulation. the US guided puncture and VIST and the silicone model. And then to standardize the material, we published a textbook of our course. But of course, this is written in Japanese. So for international readers, we published a series of the review article that contains our teaching material. For example, the combination of the thoracotomy and rebore, and the partial rebore and the intermittent rebore, and the proactive use of the whole body CT with rebore. So the lectures were on Zoom, and the small group discussion were conducted in the breakout rooms. The course is designed as an interactive course, and we joined. This course was joined with Japanese Annual Congress of Emergency Medicine and Trauma. And first, we had the lecture section, and then we had a small group discussion in Zoom. Then we evaluated the post-course improvement between the web-based course and on-site course. So on-site course, after the on-site course, both the test score and the skill-related score were improved. But after the web-based course, the skill-related scores were not significantly improved. So we try to improve the online skill simulation. So we prepared a simple and inexpensive simulator at just only $300 at each facility. You can purchase and you can rent, and set up by the local staffs. Usually they are senior fellows or attending physician, and they have already taken our course. And the tips and pitfalls were taught by us instructors. And this is like the private lesson just for 2 or 3% per session. And even after the course, the students can repeat the practice at their own facility using that simulator. And then the US guided puncture using this is a kind of food, Japanese traditional food, konnyaku. This is a hard jelly. This is a perfect simulator for the ultrasound guided punctures. And even through the display, we could recognize very small mark on the catheter, so we can point out the very tiny action during the session. And this is the view of the local setting. All you can prepare, you should prepare is only the laptop PC and the video camera and the smartphone. And in the simplified session, all you need is just PC and a smartphone, and you can use the PC web camera. It's very easy and simple. And these are the change after the online skill simulation, but only trial session we have finished. After the course, the skill set scores were improved. So the web-based course can reduce the cost of equipment, lodging, and transportation. And it can be held more frequently, and it can increase the sustainability of the education even amid the pandemic. So we don't want to stop the education because of the pandemic. And in near future, now we are trying to make the VR simulation using the 360-degree cameras. So this is the simulation view, but we may be able to use the real resuscitation scenario in the ER or OR. So the student may understand the role of a reward in the entire resuscitation process. And they can experience the simulated environment with a sense of urgency from the operator's point of view. So in conclusion, reward education provides not only knowledge, but skill sets. And compared to group training, this method is less expensive and more sustainable for both instructors and trainees. The development of higher quality web-based educational methods, such as VR, is expected. Next year, we will have the World Trauma Congress in Tokyo, so I'm looking forward to seeing you. And hopefully, we will have the EVTM in Japan in near future. Thank you for your attention.
Questions?
Thank you for your excellent lecture. I think it's really pragmatic to solve it in the COVID issues. I think it's interesting because in the Netherlands, we're also now doing it with the head-mounted display, so that you really have the images with the Google Glass or all the Visumix. So you have glasses that you can also, especially when you're teaching, that in the head-mounted display, you have the images on the side of the eyes and you can really point it out. And that maybe in the practical part, it's a little bit easier, and then you have the 3D view as the instructor, but you can really interact also with participants. So that's something you could add in the future research.
Yeah, now we are trying to make such a great tools and using the whole entire VR, and we can combine with the local view, including a scale, the catheter manipulation. But so far, how we haven't. But now we are trying to create such VR material. Thank you.
Quick question.
Yes.
I'm always interested when I look at, papers and presentations like yours. You put a course together, you teach people, you measure immediately after the course what they learn, and they all learn to some degree. But the real question is retention of knowledge. To me, this is really important. How often do you need to teach people to maintain their knowledge? So have you done long-term assessments of the retention of their knowledge in the system?
Yeah, great question. That's exactly we want to try to do. So now we're trying to the long-term follow-up, but probably the result is not sufficient. So that's why we try to make this system so you can practice at your facility after the course. So hopefully, once a month, the students should practice using the simulator at your facility. But in real settings, so far, we haven't. Once a month is, I think, enough.
Thank you. No other questions? Thank you very much. Any other questions from the audience to any of the presenters? Previous talks? All right, if none, thank you.
Everyone, in case it's not clear, we have a breakfast break, so go eat. We'll be back here in 20 minutes. All right, I hope everyone had a good breakfast. Coming up now, we have Reboa for Trauma, moderated by Zaf and Megan Brenner. So first talk is on. Yeah, no, really go straight to
How are you? Yeah, I'll start. Yeah. All right, guys, we're going to get started on the next session. I have the pleasure of co-chairing with Dr. Brenner. I'm Zaf Kassim from Philly, and we'll be talking about Reboa for trauma. Unfortunately, our first speaker wasn't able to join, so we're going to be starting with Dr. Wilkstrom, talking about tools to facilitate the use and monitoring of pre-hospital Reboa.
Okay. Thank you for inviting me to come and talk here. Appreciate that a lot. I have no disclosures, and my name is Maria Wikström. I'm working at Karlstad Hospital in Sweden. And I'm going to talk about tools to facilitate the use and monitoring of pre-hospital Reboa. Is it
Working with the green arrow? Green arrow. Yeah. Yeah. There you go. There we go.
Right.
Mm-hmm.
Yeah. So Karlstad Hospital is located in the rural county of Värmland, and it's characterized by a lot of forests and the countryside. And the distance from Karlstad to the most northern parts of Värmland is about 200 kilometers, and it takes about 45 minutes by helicopter. And which means that our helicopter service works in a completely different setting than the urban setting of the London Air Ambulance that we heard about yesterday. We share, of course, common pre-hospital challenges, but in this remote setting, the long transportation times require us to stay and play, as opposed to the established pre-hospital scope and run model that we are used to. And the military shift we have seen during the past decade, with a shift away from the golden hour model and rapid evacuation to a higher level of care, to a more prolonged field care, require us to find tools to stay and play and stay in control. So what tools do we have to stay in control, and what tools do we have to manage life-threatening torso hemorrhage? Well, in the bottom of our toolbox, we find the Reboa. And this brings us down to the topic of my talk, namely what tools do we have to facilitate the access, the placement and the monitoring of our pre-hospital Reboas. Early access is crucial and also considered as the most time-limiting step in the Reboa procedure. And timely access is likely to have the greatest impact where evacuation times to hospital is longest. But there are a lot of challenges to the access procedure, and some of them are listed on my slide. So to guide and help us with the access, we have the handheld ultrasound device that I think most of you are familiar with and perhaps use on a daily basis. There are also smartphone ultrasound apps that may have a place where standard ultrasound devices are not provided or cannot be afforded, such as low-income countries and They may also play a role for individual physicians working in field, perhaps at sport events and in forward austere environments in the military setting. So they may have a role. In the future, we might use handheld ultrasound-guided artificial intelligence devices. This is a study from last year done on a combined porcine model and a tissue model that we might see more about in practice later on. Still not on the market. So there are a lot of new devices for access under development, but some of them have recently got their patent applications approved, and it's difficult to find any detailed information about them. So I can't really tell you much about those devices, but I'm looking forward to hear more about them on future EVTMs and see them on the market. So moving on to placement of Reboa and what tools we have for placement. In the pre-hospital setting where fluoroscopy is absent, blind placement of our Reboa has to be performed, which has its limits and risks. And without fluoroscopy, we can use the ultrasound, as mentioned, ultrasound devices, but in the future, we may also use infrared technology, radio frequency detection, or magnetism to guide our Reboa placement. And this is an example of a smartphone-based device that uses infrared thermal imaging for detecting Reboa placement. And this is a cadaver study where they took a radiofrequency tag from a laparotomy sponge and affixed it to the tip of the Reboa catheter. And then they detected it by using a radiofrequency Assure wand that you see on the picture to the left to detect the intravascular Reboa. And successful use of magnetically trackable Reboa balloons has been demonstrated by Resende Neto and his colleagues in this study from last year in a porcine model. So to provide hemorrhage control while at the same time limiting the side effects of aortic occlusion with a distal ischemia, partial Reboa has emerged, as you all know. But the traditional Reboa balloons with a compliant design has proven not to be that suitable for partial Reboa due to the difficulties to titrate the flow and to adjust the balloon volume. So new semi-compliant balloons has emerged and seems to be promising for partial Reboa. And hopefully the partial Reboa can help us to extend the tolerable duration of zone 1 occlusion and allow for longer transportation times. So here is one of the promising new Reboa balloon designs that you are all familiar with, and perhaps many of you has used it already, but it's quite new, and it's a combined semi-compliant and compliant balloon that had 2 channels of flow. And you can, of course, watch it out in the room beside here. Recently, Powell and his colleagues presented this new Cobra balloon that can provide an alternative for partial Reboa. And it has a very favorable design in its compliant ability for inflation, and also it has a good control for titration during deflation, and it's also good safety if you overinflate your catheter, your balloon, and of course it has a 4 French sheath, which is also an advantage. An alternative to partial Reboa was presented by Williams and also Dr. Rasmussen, I think, was in this study, with this extracorporeal circuit providing a controlled amount of blood flow from the carotid artery to the left femoral artery, providing distal perfusion while at the same time maintaining proximal aortic pressure. So very favorable and perhaps an alternative for our partial Reboas in the future. Okay, so to monitor Reboa occlusion, we have, of course, our standard arterial lines, but they may be helpful, of course, but they may also be a bit unavailable and cumbersome in the pre-hospital setting. So an alternative to those standard arterial lines may be the Centurion Compass device that has been commonly used for central venous line placement to avoid accidentally arterial cannulation. And this is a small portable vascular arterial pressure monitor that is suitable to measure MAP. And it has been shown to be clinically comparable in its MAP measurements compared to the standard arterial lines in critical care recently. How about the use of Centurion in trauma? Well, Holterstall showed last year in his study that you can use the Centurion successfully to guide resuscitation and intermittent zone 1 Reboa occlusion in an animal study at least. The use of trauma is new scientifically. The use of Centurion for trauma is scientifically new, but it's not new in clinical practice. It has been used for a while clinically, and that was demonstrated well by Northern and his colleagues from the military setting. They presented Centurion was used for 15 patients in a military setting successfully, combined with partial Reboa. And that was 2018, so quite a while has it been used. I don't know, perhaps many of you have clinical experience from it. All right, to summarize, in remote places where you have long distances, long transportation times, situations of prolonged field care, you need to stay and play, stay and control, and we need tools to stay and control. And partial Reboa might be such a tool. To guide the access, Reboa access, we may use handheld ultrasound devices. And in the future, hopefully, it might be artificial intelligence connected to the ultrasound devices. And to guide placement, we also have the ultrasound for our help. But in the future, we may use infrared imaging, radio frequency detection, and magnetically trackable balloons. And to monitor our Reboas, we have the partial Reboas to facilitate and the new balloon designs may facilitate the use of partial Reboa. And to monitor, we have the standard arterial lines, but also the Centurion device. And it's another issue, but the question of if it's pressure we should monitor, or if it's flow, or if it's return of distal waves, or if it's end tidal carbon monoxide, that's another issue. What to monitor. All right. Thank you.
Great. Thank you for a great talk. Any questions from the audience?
Thanks for your lecture, of course. I have actually a short question because, you know, I like the prolonged field care phase a lot. But I think with Reboa, at some point there needs to be a cutoff point to use it or not, because when your evacuation time is too long, so then it's not stay and play anymore, but then it's just doing something without an endpoint. So what's the maximum time you consider for evacuation if you use a Reboa in any form?
It depends on how long time, how far away the patient is for the helicopter to come. Our helicopter has recently got a Reboa, so we haven't had a case with our helicopter yet, but they are preparing for it. But I think you have to look at the whole patient, the whole physiology, the distance to hospital, what injuries the patient have, and make a judicious decision of if you should put a Reboa or not.
The reason I ask is, if you talk about civilian life, with an MMT team, then it's just you go for it, and it's a civilian and you just try to go for it. But when you're in the armed forces and that you're in really remote places along the distances, and I know that the patient is, let's use the word, unstable, and I know my evacuation time with a severely bleeding patient is more than 12 hours. Of course, you can say, I try to stabilize the patient, but I don't see how you can stay and play when the patient needs the definitive treatment on that.
No,
and if you don't have the surgical option, of course.
No, I think you have to use it to transport the patient to care, of course, but it can extend the transportation time if you can use the Reboa. And I'm now talking about the helicopter possibility to transport patients, but in the prolonged field care and in the field, of course, you have to think about what do we use the Reboa for? Well, it's just to buy time to get the definitive surgical treatment, and if you can't achieve that within 30 minutes or 45 minutes, or perhaps the partial Reboa will allow us a longer time until definitive surgical treatment, then perhaps you shouldn't consider Reboa.
No, the reason I ask, but otherwise we leave it for a later phase. But, I say you have point of injury, let's say you have evacuation, problem field care, then you go to surgical care and you go to evacuation. But I always say, if you go to the initial point of injury, that's stabilized by medics or whatever. But then in the evacuation phase, when you're actually here, if you know the delay to surgeon is 12 hours, then I think it's quite hard to consider it. If you can bring the surgical part forward in any form, or you can do a rendezvous with the surgical team, then you could consider it. But I know, the way we also organize it, if I know that will be a non-survivor, I don't think it's the best option to consider it. But I think you have in theater a surgical team, I think.
Yeah. So that's a decision you have to make based on what you have and what are your transportation time to definitive surgical control. And that will differ in different settings, I think, but that's what you have to consider. How long time is it to definitive surgical
okay, thank you.
control?
Dr. Brenner, any questions?
Let's move on to the next speaker. Thank you, Maria.
Thank you.
Our next speaker is Dr. Jean Moore, who's going to discuss Zone 1 versus Zone 3 Reboa for post-injury shock.
Thank you, Megan. It's great to see you. It's the same fluff about conflicts. Now, one of the unique advantages of this international forum is to make friends outside of your country, one of whom is just the Maria, who just presented her nice talk. And she generously invited me to go to Sweden to join her family on a moose hunt a month ago. And here she is with her husband, father, and son. And she helped her son get his first moose. Well, my talk has been stimulated by the TCCC document suggesting that Zone 1 Reboa be used for remote care in the military. So we attempted to simulate what we could, the best we could, for a so-called dismounted complex blast injury in animals. The typical pattern, as you know, from the Middle East has been multiple amputations, extensive injury to the pelvis with junctional bleeding, and a blast traumatic brain injury. Hemorrhage is the number one cause of death in this situation. And the report by Johnny Morrison of Combat Used showed that, in fact, just as the document indicates, that nearly 90% of these were placed in Zone 1. Well, we had the hypothesis that in this complex injury pattern in which pelvic bleeding was a dominant source of blood loss, that Zone 3 Reboa might provide equivalent survival benefit and attenuate the ischemic insult of the Zone 1. So we created this model in pigs of hemorrhage, tissue injury, and traumatic brain injury. This is the model. We don't have time to go into the details, but these insults were made and we followed them for 6 hours. The traumatic brain injury was a particular challenge. We rented a mobile unit to replicate blast, put these little piggies in there where they protected their body and their eyes, and gave them a 55 psi insult to their brain. We then cut down on their femurs and did open fractures of the femurs with a captive bolt. And then we put them in profound shock. Profound shock, as we discovered, was guided by end-tidal CO2. End-tidal CO2 below 20 was imminent death. So we drove them down to this end-tidal of 20. And in the pigs, we got a base deficit of minus 10. Well, you might say, well, in the humans, minus 10 is nothing. But you got to remember that pigs start out with a plus 10. So this is equivalent to dropping someone to a base deficit of minus 20. Well, these are the results of the cardiovascular response. The red is the Zone 3. Not surprisingly, of course, immediately after the insult, the Zone 1 increased the perfusion. But interestingly, the end-tidal CO2 didn't change much. And that's probably because the Zone 1, of course, reduced oxygen consumption below the balloon. Well, that's interesting. Anyway, whatever that says up there. This is supposed to be neuroprotection. But if you look on the slide to the left is the mean cerebral perfusion pressure. And again, not surprisingly, the Zone 1 enhanced that early, but as you went on, actually, it was reduced. And if you look on the right, perhaps the most important fact was surprising to us is that Zone 1 and Zone 3 had the same reduction in ICP compared to no Reboa in this study. So they had equivalent protection in terms of brain edema. Wow. Anyway, this is, of course, cardiac. And interestingly, and perhaps not surprisingly, Zone 1 had the greatest troponin leak. Zone 3 basically wasn't similar. It was similar to non-occlusion. Creatinine, a similar pattern. You see here at 6 hours that Zone 1 had evidence of an acute kidney injury compared to Zone 3. And then finally, visceral injury, lipase and bilirubin went up more with the Zone 1. Now, surprising to us, and I'm not sure this has ever really been shown at a model like this, there was a reperfusion coagulopathy with the Zone 1. We released that balloon. You can see these are complicated slides, but you can see the R time, angle, mean, and maximum amplitude on the bottom right is a TPA challenge that I mentioned we think is the most sensitive way to look at coagulation with a TPA challenge. There's no question that Zone 1 led to a reperfusion coagulopathy. So we look up and think the blood pressure is great. We put this in Zone 1 and we got a grade 5 liver injury. All of a sudden, we've induced a coagulopathy. Then we couldn't really find clinical data to simulate this, so we went into the aorta database and we chose patients who had what appeared to be severe pelvic injuries, and we would say this would be as best we can to simulate this. And then we had 43 Zone 1, 66 Zone 3. And interestingly, in a Cox proportional hazard, the Zone 1 in a patient with complex pelvic injuries had a risk of mortality of 1.5, again, consistent with our animal data. So in our swine model, the Reboa and 1 and 3 both increased MAP. They both reduced troponin. They both reduced intracranial hypertension. But Reboa 1 increased organ dysfunction and produced a reperfusion coagulopathy. And similarly, if we look at a clinical database, the best we can, it appears that zone 3 is better for complex pelvic injuries. So my conclusion is zone 3 and whole blood. Nothing controversial about that. And I want to thank Chuck Fox in particular. He actually flew out from Baltimore to help us with this model. Thank you for your attention.
Thank you, Dr. Moore. Any questions from the audience?
Yeah, Luke Neff, Wake Forest, great talk. The coagulopathy post-Reboa, I think one of the things I'll just mention that we have seen, and I don't know if y'all have investigated this any further, but just the sheer forces that are at play with complete occlusion versus partial, we're starting to see some pretty significant differences in hyaluronic acid levels and syndicin-1 levels related to glycocalyx shedding. So I know that the endotheliopathy of trauma and blood failure, those are all hot topics. I think, at least in our lab, we're starting to see some of that. And I was curious to know if you or any groups here have started to kind of peel back the layers of what's happening at the endothelial level.
Well, it's complex pathophysiology, and I think you're absolutely right that it's not physiologic to have a scenario where you have no flow. And obviously, that's the goal of the partial Reboa now, is that we don't have periods of no flow. And even shear stress, we don't understand. Of course, you guys are vascular biologists here, but we don't understand the fibrinolytic system. And it probably is a reduction in perfusion, not oxygen, that activates the neurons around the blood vessels and releases TPA. So you're absolutely right. No flow is not a healthy condition for human beings. Yes.
Dr. Moore, I was wondering, zone 2 Reboa has been verboten because of worry of damage to the paravisceral aorta. With the advent of partial occlusion and the pure Reboa, do you think that that opens up zone 2? And should we be thinking about what clinical scenarios that might, in which that might be appropriate?
Well, I think this, of course, this study was configured long before partial Reboa came out. And I think what it does is support the concept of partial Reboa. And I have always favored zone 3, as Chuck can attest to, and everyone, unless they're undergoing CPR. So a patient with a pressure of 70, I'll put a zone 3 in and see if I can get them up to 70, 80 and keep them there. And try to avoid zone 1 if they don't respond. Obviously, put in zone 1. But if you look at our experience in Denver compared to the national database, we use zone 3 a lot more frequently than zone 1. And it's I don't think it's black and white issue, but I am here to say that I think that the data suggests that in the appropriate patient, we should probably try to get away with zone 3 rather than zone 1.
That's certainly evolved to be our practice. We use zone 1 almost exclusively in arrest or peri-arrest patients at this point.
Yeah, certainly they're arrested. You got to get that blown up.
Thank you.
Yes.
So are you guys seeing the decreased ICP as a positive?
The decrease in what, I'm sorry?
ICPs?
Well, this model, unfortunately, is only 6 hours. But I would guess that if we kept these animals for 24 hours, we would see increasing intracranial hypertension and the result from cerebral edema, secondary injury. But clinically, it's difficult to study this, as you know. We don't have ICPs. We don't have data granular enough to see the effect on ICP with various zones and duration of inflation. But I think this suggests that, again, we have to be careful with zone 1 because we can get a reperfusion injury even though we don't create hypertension above the balloon.
Yeah. You know, the reason for the question is hemorrhage, they die, they have a secondary brain insult, and usually these patients with the blunt traumas are going to have, you know, significant brain injury. But if we're seeing decreased ICPs, it's probably just because we've shut off blood to the brain, you know, to allow for the decreased ICP. And how are we finding a balance between that and the hemorrhage? And should we just at least allow partial balloon rather than full balloon occlusion in order to achieve those results?
Well, the balance is always difficult, but I personally think, and without good science, that the target ought to be 100 systolic in patients with a partial until we exclude a brain injury. And then I think we have to be careful not to exceed 100 because if they got a torn aorta, 110 is not healthy for that patient either. So I would argue to strike that balance. I'd shoot for a systolic of 100, and that's what I do to get them over and get a total body CT before we go to the operating room.
So, Gene, this zone 1 and 3 with known injury makes sense, right? So if you know that you only have a pelvic fracture like in your animal model, and in the cases you selected, zone 3 would make sense. Why would you ever go with zone 1? But what if you don't know? Guy comes in, really low blood pressure, belly full of blood. Isn't blowing up a zone 3 when the most common injury is above the aortic bifurcation analogous to putting a tourniquet below the injury versus above the injury?
Well, that would be intuitive, and that would make sense if we didn't recognize that every minute of zone 1 occlusion has its adverse effects. So I think it's a balance. And again, if there is blood in the abdomen and they don't have a head injury, then I shoot for a systolic of 90 and don't exceed that. But I think that affords us the opportunity to go over and get that total body CT before we go up to the operating room, particularly to exclude a major brain injury.
Since 90% of the injuries in the abdomen, the vascular origin is above the aortic bifurcation. If you put a zone 3 up, do you think you're increasing? Let me rephrase the question. Are you increasing blood loss by putting a zone 3 in a patient with intra-abdominal?
Well, as you know, your institute developed the so-called pop the clot and showed in swine models that it was 90.
Mm-hmm.
So I would assume that 90, I'm not going to create a lot of bleeding from the liver or spleen. And those injuries are complex. They aren't just arteries. In fact, most of the coagulopathic bleeding is capillary, not arterial. So I think it's a balance, but my practice again is to have more enthusiasm for zone 3 than zone 1. And again, perhaps the partial Reboa will solve the debate.
One quick question. Dr. Martin was going to throw this out there. The ICP data is really fascinating, I think. Do you think we should, in the absence of hemorrhage, should we even be talking about maybe a zone 3 partial Reboa for treatment of ICPs? And if so, how would we create an experimental model to try and take a look at that further out than 6 hours?
Well, it'd be an interesting concept. Unfortunately, we spent all the DOD money on pigs that we applied actually for a supplemental because we had a number of findings in here we didn't expect, which is the fun thing about research, as everybody knows. You discover things you never dreamed of before. But you're right, it suggests that perhaps that would be appropriate in patients with traumatic brain injury.
All right, thank you very much. We're going to go ahead and do a quick coffee break in the exhibit area and come back here for the next session at 10:15.
Hi, no. It's really just to give people a lot about staying cards. No, that's all right. Yeah, hi, Zach Kassim. Nice to meet you. Great. Oh, great.
She's a
Okay.
retired basketball player. I can say that.
I'm not going to be retired. I'm excited to go half time.
Oh my God. I warned her
Good.
that
I
might
think
happen.
it's smart.
I know. She just set up a task force, the first task force in Israel.
Oh,
So,
great. Okay.
Yes, and we have our date on December 13th.
Oh my gosh. Yeah, it's so exciting.
In January, we're going to do a hosting in Israeli.
Stop it.
Yes,
Oh
going
my
to help
God.
peace through peace. How's
So
that?
you're tackling politics and bleeding.
Oh, I'm not a politician, but
In real life, yes. How are you? Good, good. Do you know Zach? You know
Hi,
Zach,
Zach
right?
Kassim. Nice to meet you.
When were you at Shock Trauma?
I was in 9, 10.
Yeah.
Oh,
so
no,
you were
I was
like,
13, 14.
Yeah, he was right
yeah.
up with that.
Yeah.
Zach is one of the ED docs that does this.
where are you working?
I'm in Philadelphia now.
Oh.
Yeah. So it's close.
EVTM?
Yeah, we have a very active Reboa program that we set up in 2017. So, yeah, me and I have a partner in crime, Jeremy Cannon, who's involved with a lot of the research, and so between the two of us, we keep pushing.
Yeah, you need some ambassadors. I know.
Yeah.
Trying to lately. That's so awesome. And you guys are doing a great job with their little steps. It takes time. It does, but education is key. We're discussing why because they don't have enough, and they just assume, right? Or they'll listen to someone who they like, and then that person says, "Oh, that's I've had you are coming to Abu Dhabi. I'm here in Abu Dhabi in April. Marcelo Rivera is trauma surgeon from Brazil. He's now getting surgery. Because I've already, I can't take that much time off work at once. So I'll come back. I just can't. 2 hours away. No, but I'm already taking days after that. I know. You know what it's like trying to get days off. It's impossible.
It's a challenge.
They're like, well, you can go away this day, this day. I'm like, why the other side of the globe? Well, 8 days should be enough. Oh my God. Okay. So I know that Boris is administrators. Okay. Good. Great. I also have to try to in April, now that Israel has all these I know. You should send people over to come over and teach. Why don't you come teach with me? Okay, invite me. Okay, great, done. I'm coming. Good. April is April 7th, I think. Yeah, that's great. And bring just for this hospital. It doesn't matter. It's running on April 7th. Hospital North. He decided one day that his hospital has to be EVTM put together. Really? No, really, the administrators came. It was amazing. The administrators were so
This is when you see the champions.
Always using Coda or idea. There is not a specific, also in Greece, there is no so we also see that the masters. Coda is
I don't have money. There's not a lot of regulatory stuff. There's no awareness, none whatsoever. So he wants his whole group to learn, but bring people from Israel over.
The University of Bengal, where we're doing this simulation center, the president of the university is a good friend of mine from Pittsburgh.
We'll bring him.
Wait, bring him?
Yes.
He has been to Abu Dhabi and had ties with this guy that's head of regulation of medical programs.
Great.
I can tell you his name. Can I
Tell him and hook him up with Marcelo, yes. Because Marcelo needs help getting the product there. So tell him about that. Yes. Bring them all. Yes.
I can bring them in my pocket.
Yeah, at least invite them. Marcelo. I'm telling you, you literally, as long as people will sit and listen, which is the hardest part, to get them to actually sit and listen, then they'll be like, wait a second, this actually makes sense. But not until they actually sit there and listen are they going to even remotely think about it.
You see cases.
Like real life, exactly. Oh, that's
Like
what
Eric has, they'll talk about, then I had this case where I could have used this.
That's what it happens. That's that light bulb. Yeah, light bulb goes on. They're like, what about that patient that died? But listen, all the time we had an
just hospital use already in 3 cases. No anesthesiologist. So I'm asking, are you going to come and give like talks about it, or it's just for this? I can come and whatever you need to do. No, you can up with that. No, I'm just gonna. But if you want to set up some lectures, let's do that. Yeah, what's the cases that I use? Yeah, let's do that. I have that. You can present that. That's perfect. Awesome. Done. I have to see in case when do I use it? What date is it? It's April 7th. The course itself is April 7th? Yeah. So we'll do that course, and then you can do your lectures to people who want to hear, like, and then you have more incredible, but no, I don't. No, mine are just the old ones that I have to keep leaving you yesterday somebody works with Williams. Yeah, he gave an incredible talk about how it's a resuscitation. Yes, all the nootropic drugs and all that. That was that's awesome. Yeah, they could continue to augment for sure. Oh, that's so cool. Nice meeting you guys. Very nice meeting you. Thanks for co-moderating. Yeah, thank you. Good to see you. So, I will have to set up a flight to come the day before. It's about 2.5 hours flight.
Yeah, I'm gonna hook you up with Marcelo.
Because Dennis is going to become administrator, so we'll have some kind of
Whoever, of course, anyone that wants.
in January with this hospital administrator. So the reason why I decided.
So is it going to meet with? Is it going to meet with
Marcelo?
Yeah.
Have a meeting with Marcelo.
Okay, good. Perfect.
Great. Some kind of cooperation.
Okay,
And also promoting EVTM and all that.
Yes.
And I told him that you were coming in.
Good.
In April, I thought I'd get you over to this one. But Marcelo doesn't know. So I would be.
Do you know Marcelo?
I met the Brazilians here at an hour and but I know Fernando. Simone Fages, right? At gmail.com.
Okay, so then you have his email. Just email him and tell him that you're gonna. I'll tell him that you're coming with me, but that also you're with Boris. And Boris is coming over.
Do you think he would help with?
He will 100%. He's the most collaborative person ever.
Okay, with my number.
No, he was there. He was not even make mine.
Okay.
Even though.
Okay, I just need to know that this guy.
Trust me, I tried.
Okay. I thought he was Abu Dhabi, but
They do.
look, there's this guy Muhammad. He's this administrator there. I tried to get some information. That's what I know. That's great. But I think because he said if I come,
Forward this. Marcelo. No, I'm serious. Forward this to Marcelo.
Yeah, we talk a lot, yeah, write a lot, and it is. But he did say if you want to come, I'll be glad to meet you and just do something like regional
Yes. No, haven't. Yeah, we'll get Marcel.
Is it real that people can connect like that and do good things? It's amazing.
Yes. For EVTM it is.
It
Not
is.
for Symposium.
It is.
Yeah, EVTM. Yeah. That's what we're about.
Just seeing this, there's a lot of it. There's a lot of things that are very chauvinist.
Yes. Right.
Yesterday,
Yeah.
there's some women surgeons yesterday
Yeah.
who spoke. I don't know if you know, it's like this short beret and glasses. There was a group of the women surgeons that work in Cowley, and she came out and talking about.
I know.
It was like very.
I'm glad I wasn't here.
It was, yeah. And Deb Stein, I said, this is hospitals. It's not essential.
No, they're not. They're Sunday. They are Sunday. For my own the more we bring, the more we
They may be sick and need Are you good in California? Good, yes.
Take it, California.
Thank you. Good morning and welcome back. I hope everyone had a good coffee break. We're going to get started again with Reboa, the past and the future. And starting is Dr. Laura Moore. Unless she's getting coffee right now. She's getting coffee? Someone go get her. Yeah. All right, here we go.
Good morning, everyone. And I'm really excited that I got asked to give this talk on the evolution of Reboa. So here we go. These are my disclosures. So 1954, this is the original article written by Colonel Hughes with his experience using what was not called Reboa then, but is what we know as Reboa now, in the Korean War on some military combatants that had massive intra-abdominal hemorrhage. And unfortunately, none of those patients survived, but it was the first proof of concept paper that was written talking about the potential role of an intra-aortic balloon to provide hemodynamic support and temporary hemorrhage control. Now, we'll fast forward to modern day and my personal involvement with the evolution of Reboa. So you'll recognize all three of the people on this slide, but I was in Houston. Holcomb was my boss at the time, and Todd Rasmussen showed up and we had a research day, and I was presenting a bunch of research on sepsis, which is what I was really interested in at the time. And after that meeting, I was asked if I would go to San Antonio to participate in the E-STARS course and be a guinea pig to validate a curriculum that the military was developing to try and train trauma surgeons to do some basic endovascular things for life-saving purposes. And at that course, Dr. Napolitano and Dr. Rasmussen taught me how to do a lot of different things, but one of the things they taught me how to do was Reboa. And the person that I got paired up with at that course as my partner to work on these pigs was Dr. Megan Brenner. So left San Antonio, and within a week, and this was early 2013, Dr. Brenner and I had both put in the first Reboas using the CODA device in trauma patients in Houston and Baltimore. That was followed very quickly. We, between the two of us, amassed 8 cases in just a matter of a couple of months at those 2 institutions, and we published this first paper in the Journal of Trauma, showing that it was not only something we could do and it was feasible, but we had improvements in patient blood pressure. Remember, we didn't have a lot of data on this yet, but we showed that everyone's blood pressure went from, a median of 50 systolic up to 120, and that we could do it fairly quickly even with the 12 French device. We continued our collaboration between Houston and Baltimore, and then in 2014, I presented this paper at the AAST, where we looked at our case series from Houston and Baltimore of Reboa and compared that to patients that underwent resuscitative thoracotomy for the exact same indications, and presented this again at AAST and showed that it appeared not only was Reboa feasible, but it actually had what appeared to be a survival advantage over resuscitative thoracotomy. Looking at the mortality there at the bottom, survival rate for the resuscitative thoracotomy patients was about 10%, but the survival rate for the Reboa cases was closer to 38%. So that all seems great. Wonderful collaboration. We're showing some good data. But as you can imagine, not everyone has been an adopter of Reboa. And even though we've been doing it for almost 10 years, and these are some of the early tweets and debates and things that happen, I would say that the disgust for Reboa continues to persist. Obviously, people in this room are believers in it, but not everyone out there is as in love with Reboa as we are. So I think we still have a lot of work to do to determine the place for Reboa, but I think it's a worthwhile cause to continue. The 12 French sheath was what we used for a while, and again, we had adapted that from the vascular experience that was being used for ruptured AAAs. But then the 7 French ER Reboa came out, and it was a game changer. Wire-free, 7 French. We didn't have to put that giant 7 or that giant 12 French sheath in everybody. It was safe, it was fast, it was easy to use. And so it pretty widely became adopted as the device of choice. That was followed by this DoD-funded multi-center trial, prospective observational study, looking at Reboa catheter use in 6 level 1 trauma centers in the U.S. was published in Annals of Surgery in 2020. And again, all these Reboas were being placed by trauma surgeons. It was fast, it was safe, very few complications. And again, continued our efforts to try to identify the optimal patients for Reboa utilization. We're now down to 4 French. So as the technology continues to evolve, I think we're going to start to see variation in devices, and some of them will be smaller, some of them will have additional features, but this is the most recent FDA-approved Reboa. It's 4 French. Again, wire-free, easy to use, and we'll, I think, continue to see emerging data about the use of this device in a variety of settings. Clinical trials are ongoing. This is one that I'm particularly excited about, looking at pre-hospital Reboa for patients that are in cardiac arrest. It's a randomized trial that's taking place over in Europe, enrolling 200 patients to see if the addition of Reboa to patients that are undergoing ACLS for cardiac arrest can improve the achievement of ROSC. And device evolution, I think this is really exciting, to think that we've gone in 10 years from the big 12 French CODA device to all of these different devices that are varying sizes and varying capabilities. Some are automated, some can provide partial Reboa. But all of these things, I think, are advances in technology and will, again, continue to improve the delivery of care for our patients. We still have a lot of work to do. Like I said, not everyone's a fan of Reboa. We know that. So we still need to work on optimal candidates, not just in the world of the trauma patient, but other applications that I think we're going to hear a little bit more about later. But what's the role of Reboa for cardiac arrest? What's the role of Reboa in postpartum hemorrhage? What's the role of Reboa in the pre-hospital setting? We still don't know who the optimal trauma patients are to select for Reboa. And it's going to be difficult, I think, to get some of this data, but it's up to us to try to figure these questions out. What are the things we can do to prolong inflation times? Is it partial occlusion? Is it intermittent occlusion? Is it infusing things through the device itself to help minimize the effects of the distal ischemia? And again, what are the other applications outside of the trauma patient that might potentially benefit from this endovascular device? So with that, I will close and ask the very simple question of which one would you rather have? I know which one I would pick, and I will open it up for questions.
Thank you. Dr. Moore, you described the evolution of Reboa as almost a conceptual one, where it started as, it's like a clamp, but from the inside, to something that's becoming more subtle. Do you think that there is a physiological difference that we're seeing in the effects of partial Reboa, especially after hearing the data from Wake Forest, that is more than simply we're reducing flow by reducing the cross-sectional area?
Yeah, I think, the simple thing is you think of it as the internal tourniquet or whatever that supports perfusion. But I think there's so much we still don't know about Reboa, and I think a lot of the data that we've relied upon has been clinically generated from, high volume centers. But I think the emerging basic science literature is going to be really important. Like Dr. Morse talked just now about the coagulopathy that he saw in the swine model. So I think we need to continue our, collaboration with our basic science colleagues and we have a lot to learn about the impact of these different strategies for how we deploy Reboa.
Thank you. Other questions?
Really nice talk, Laura. When we were clamping aortas after doing EC thoracotomy, we never left the operating room without getting the clamp off. Because if you took them to the ICU with the clamp on, it was guaranteed there was going to be a death. I don't see any guidelines about the length of time that you leave Reboa fully inflated. And I'm aware of cases around the country where the balloon time has been excessive. And I'm afraid you need to clarify for all the young people doing this around the country that this is an aortic clamp.
Yes.
It causes all sorts of havoc beyond, as we knew when we were clamping. And you need to have some guidelines, like anesthesia needs to get caught up, and then you deflate the balloon, and then you close the abdomen, et cetera. So I'm mystified about these prolonged times.
Yeah, I agree. And I think, one of the things that happened in Houston when we started doing this is, when you do a resuscitative thoracotomy and you roll into the operating room with a clamp on, everybody can see that. And when we started using Reboa, there's a little catheter in their groin with a balloon, and it's not obvious to everyone what that means. So a lot of what we had to do was educate our anesthesiologist about, we have a clamp on the aorta. It's endovascular clamp, but it's a clamp, the aorta is occluded. In terms of time, I think we don't have the answer. I think we all believe that minimizing the duration of inflation is really important. I know my own personal practice, we keep track of those times, but it's not like you say it's 60 minutes, the balloon's coming down, and if they die, they die. I think there's some nuance and finesse to doing it. Just like when you take the aortic clamp off, we didn't just fully release it. One click, worn anesthesia. So I agree, though. I think a guideline would be helpful if we could create it. I think the general rule that most people accept is 30 minutes in zone 1 and 60 minutes in zone 3, but certainly people have done it for longer than that. So I think general rules are okay, but we probably could do a better job, I agree, of putting that into a guideline.
Baltimore, with the advent of the P-Reboa Pro and the ability to maintain distal perfusion and avoid the reperfusion injury after potential prolonged clamping times, doesn't that sort of push back the boundaries for us and say, well, it's really difficult to figure out when that cutoff time is, because physiologically we're able to monitor the patient the entire time and say there doesn't seem to be any consequence to this. The patient might still be losing some blood, but we've achieved some sort of homeostasis between bleeding and perfusion.
Right. And I think even before the P-Reboa Pro was available, those of us that did a lot of this, it's not like we left it fully occluded the whole time. We would deflate it a little bit when we went to the OR, see what was bleeding, maybe have to reinflate and deflate a few times. So it was never, I don't think anyone really that used it a lot just kept it inflated the whole time and didn't, ever let it down. But describing that and putting that into a formalized guideline, I think is extremely difficult because there's a lot of nuance to how you use it.
All right. Thank you, Dr.
Thank
Moore.
you.
All right. Next, we have Ryan Lawless speaking about his initial experience with, speaking of partial Reboa, P-Reboa.
Good morning. Thank you, Dr. Kundi and Dr. Fox, for inviting me to talk about our initial experience with the P-Reboa Pro in the Center of Excellence, and I'll touch a little bit upon that. I have no disclosures. So over the next 6 minutes or so, we're going to talk about the benefits and features of the P-Reboa Pro. I'm not going to go into too much about it. You guys can go over to the booth and see it for yourselves, and they can tell you way more about it than I can. But I'll talk more about the Center of Excellence model and what we're doing to gain the data that was just talked about, the Reboa patient selection guidelines between all of the centers, this idea of breaking that 30-minute barrier that Dr. Feliciano is going to eat me alive about when I start talking about it, but a little bit about the observed benefits and some of the data from the aorta registry as to what everything is looking like and how we can move forward, and then some of the lessons learned that we've learned kind of to date. So we've all been in the operating room. We've all had a clamp on the aorta. We know that when we're in the supraceliac position, we really need to get that down below the renals. Same idea with the Reboa, right? The Reboa's up in, we got a clamp on, sickest patient in the hospital. We really need to move that clamp down. What limits that? Continued hypotension, reperfusion injury. So for the Center of Excellence model, there are 7 alpha centers and 7 beta centers. Now you're either an alpha or beta based on when you came in, not are you high powered or are you the secondary, but it was really on how you came into the Center of Excellence in as far as timing. This is a peer-to-peer collaborative network, meaning every month we get together, we talk about cases, we learn from each other. We're learning the ins and outs of the partial Reboa, the complications that we're seeing at every center, but also the hurdles that you're seeing to get your program implemented. So how can we learn from our peers at different places across the country of what's working for you, and can we put that in at our place? We're refining our training programs. The company itself is listening into these calls, so they're refining some of their support programs as well. And all of these centers contribute to the aorta database so that we're able to look at these in a retrospective fashion, at least through that database itself. The P-Reboa Pro was intentionally designed for partial Reboa. And what we know from the aorta database is that the overwhelming majority of ER Reboa cases were for complete occlusion. You can see it's almost 90%. There's some reports of intermittent occlusion, some reports of partial, and whether you're a believer that the ER can achieve partial occlusion or not would kind of based on whether you called it an intermittent or a partial. From the Centers of Excellence, this has completely changed. 3/4 of those balloons that have been placed so far have been used in some sort of partial fashion, whether it was partial for the whole time, or whether it was complete to partial or partial to complete or back and forth. And if you come to the lunch session, we'll talk about a couple of cases in which we've done exactly that. The majority or overwhelming majority of these catheters have been placed in the trauma bay, and what the surgeons or the end users have actually said has been a guiding principle for them is that central aortic pressure. So that ability to monitor the central aortic pressure above the balloon has allowed us to slowly titrate that partial Reboa up to achieve that goal systolic between 90 and 110. Dr. Moore was talking about the different ranges that we would use in Denver as far as what we're targeting in patients that potentially have TBI versus do they have other injuries, so that we don't create a hypertensive situation, that we really maintain that blood pressure. And on that side port of that 7 French sheath, there's a second arterial line that's hooked up, so we know that we're partial. Now, admittedly, I actually don't care what the pressure is below the balloon, but it really is nice for me to know that I do have some sort of flow below the balloon, and I know that I'm partial. Rather than try to feel for the pulse, I see that waveform on that secondary arterial line, and I know I have flow below it. The 14 centers, and this is some of them here, this will be published in SACO soon. This was our original 7 centers coming together and saying, well, how are we going to do this? How do we want to put Reboa into patients? Who are those patients that we're going to select? We started with, as Dr. Moore talked about, early access, and every center had kind of some idea of who was going to be their person to put early access in, and this turned out to be the patient that came in some sort of trauma, penetrating or blunt, with a systolic blood pressure less than 90. Common femoral access was achieved, and it depended on where you were in the country, whether it was a 4, 5, or a 7 French catheter. From there, we identified the patients we thought would benefit from a Reboa, and those were that had the central access in and that continued to be hypotensive, defined by a blood pressure less than 90, despite resuscitation. So you're transient or non-responder. There were 243 partial Reboa Pro catheters that were used, and this is end user data. This is we talked to the surgeons afterwards, or we all filled out a case report form that had what we thought the benefits were of using the partial Reboa. And the majority, and these have actually changed over time. We've seen some evolution of these since the beginning, but at least the top 3 are the surgeon thought that it extended the safe occlusion time for them, whether it was in zone 1 or zone 3. That was the most commonly reported benefit. It improved the transition to occlusion, meaning that slow inflow up to achieve your blood pressure, or to reperfusion, the slow titration down in order to restore flow below. It wasn't I took 1 click off or 2 clicks off the clamp and got hypotensive. It was really taking out half a cc or 1 cc of fluid. And a perceived reduced blood use. Now again, end user data, not patient data. To look at the aorta database, this was actually very interesting to us. So with the ER Reboa, there was the majority, at least that I was taught, the balloons were placed in zone 3. With the partial Reboa, we're seeing a stark increase over the last 7 quarters of placement initially in zone 1. And you can see that the distributions of zone 1 occlusions there, greater than 50% of those are exceeding that 30-minute barrier. And some of them, there are some reports out to 2, 3, and I believe there's one that's close to 4 hours. Now, that gives me still a little bit of chest pain as I say that we're leaving a clamp on above the renals or above the celiac for that long. But if we go further into the aorta database and pull out the P Reboa Pros that are in there versus the ER Reboas, there's no difference in who we're putting it in, but the difference is in the duration of time. So there's a longer duration of occlusion time with the P Reboa Pro, and we see an improvement, or at least a decrease in the amount of ischemia that we're seeing. So we see a decrease in the peak lactate levels between the partial Reboa and the ER Reboa. And if you break it down further, there's a decrease, not only a decrease in overall, but there's a decrease in those that are in zone 1 and a decrease of those in zone 3, and an improvement in acute kidney injury that's seen in those that survive greater than 24 hours. There's no difference in access site complications, no difference in 24-hour survival, and no difference in survival to discharge. This is a big deal. This says that we might be safe in order to put that balloon up in zone 1 and leave it up there past that 30-minute barrier. So now that we have extra time, what are we doing with this? We've seen an increase in the amount of imaging that has been done. And the imaging is for either, quote, endovascular hemorrhage control, or to, quote, optimize surgical planning. We talk about this every month, and we see that these balloons are, at least in the surgeon's eyes, helping them identify where this patient is supposed to go. Is it pelvic embolization? Are we keeping them out of the operating room for that? In a positive fast, in a responder, a potential embolization versus optimizing your surgical approach to go right after it. And also in patients in neurogenic shock or severe traumatic brain injury, preventing somebody going in for a negative exploratory laparotomy by getting them to the CT scanner with a balloon in. Some of the lessons learned in a place or a time when time is of the essence, or time is our enemy, P Reboa Pro, it seems to be adding back a little bit of time. We have identified that the central aortic pressure monitoring has been very important to the surgeons that are using it, as they're using that as the guide to how they're inflating the balloon and deflating the balloon. And what we've all started to do is implement guidelines. There was a talk about this a little bit earlier. Early common femoral artery access, I went over those. Arterial lines to monitor blood pressure above and below the balloon. But the big one that got brought up earlier was this idea of sheath management. The case is not over until the sheath is out. Balloon is out, but the sheath is still in. When do you get it out? And the best ways, I think, is to get a guideline in or use technology to your advantage. Get something in the computer that nags nursing, that nags residents, that nags the attendings to go in and get that catheter out. And now we have some clinical data that shows that P-Reboa Pro reduces the ischemia and reperfusion injury despite longer occlusion times compared to the ER Reboa catheter. So again, I thank you all for the privilege of the podium presenting some of this data, and I'll take any questions. Fire away.
Listening carefully to what you said, but still not quite understanding what we're doing with the extra time, right? So with the old catheter, it's you hit a stopwatch and you're running to the next thing to get the balloon down. So now you're talking about 2 and 3, I think you even said 4 hours of partial occlusion. Like I heard you say that a lot of this is about the CAT scan and getting to IR, but I don't understand what we're doing beyond an hour. So, I mean, you have these reports, so what is it?
Sure. So some of it is it's being used in the operating room. So as Dr. Moore stated earlier, put betadine on the catheter, bring it into the field, and we're regulating the Reboa catheter as we're doing our thoracotomy or our laparotomy or packing the pelvis or waiting or having orthopedics put the frame on. So augmenting our blood pressure in order to achieve the surgical control of the bleeding. Other things we've used it for is to get us through that perceived time frame of where we're debating between hemodynamic instability from hemorrhage versus neurogenic shock. I've taken patients to the operating room or to the CAT scanner with the balloon in zone 1, resuscitated, got it to 3, found out that they had a bad thoracic injury and be able to take the balloon down, knowing that now I could start the pressors, not wanting to start the pressors and hemorrhagic shock. So giving us the time to plan where the right place to go. Now, just because we go to the operating room doesn't mean I take the balloon down. I might move it to zone 3 but still use that to augment my blood pressure while we're getting surgical control. So that's what I think is happening afterwards. It's giving us a surgical planning time, getting to the getting to the CT scanner, but then also allowing us to maintain perfusion to brain, heart, kidneys while we're getting control of the bleeding.
Yeah, I'm also just wondering because of these longer times. So you have sicker patients that are living because they have a Reboa in, but they're just like, you talked about the clicks on the aortic cross clamp. And when you undo those clicks, the heart is really unhappy. So it's the same thing. Maybe these very sick patients now that you have a shock myocardium, and there was a whole bunch of discussion of this yesterday. You're getting resistance support, which has to come off slowly. So is it that also?
Yeah, and the way that I've been augmenting the fluid in the balloon is the company recommends using a 30 cc balloon to pull out the fluid. I don't do that. I put that on the back table. I put a 10 cc balloon on, and when I'm removing or putting more fluid in the balloon, I'm going in half cc increments. And I've noticed that as I'm resuscitating a patient, they'll become partial on their own, right? Blood volume goes back up, aorta's not as clamped down, you go on to partial. And so as I'm coming down on that balloon, I'm taking half a cc out, and I'm starting to see an inflection point where I get a real response that goes from 110 to 80 when I take a half a cc out. So that half cc goes back in, resuscitate a little more, take that out as well.
Thank you.
Ryan, do we have any information on what proportion of partial Reboa patients have the balloon in after definitive surgical control of bleeding as a measure of continued resuscitation postoperatively? How many patients are going to the unit and coming down slowly as they're getting resuscitated after the OR?
That's a good question. And on our current observational trial where we're talking about this, we haven't talked about or haven't asked that question of, is the balloon in still after surgical control? It's a good thought, right? I mean, you're no longer bleeding. Why do you need to have the balloon in the aorta anymore? And are you taking that patient back to the ICU? We have a couple cases that we've discussed about going back to the ICU and weaning that balloon off. I've taken patients from the CT scanner to the ICU with neurogenic shock and weaned that balloon off. And taken people out of the operating room to the ICU and wean the balloon. Haven't had a good outcome taking somebody from the operating room to the ICU to take that balloon down. Others have, and I believe Dr. Duchesne presented a couple cases at the COE meetings, but we don't have accumulated data to say that that's the way to go.
Is it your practice to go to full occlusion and then titrate down, or to titrate up?
I titrate up. So I'm titrating up to my desired blood pressure. I don't want to overshoot and then come back down. And I found that to be different from how I was using the ER Reboa. So with the partial, I slowly inflate in zone 1, maybe up to 8 cc's, maybe a little more if I need to. But a slow inflation allows you to watch that blood pressure go up with it. And that's why we're really relying, and I'm speaking for the whole COE now when we talk about this, that we're relying on that central aortic pressure to really guide that.
Any other questions? Yes.
Just discuss a little bit about kind of balloon management in the prolonged occlusion setting, because my personal experience is that when the balloon is up for 30 minutes, it's pretty easy to assign the resident the task of making sure the balloon doesn't migrate. But then when you're talking about 30 or 3 hours and you're in the OR and you're in IR, balloon migration definitely happens. I personally have had an aortic intimal injury, which I'm pretty sure is a result of that. And is that something that you're seeing?
Thank you. Have not seen aortic intimal injuries, or at least that we've talked about on the COE calls. And hopefully some of the data as it gets more populated in the aorta registry will kind of ferret that out a little bit. Balloon management, to keep it in the same space, I try to sew it in, but it's hard to sew in, right? Using the what comes in the pack is that same kind of clamp that comes on for the central catheter or the triple lumens, and so we can put that around. I found that to hold a little bit. Silk tape. Your medical student hold this.
To that, which was challenging if you're in the middle of your XLAP, then the balloon migrates, and if it migrates into your visceral segment, that potentially creates some really significant problems.
You're absolutely correct. I've been fortunate enough to always be at a place where I've had somebody to be able to put their hand on it, and it delegated that job. And I know that's not an option everywhere, but I've been lucky.
Thanks for your talk. Exciting times, right? The question, my comment and my question refers to the data, the quality of the data. So in 2015, Reboa was the laparoscopic cholecystectomy of the 80s. We didn't collect the right data, but we used it anyway. Now we have a new device, partial Reboa, and if we don't collect the right data, we are going to miss that opportunity again. Did I understand correctly that the data of the centers of excellence is being collected, the clinical data is being collected in the aorta database?
All of the centers are involved in aorta. So yes, all of those Reboas have been going into the aorta database.
Okay, so I have the privilege to have Megan as my partner for the last 5 years, and we've looked at the aorta data set in any way possible, and the data is not great. There's a lot of missing data. People don't collect what they need to collect, and the database was not planned for the future. So there's a lot of missing variables there that just are not part of it. Isn't it time for us to put out a definition, a data dictionary, and a minimal data set that's mandatory for every research that's going to be done with Reboa? And this is the opportunity with partial Reboa, because if we miss this opportunity, the data is as good as what you put in, and what we are putting in is not great.
Dr. Coimbra, thank you. I feel like you're leading me down the pathway that for the Center of Excellence. And so one of the things in the Center of Excellence next is to really get that patient-centered data. That's what we need. And we need smart people to come up with, as you said, the data dictionary in the set, and we need to do it in a prospective, well thought out fashion. I don't know, and you got to forgive me, I am not the researcher of the rest of the people in this room, but I don't know if there is equipoise to do a randomized study. But to do a prospective study, I think we're primed to do that and collect patient-centered data, and I believe that's coming down the pike. I'm not that person to do the randomized one. Dr. Holcomb.
Yeah, so there is a randomized study that's just completed in the UK, prospective randomized, led by Jan Janssen. Bayesian, blah, 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 all the stuff, right? We all await the results. Should be pretty interesting. So it can be done. It has been done, and the results are being tabulated right now. And hopefully, I don't know, do we know anybody at the Journal of Trauma that might want to publish that paper?
Be glad to.
All right. Thank you, Ryan. Next, we have Dr. Holcomb.
Okay, state of the science, animal studies. I do have some disclosures. The one that's applicable here is we have a DARPA grant on smart hemorrhage control and resuscitation at the point of injury. So big issues. We've all heard this over and over and over this morning, actually. It had been interesting to share our slides because we're all saying the same thing. Common femoral access, early, smaller is better. Automated. People are working on automated common femoral access with ultrasound and little machines and that kind of thing. Certainly that would facilitate non-trauma center deployment and then transfer and pre-hospital by EMS. So common femoral access is a big deal. Use of non-trauma cardiac arrest by emergency medicine. There's a little people want to hold on to this technology, not share it with everybody else. Cardiac arrest is a big deal. It's 100 to 1 at least for trauma applications, and it would certainly ensure familiarity for the use in the trauma patient and kind of just kit flow right through the hospital. So you wouldn't be doing something 5 times a year. You'd be doing it 100 times a year at many hospitals. The automated controller for most partial Reboa is still difficult. We've heard some comments today about distal migration. How do you do it? Where do you put it up to? Automated controllers are a big deal. A lot of ongoing work there. And of course, then partial Reboa, which is what I'm going to focus on the next several slides, needs to be easy, needs to be effective and safe for at least 4 hours, if not longer, some period of time, both for military and civilian requirements. Marty Schreiber's group published in 2020, and it's a study done in 2018, major limitation of Reboas below the balloon ischemia reperfusion. Everybody knows exactly the same thing. Now, this is with the older ER Reboa, and you can see the difference between the unilobe and the bilobe. And what they showed is with both of those, these are all in animals now, all in animals, as they were achieved 4-hour survival, the map below the balloon was 40, which seems to balance, right? And they had holes in the aorta below the balloon. So it seemed to balance, not causing rebleeding with enough flow to keep the animals alive and not be dead below the balloon for 4 hours. Although the adjustments with one balloon were very different than the other, and they were in as opposed to 0.5 mils, as we just heard Ryan talk about, these are in 0.1 mil adjustments. And almost exactly the same physiology between the two groups. And then White published this year in JSR, a new generation, the P-Reboa Pro, with kind of the, I don't know, would somebody call it a prune shape, right? Is that what you call this, a prune shape thing? Prune balloon, hard to say, incorporating a pressure-regulated, semi-compliant balloon design to allow for precise control. And this was in this animal study out to 90 minutes of partial Reboa without any technical complications. This study from the other group, the Cobra OS, talked about compliant balloon and balloon design, allowing a cushioning effect and titration control on deflation, both in vitro and in vivo, with a nice little model of I think, cow aortas that they cut out and were able to look at. Anyway, it was nice. They said designed to have safe overinflation ability, but also control partial Reboa as well. And then the Williams and these guys that we've heard at this meeting talked about the severe ischemia reperfusion injury. And then they've put together a pretty sophisticated group in the lab of EPAC, endovascular perfusion augmentation for critical care, where they've kind of combined vasopressors, crystalloid, which is a horrible thing, by the way, and should be used in blood for the treatment of post-Reboa ischemia reperfusion injury. And this is now that controller concept, if you will, both for balloon and also for things that are going in and monitoring many different aspects from a critical care point of view of not just the balloon, right? Not just this technical balloon catheter, but the entire organism, if you will, with syringe pump, multi-channel pulsatile pump, and then a peristaltic pump for blood transfusion and crystalloid. So this has actually been mentioned here, and I would recommend everybody go read this paper by Ellie Rabar. She's a senior author in Frontiers, came out just a couple months ago, developing a computational fluid dynamic model. So we've all kind of focused on the technique and the technical aspects. Ellie has really put together, taken data from these animal studies, and then because she is basically a mathematician who has spilled over into the biologic world, has looked at these areas of stagnation with full and partial Reboa that are around and below the balloon. And you can imagine this, and looked at the shear levels because she's a vascular mathematician biologist, and looked at the severe, these are right out of the paper, and this is what was mentioned earlier, severe physiologic consequences, platelet activation, disruption and shedding of the endothelial glycocalyx at very high rates and even denuding the endothelium. This is much more pronounced with total occlusion and less so with partial occlusion. And Jean probably explained some of the coagulation findings that you saw in your study. Ellie's paper is really good. And in my review of the literature is the first time I've seen a mathematician kind of get involved with a group of surgeons to understand what's going on at the endothelial level. And then because now there are a lot of studies out here, Kinslow last year published a systematic review of all the animal studies, kind of did a meta-analysis and came up with the stunning conclusion that there's a fine balance between desired proximal arterial pressures and pressures and or flow below the balloon. So in summary, there's multiple devices today, like Laura showed in her talk, balloons, catheters, controllers. All clinicians, funders, and companies are now recognize the need for prolonged partial Reboa of some kind. Animal effectiveness, how does that translate into clinical effectiveness? Safety, I need to put safety in there. Safety and effectiveness of the devices. And then kind of as Ellie showed, that just because you put a catheter into the body and blow it up and down, there's a lot of other stuff going on at the endothelial level, a lot of biology going on, much more complicated than just how much volume do you put it into the balloon and how long do you leave it in. Thank you very much. I appreciate it.
Thank you, Dr. Holcomb. Just as the coda was used initially for total occlusion, Gore, their modeling balloon is actually trilobed. Do you know of any clinical use for that in the past to model the partial occlusion?
You know, I don't. I think this idea of partial really comes in where we balance prolonged balloon inflation times in the face of hemorrhagic shock. I think the partial Reboa concept is really going to be, has been, and will continue to be developed and refined by this group more than the other. And as I said, in combination with funders, you know, to Rao's point, we need better, high quality data. There's no question about it. That's going to require funding. The device companies are all getting kind of engaged, and there's a lot of activity in that area. Competition's good, right? It's the United States of America. Competition's good, and Canada, by the way. Sorry about that. And Norway. That's kind of a faux pas, wasn't it? But yeah, competition's good, but keeping the focus centered on the patient. Ryan, you said these words: patient-focused outcome, right? We get kind of caught up in the technical details, but it's how the patient does that's really remains focused for the group.
Thank you, sir. Other questions?
So thanks for your talk. There was a discussion online in one of the European trauma journals about whether we should be inflating, deflating every 5-10 minutes, whatever it may be, in order to mitigate the endothelial damage from reactive oxygen species. Any thoughts on that? And
you know, I think it's a question of what's intermittent Reboa versus partial.
Mm-hmm.
I think that the studies that are from Jean's lab with, showing those TEG values and that rebound coagulopathy, Ellie's work with the computational biology, creating models now that you can then potentially, what if you could take Ellie's model? I haven't had a chance to talk to her about it. She's really good, by the way, for those guys who work with her at Wake. But what if we went to Dr. Rabar and said, look, you did it with this technique, but now you have this massive data that you can simulate what might happen with a different balloon geometry, with a different inflation deflation technique. I think those kind of things are possible. Much like if, you know, they don't design airplanes anymore by putting metal together, right? They do it on a computer because they have so much data, understand how things work. I think that's kind of the future in this area.
Thanks.
Any further questions? No? Thank you, sir. Next, we have your friend and mine, Johnny Morrison, talking about Reboa and brain perfusion. What does the animal data tell us?
Good morning. Thank you very much for the opportunity to come and talk. It's a well put together program that lets me follow on from Dr. Holcomb with something of a similar theme where we expand upon the animal data and talk a little bit about the specifics of brain perfusion. Trauma surgeons are often confronted with the issue of balancing hemorrhagic shock and the circulatory consequences of that, where our predominant therapeutic modality is permissive hypotension, in that you are allowing your circulation a little bit of hypotension in order to preserve the formation of blood clotting. You're trying to deliberately avoid some of the harming agents like crystalloid and what have you, that can give you dilutional coagulopathy and make things worse. So often you're prepared to tolerate a lower blood pressure, and there's certainly good data to suggest that that improves outcome in certain injury complexes. The problem comes when you've got an organ which is largely dependent upon perfusion, specifically the brain. That's the thing on the right. It was a little bit of a bargain basement cartoon store that I bought my graphics from this morning, so apologies. And balancing hemorrhagic shock with the needs of the brain, where we know that periods of hypotension have real adverse consequences, is something that comes with a world of importance. So is Reboa the holy grail that allows us to balance those things? You're aware with the world of full Reboa that you're balancing really hemostasis and support against distal perfusion, where we know that your distal perfusion is cut off, and that's often injurious, certainly in a kind of multi-organ failure, reperfusion injury kind of context. We know that often with no balloon occlusion, with uncontrolled hemorrhagic shock, patients fare poorly in that circumstance as well, especially with a brain injury. And the question is, does partial occlusion land us somewhere in the middle that allows us to titrate that? And that's been a source of kind of great exploration. And there's a number of groups that have been looking at that. So my job here is to give you a little bit of a taste of the literature around animal data and brain perfusion. The first study I'm going to talk about is this group from Michigan that published in the Journal of Trauma in 2019. And they strike a note of caution. They present 3 groups of swine undergoing hemorrhagic shock, 2 with traumatic brain injury, and 2 with partial occlusion. And what they found is that the brain injury lesion size remains consistent in the groups with a traumatic brain injury. However, the survival that we observe with those patients undergoing Reboa and traumatic brain injury is worse than compared with the other groups. Now, to my mind, this is, number one, this is really interesting data. It's important to have an outcome to measure. And this group should be congratulated on having a brain injury model and looking at the kind of histology of this, which is something that we're going to talk about a little bit more in due course. But their note of caution was struck in relation to the survival of animals undergoing traumatic brain injury, hemorrhagic shock, and partial Reboa. My concern is that what about survival bias? Is that your patients have to survive long enough to actually undergo partial occlusion, and it's all well and good discussing the reperfusion injury, but if your patient dies of exsanguination, then it's unclear quite how this clinically translates, but we can talk a little bit more about that. There is just been a paper come out in Surgery back in 2021. A couple of the authors, I think, are in the audience. And they've extended the issue of brain injury to a swine model of dismounted complex blast injury. So they are one of the few groups that have added blast into this. And crucially, these authors have demonstrated that you have a superior profile of cerebral perfusion pressure in the setting of a brain injury. And that's something that we believe is beneficial to the brain, in that this group down at the bottom, which is the no intervention group, is the group, to my mind, that sustains the most injurious brain injury, and your raised perfusion pressure is crucial. So the question, to my mind, that comes from this work is, does brain perfusion translate to actual, or does cerebral perfusion pressure translate to actual brain perfusion? And this leads us to some of the work that we've been doing at the University of Maryland. This is a technique that we developed in my lab when it was here at Shock Trauma, where we looked at an intra-arterial injection of contrast to develop a method of measuring cerebral blood flow directly. So unlike using surrogates such as cerebral perfusion pressure, actively measuring the transit of contrast through the parenchyma. And since then, we've been able to take this to a swine model of raised intracranial pressure, where we raise the animal's intracranial pressure, we subject them to a controlled hemorrhage, and then we measure their brain perfusion using our CT perfusion protocol. And what was kind of interesting was down here at the bottom left, we were able to maintain our peak intracranial pressure. So our model is realistic, and that we are able to achieve raised intracranial pressure. And that's actually harder than you might imagine. This is cerebral perfusion pressure. So kind of building on Dr. Fox and Dr. Moore's work from the earlier paper, where you can see that you've got a stepwise improvement in cerebral perfusion pressure during REBOA, be it partial REBOA or full REBOA. Where it gets interesting is looking at cerebral blood flow. And curiously, right slap bang in the middle, we have our partial occlusion group. And what's interesting is there doesn't appear to be a correlation between cerebral perfusion pressure compared to cerebral blood flow. So the actual blood flow in the end of the organ, that's my time to wrap it up. So crucially, one of the things I think that's important is translating your endpoint. So does the animal data help? Well, I think it does kind of. It leaves us, as with a lot of these things, it leaves us with more questions than we have answers. It certainly confirms that REBOA does raise pressure in terms of pressure of blood going into the brain. However, the perfusion question is a little bit more complex. I think that there are a couple of things. There's the acute perfusion and the loss of autoregulation, which is kind of not exclusively, but largely a hydraulic effect. But then you also have issues of autoregulatory dysfunction once you bring the balloon down. And that's certainly something that we noticed in our study. The reperfusion injury is a real big deal, not just for the rest of the circulation, but also for the brain. And I'm convinced that there is a kind of sick brain syndrome from REBOA reperfusion. And what you measure is important. I'll take any questions. Thank you. All right, fella. I'll see you later.
Really interesting talk. Why do you think it is that the cerebral perfusion flow does not correlate with cerebral perfusion pressure?
Great question. So we've pondered that a lot. So I think the other piece is with our cerebral perfusion protocol, you're able to generate a whole bunch of metrics, including cerebral blood volume and mean transit time. So what we find is that if you're in a kind of, if you're in that zone of autoregulation, then your cerebral perfusion pressure correlates very well with your cerebral blood flow. When you're at the extremes of either end, that's where it goes awry. And you can be in the situation where you're on pressors, noradrenaline is a good example. You kind of really tighten up your total peripheral resistance, and you can have a great pressure, but you've got next to no flow. So all of that dysfunction appears to occur at kind of either end of your autoregulatory spectrum. In this case, it's very much at the lower end. So I think a lot of it relates to, dysfunction of your capillaries at the kind of extremes of physiology.
I kind of thought that it was the other way around, that the compensatory mechanism allowed for constant or a relatively constant flow over a broader range of pressures. But then at the extremes, you have higher pressure, you have more flow, too much flow, and at lower pressures, you have too little flow. But you're kind of saying a little bit, it sounds like the opposite.
So all of this is in the context of health. For these animals, we were raising intracranial pressure, and I don't know if by virtue of doing a Burhole, all of our instrumentation plus the Fogarty, that all of that has led, has precipitated dysfunction of autoregulation, before we've even got to the point of initiating hemorrhage. So I don't know how much of this relates to the brain injury in the actual process. But yeah, we were kind of guided by that kind of, all of that kind of initial autoregulatory work that we thought we would find a kind of static plateau of blood flow. But we found that results were very different. It's a little bit hard to explain where all of that comes from. When you look at the cerebral blood volume, which to my mind is a measure of vasodilation, you start to see that you also vasodilate as well. So I don't know if there's some stagnation of blood as it travels through, that relates to injury from the instrumentation or general anesthetic or any of those features. So there's certainly a lot more to this to unravel. It's unclear.
Johnny, were you able to see any regional differences in cerebral perfusion, whether that's anatomic or around the lesion?
So the pig brain is difficult to work with in that it's kind of the size of your fist and it's in a really thick skull. So our scanner was a 16 slice CT scanner, so we weren't really able to. We were able to use it as a global measure of perfusion, but not drill down on region specific stuff.
Right.
Hey, John, good to see you.
Hey, Ryan.
Just for the sake of discussion, did you measure ICPs in these pigs? Just based on our last one, and what happened with that? And then just to tag on to Rishi's question is, if these pigs did have brain injury, induced brain injury, was there larger blood pooling or blood injury in those areas?
Well, sorry, I missed the last part.
If there were induced brain injuries in these pigs, I don't know if you did that. Was there more of a bleeding risk when you were?
So we raised intracranial pressure. So we were artificially playing with intracranial pressure, and then we actually used a Fogarty balloon. We tried every which way possible to try and get a realistic measure, a realistic way of raising intracranial pressure. And in swine, that's actually a really difficult thing to do purely by injury. So we used a Fogarty balloon put through under CT guidance and then inflated, and that within the confines of the skull raised pressure. So a lot of this was kind of a hydraulic effect. However, by virtue of raising intracranial pressure, you then induce a kind of global cerebral insult. So from that point of view, we were, I have the, if I can go back, I have the ICP figure. Not to worry. I have the ICP figure, which was all elevated successfully in those animals. And it's kind of interesting how that wanes with changes in volume and how that changed with ventilatory status and all of these things. What was your last question?
It was just with these patients. So the physiology, and again, it's just for discussion purposes because I'm interested in it, is, they've got a vasodilatory phase. You're now increasing the amount of volume in the brain. A lot of our patients that we're going to be deploying Reboa in are going to be blunt injuries with brain injuries. So it's what are we doing to the ICPs? Are we actually further injuring these patients?
Okay, got it. I see. Well, it's interesting. The amount of volume that you give intravascularly really plays a huge role in terms of their intracranial pressures later on. So once we had finished our kind of intervention phase, we brought down the Fogarty, so removed the space occupying lesion. Their ICPs were largely on the lower side, but a lot of that was volume dependent. The other pieces there are in our lab, volume limitations. You eventually run out of blood, where in a human patient you often have a lot more resources. But yeah, we didn't have a huge problem with persistently or refractory raised ICP.
All right, thanks, man.
Chuck.
Nice presentation, Johnny, and I'm just interested because we're studying similar things here. With the dismounted complex blast injury, we thought that that would be more relevant to soldiers so that we could ultimately predict what a good blood pressure should be with Reboa. But we didn't do the study with a partial Reboa. So in your case, are you able to put the ICP to a fixed number that you want by dialing in the degree of partial Reboa?
That's an interesting question. No, we did have a balloon that was computer controlled, but that was the balloon that we had in the head that we were using to manipulate ICP. Once that was down, we certainly did see, following their intracranial pressure, that they were very dependent on volume status, and that you could manipulate your intracranial pressure to a certain level. Now, those manipulations were all in the context of ICPs of 10 to 15 millimeters of mercury, so not anything that's going to put you over the edge. The failure of our model is that it's very much a kind of hydraulic model in that it was a balloon space-occupying lesion. It wasn't a contusion that evolves over time, as you would see with a kind of secondary brain injury in a neuro ICU. So there were significant limitations of the model. But yes, it's fair to say that I think you could manipulate your ICP by playing with your Reboa catheter. We controlled so many parts of that makes it difficult to say exactly how you would do that, but that would be doable.
It seems like the knowledge gap we have is for somebody who's in hemorrhagic shock with a TBI, what is the optimal blood pressure for that patient? And so it seems like if you could control that ICP and then determine the point at which the perfusion pressure drops, then we would know that that's an ICP goal that we shouldn't cross. And then therefore figure out the blood pressure that we can dial in to make sure that the ICP doesn't get higher.
And that I think comes down to what it is that you measure as being your trigger for raising your pressure or lowering your pressure. The ideal thing obviously is to have somebody who you've got a clinical measure of their brain performance, ideally they're not obtunded and you're able to titrate to their conscious level. However, that's never the case in these settings, and then there's drugs on board and all kinds of other problems. Ideally some sort of bedside monitor that gives you cerebral perfusion. I really kind of liked our little blast of intraarterial contrast that we could then measure quickly with our CT perfusion scanner, because it gave you some level of end organ perfusion, some sort of parenchymal measure, because I think pressure alone is insufficient.
Thank you.
Yeah, Johnny, you've mentioned this already several times, but this balloon in the brain is extraordinarily artificial.
Oh yeah.
And you've actually read your paper, but then I read the agenda, so that's the reason I didn't put it in my state of the science thing.
Thank you.
But I spent a lot of time on your paper. It's extremely artificial. So the conclusions on autoregulation, secondary, all of these things that we're talking about, I think and you said this in the paper and you said it here, really need to be put in the context of an extraordinarily artificial, non-representative brain injury, right? And so are you guys going to, and you, again, stated that very clearly, are you going to take this then and do a brain injury model, replicate it, given all the problems of the pig skull and brain?
So the ideal, the interesting thing is you're in this world where clinically at the bedside in the neurotrauma ICU, people are measuring intracranial pressure, and it's all about, managing secondary brain injury. Whereas all the kind of models that we have, or a lot of the large animal models we have, don't actually have a raised intracranial pressure component. So that's what led to us coming up with that, with that, which granted is really a hydraulic model. The big question is whether or not we can add on a parenchymal model that gives you a region of contusion that then is manipulated by your brain perfusion. That adds a level of complexity that really requires a lot of money to do that. The study that we did with Reboa, where we had the pig going in and out of the CT scanner, we had the Fogarty balloon to look after, we had the Reboa cath to look after, and then we had to do the bleed and the resuscitation. That required a huge amount of manpower. So to add a contusion on top of that, that's absolutely, it's doable. Do we have plans to do that? I don't have any funding in hand right now, but I think that would be the next step of this sort of work, to have a relevant large animal model of both raised intracranial pressure and brain injury. Thank you.
All right, thank you, everyone. For a nice change, we are going to have neither a breakfast nor a coffee break at this point. We are, in fact, going to continue moving on to Reboa for non-traumatic disease.
Okay, so first talk, it's my co-moderator, Dr. Moore, who's going to be speaking about non-trauma applications of Reboa.
All right, so same disclosures as my other two talks, nothing's changed. So I think we've touched on a lot of these topics today, and there's going to be specific talks on some of these, including the postpartum hemorrhage indications. But I think obviously Reboa initially was really brought into the trauma world, but there are certainly other causes of non-compressible torso hemorrhage that occur. I think the original really thing that spurred us to believe in Reboa for trauma patients was the vascular literature about using the CODA device for ruptured AAAs. And as we've started to have more trauma surgeons and more trauma centers use Reboa, obviously the indications for it have expanded. Oftentimes in a lot of these facilities, the acute care surgeons, i.e. the trauma surgeons, are also the ones that are getting the phone calls in the middle of the night for the hemodynamically unstable patients with intra-abdominal bleeding from a variety of causes, massive GI bleeding, postpartum hemorrhage, post-surgical complications from Whipples and other, big abdominal operations. And then as a result, we've applied our knowledge of how to manage trauma hemorrhage to patients with non-traumatic hemorrhage within the abdomen. And then certainly non-traumatic cardiac arrest, which I'm sad Austin Johnson's not here today to talk about that, but the interesting data is certainly emerging about that indication as well. So I'm really just going to try to focus on the general surgery aspects of this. There's not a ton of data out there right now, but you're starting to see more and more case reports come out of different centers with different sources of intra-abdominal hemorrhage, catastrophic bleeding from a gastroduodenal artery after a Whipple, massive GI bleeding where they're using Reboa to support blood pressure and perfusion so that you can get to the operating room. And again, a lot of these cases are just single series, case reports that are showing up. There are a few multi-center registry data experiences. This was a 37 patient series combined from the ABO trauma registry as well as the aorta database, looking at patients with non-trauma hemorrhage and what the sources of bleeding were and the mortality. As you see from this figure, the majority were GI bleeds, the majority were placed in zone 1 and peri-arrest patients, and the mortality rate was high at 37%. But again, proof that it can be used for these various sources of hemorrhage. And then peripartum hemorrhage was about 25%, and Dr. Brenner's going to talk to us a little bit more about that in detail. I think one of the really important papers came out of the group here in Baltimore. This was a series of 11 patients that underwent Reboa for non-traumatic hemorrhage. And I realize this is a very busy slide, but it is really the first published algorithm for the non-trauma use of Reboa. And you'll see it's actually very similar to the algorithm that we've proposed for trauma patients with Reboa. So do they have life-threatening hemorrhage, yes or no? If it's not life-threatening, they don't need a Reboa. But if it is life-threatening and they're persistently hypotensive despite initial attempts at resuscitation, then they would be a good candidate for Reboa. And again, the zone of occlusion for most of these cases is really recommended to be zone 1. But again, you'd have to factor in the site of suspected hemorrhage. Certainly for those patients that are in arrest, regardless of the site of suspected hemorrhage, they're recommending for zone 1. The group in Japan, who certainly has been leading the way far ahead of the U.S. experience with Reboa, has also looked at some of their data related to Reboa use in non-traumatic bleeding. And I'm just going to blow up this slide here to show you the predicted mortality for these groups was extremely high, but the actual mortality was much, much, much lower in those cases where they were able to utilize Reboa for temporary hemostasis and blood pressure support until they could get to definitive hemorrhage control. I thought this was a really interesting study that just came out this year from the group in Sweden looking at the use of blood bank data to identify patients that could potentially benefit from Reboa. So they utilized blood bank registries to identify patients that had massive hemorrhage. In the group of 804 patients that had massive hemorrhage, 53 patients were identified as having a source of hemorrhage that could have potentially been addressed by Reboa. And of those 53, only 19 actually received it. Interestingly, 78% of those patients were women with postpartum hemorrhage, and 44 out of the 53 had non-trauma sources of bleeding. So I think we've all, focused a lot on Reboa for trauma, but in reality, I think the need for Reboa support in non-trauma hemorrhage far exceeds what we're going to ever see in the trauma patient population. So with that, I think we have to really start to expand our process in terms of we shouldn't be limiting Reboa to the trauma bay. It needs to be available in a variety of different areas within your institution. Your OR, your ICUs, your emergency department, not just the trauma part of the ER, but the entire emergency room. And then we also have to educate our colleagues in other specialties. I think at the beginning of our Reboa experience, we were very cautious about who we trained because of the size of the sheath that was required to deploy the device. We didn't want to have a lot of complications that would have significant detriment to our patients, like limb loss. But with the smaller devices that are available now, we're certainly seeing a decrease in the number of vascular access related complications from the sheath. And so I think it's time for us to start helping, train our colleagues in other areas to use Reboa and think about the use of Reboa for these various indications. And then finally, I think it's really important for us to start collecting data for the non-trauma cases and come up with some guidelines for how to use Reboa in these other situations. So with that, I will close and open it to questions.
Thanks for your excellent lecture. I'm also a true believer for the non-trauma cases, but the only thing is also from my own experience, especially when you have ruptures, aneurysms, you have a pipe, you have of course the ball, and you have a pipe again that I actually made in 3 cases. I made a free rupture when using a true Reboa. So without a guide wire, that you have a contained rupture, and you have an aneurysm, you actually puncture it. So actually from a stable patient, I made myself an unstable patient. So I'm quite cautious when I do it in ED without guide wires for aneurysm. So I think for all the cases you have, it's much more straightforward, but that's only for my personal experience. So we say, if we have x-ray, we just see if the guide wire is up or in the renals or whatever, but at least when it's up, then you have a more safe position. And it's quite hard, because if you have an aneurysm, to put it straight in the thoracic aorta.
Yeah, that's a great point. Absolutely. I mean, obviously the move away from the wired devices, I think was a really great advancement in terms of the ease of use, especially for the trauma indications. But you're right. If you're putting it up for a ruptured aneurysm, it's a very different, set
That's
of...
the only reason, so because of personal experience. So
Yeah.
I made the intervention a little bit harder myself. So
Yeah, understood. Thank you. Great comment.
Dr. Moore, I just have one question as well. Do you think that, because we've been talking about before where, so trauma patients are trauma patients and therefore they're different compared to other patients. So these patients are not trauma patients. Do you think we should have other algorithms for when and how we should be using Reboa?
I think potentially, I think the physiology of a hypotensive patient with non-compressible hemorrhage is probably not that much different from a trauma patient. But I think one of the things that I've observed, and I don't have a lot of experience with this yet, but the postpartum hemorrhage patients in particular, I think pregnant women have a coagulation profile that's very different than a trauma patient. And so the ones that we've done in Houston, they've all tended to form clot in a way that I haven't seen in the trauma patients that I've done this for. So there's something different, I think, physiologically about them. And so maybe the way that we manage the sheath, and do we give, heparin through the sheath and that sort of thing, I think those are really important questions that we need to figure out, because it will kill your postpartum hemorrhage Reboa program if you lose a leg, you know, in a young, healthy woman. So I think those things are really important for us to look at and incorporate into algorithms for non-trauma use. Dr. Holcomb.
Yeah, Laura, it's a nice, really nice overview. And I just going to rise to tell a little story really quickly. I was on call, this is several years ago, and the chief resident called me from the MICU saying, I just put a Reboa in a bleeding patient in the MICU. We're on the way to the operating room. Meet us there. I'm like, okay. And I just say that because a lot of residents now have grown up with the Reboa and it's normal to them. So at these meetings, we talk about this as kind of cutting edge, but a lot of folks have grown up with Reboa. And when there's a patient bleeding outside the operating room, putting Reboa in is almost a first thought, right? And so this group is changing how people manage bleeding. I agree with you, irrespective of the cause when it's outside the operating room. Some of our residents think it's normal to put a Reboa in.
Dr. Moore, hearing about its use in ruptured aneurysms, I was wondering, as the catheter size decreases, do you think that we are going to see an increased incidence of Reboa placement into renals or into the left subclavian inadvertently when someone's going for zone 1?
I mean, I think anything's possible. We haven't, I don't think we have enough data out there yet about the smaller devices to say that we see that happening. But I think like we teach in the BEST course, you've got to get some sort of plain film imaging before you inflate. That's what keeps you out of trouble. We saw zone 1 misplacements with the 12 French device. We've seen it with the 7 French device. I'm sure we will see it with the 4 French device and other devices that come after that. But the way you stay out of trouble is you've got to get that plain film before you do it. And I think most of us would agree that that's a safe practice. It's not always, executed, but I still think you have to keep in mind the safety profile and confirm that it is where you think it is before you blow up that balloon, or you're going to get in trouble.
With the rapid advancement of small steerable sheaths, I would challenge those in the audience or their trainees to look at brachial artery access. I think, if we're really looking at a ruptured aneurysm, I wouldn't probably go and you're going to use a traditional Reboa catheter and not a over-the-wire coda in your endo suite. I would consider coming from above. And the sheath technology right now where you can steer a sheath, you'd need fluoro for it, but I think brachial access is also something that will continue to advance and allow broader use of this.
Yeah, that's an excellent point.
And reduce your risk of femoral artery and lower extremity ischemia.
Yeah, agreed. Great point.
Any more questions?
For those who haven't seen those sheets, look them up. They're magic. I know many in the room have used them. But the steerable, for example, tour guide sheet, they're magic. The way you put the sheet where you point where you want the device to go. Pretty cool. Break them out in your best course.
Will do. Sounds good.
Okay, thank you very much. So our next speaker is Austin Johnson. No?
He's not here.
He's not here. Okay. You're doing it. Okay, Megan Brenner. So we're doing Reboa for postpartum hemorrhage.
Thank you. Good morning. Thank you, Rishi. Thank you, Chuck and Dr. Scalia for organizing the conference. Thank you, Tal, for starting EVTM so that when we talk about crazy things, we have a safe space to do so. I'm going to briefly discuss Reboa for postpartum hemorrhage. This is something that many of you in this audience have done before and continue to do. The following are my disclosures. So as you all know, postpartum hemorrhage comes in a few varieties. This is the placenta accreta spectrum. And the diagnosis is really based on the degree of invasion into the uterus. So accreta, increta, and procreta. There's 3 clinical scenarios that we use Reboa for postpartum hemorrhage. The emergent intra-op consult from L&D. This is the trauma surgeon and emergency general surgeon who's on call at night and gets the 911 page. Please come to L&D. Second one is the planned C-section with the diagnosis on the placenta accreta spectrum. These are usually diagnosed preoperatively on ultrasound or MRI. And then less frequently, some of these patients will come in and present to the ED, or they'll be in the ICU and begin hemorrhaging at that point. So as we know, Reboa for postpartum hemorrhage is not new. Back in the 80s and 90s, there are a few case series and case reports for both prophylactic and emergent hemorrhage control using Reboa. Most of these cases were bilateral iliac artery balloons. Most of these were placed by vascular or interventional radiology, but it never really became the standard of care. One reason perhaps could be the source control. If we look at the origin of the vessels that supply the uterus, a lot of them come out up proximal to the bilateral iliac arteries, which is one problem. I think that has never been really defined. And then the consultants, right? The people that were doing the bilateral iliac artery occlusions were IR and vascular, again, not available 24/7. So this is just a depiction of the possible source control issue. There could be a lot of collaterals and a lot of vessels that come off the aorta, certainly higher than the iliacs and even higher than the aortic bifurcation. This is a recent study that was published looking at open vascular control of the bilateral iliac arteries and comparing it to Reboa in patients on the placenta accreta spectrum. This is just a single center case control study, but they looked at both groups and compared the outcomes. What they found was that the time to operation and vascular control was better in the Reboa group. The transfusion requirement was significantly decreased in the Reboa group. The rate of hysterectomy, so the rate of uterine salvage, was actually higher in the Reboa group. And the ICU and hospital length of stay was also lower in the Reboa group. Another recent study from our colleagues over at Loma Linda, they took 17 Reboa patients and compared it to 73 no Reboa postpartum hemorrhage patients. And these are patients who in which Reboa was used prophylactically. So the balloon went up prior to the hysterectomy. This was done with a 7 French balloon catheter. Retrospective case match controls were used, and they found that the EBL, the number of PRBCs that were transfused, and both the ICU admission and hospital length of stays were decreased. Another really interesting finding, I think, in this study was that the rate of postoperative ileus was significantly lower in the Reboa groups. When we think about it, not necessarily surprising, but again, something interesting that was found. In terms of complications, 2 thrombotic events occurred. One required anticoagulation and one had to return to the OR for thrombectomy. This is a case scenario from one of my cases a few months ago. This is a 25-year-old female, G3P3 with 2 prior C-sections, otherwise healthy. This was during the month of March where we had there's always a critical blood shortage, but a really super critical blood shortage. The placenta accreta was diagnosed on ultrasound. We pre-opted her according to our protocol, which I'll talk about later this afternoon. So we brought her into the operating room. Urology placed the stents. We took her out of lithotomy, prepped the groins, placed the femoral A line, hooked it up to the transducer, and then the C-section proceeded. At that point, as soon as the delivery is performed, the umbilical cord is clamped, and at that time, I inflate the balloon. Obviously, at this point, there's a radial A line, so it's fortunate that we're able to confirm aortic occlusion both that way and also by manual palpation since there's already a C-section. The hysterectomy is completed and the balloon comes down. This particular patient had 0 episodes of hypotension. There was a dry surgical field. She only received 1 unit of PRBC. I did drip TKO heparin just through the sheath itself. That's not based on any data that I have. It's just a practice I've started. We had no complications. We are starting to collect TEG data through these cases. And interestingly, it did demonstrate fibrinolysis shutdown in this patient. So there's a lot more work we have to do trying to figure this out. And Dr. Moore mentioned these patients clot like crazy. She did have weak signals bilateral, even with the zone 3 occlusion. So there are still collaterals that are able to perfuse the extremities, and she had palpable pedal pulses bilaterally and discharged as usual in post-op day 3. This is more of an emergent case that we had, not as many photos to document since it was an emergent, but by this first line already, you know that disaster is imminent. 48-year-old female, status post IVF in Kenya, who just showed up to our ED, essentially almost in labor. She had a history of a mitral valve prolapse and myomectomy. She had 2+ pitting edema and 4 pillow orthopnea from congestive heart failure. She clearly had an emergency section, and PA placenta accreta was diagnosed intra-op, and she went into profound hemorrhage, was hypotensive, blood clot resuscitation started. An echo was done, which showed severely dilated left atrium, mitral stenosis and regurg, tricuspid regurg, and septal bowing. We placed initially the Roboa at zone 3 and moved it up to zone 1. And once we realized that the hypotension was more due to a cardiac origin, we were able to start Levophed and wean the balloon down. So again, I'll discuss this more this afternoon, but the key here is creating a multidisciplinary protocol for both elective and emergent use of Roboa. We schedule these cases in the main operating room. They are not in L&D. We are co-surgeons with the OBGYNs. Consider TKO hepsaline through the sheath. Obviously, that access groin needs to stay extended, right? When that sheath comes out, no matter how small the sheath is, don't let urology flex it to do their cystoscope. If a cysto is performed, again, keep it extended. They can always frog leg the other leg, and usually there's a Foley in these patients anyhow. In profound shock, zone 1 for hemodynamic support, that's with or without, postpartum hemorrhage trauma, that's all the same. And then documentation is key. We were able to insert a small documentation form in our EPIC program, which allows for a lot easier documentation for these patients. Vigilance with pulse exam, not unlike trauma. The coagulopathy of pregnancy, as we are learning very quickly, is not well understood, and the thrombotic state is real. There's a much higher incidence, this is anecdotal, but of higher incidence of thromboembolic events than trauma patients with the equivalent size sheath. We are seeing many more clots in these women than we ever did in trauma. So there's an even higher risk with the emergent use, and we always, of course, recommend a low threshold for angiograms and duplex ultrasounds. The other benefit to us taking care of these patients is that we have continuity of care from the operating room into the SICU. We continue to take care of them there, and we know them well. Discussing data and collection, we have started the Prego trial through the AAST. It's a multi-institutional trial. We are collecting Roboa and no Roboa groups. We learned from the aorta trial that having a control group is absolutely critical. So if any of you are interested, this is an international study. Please enroll patients in the data. The information about this data and the study is on the AAST website. So in summary, the data demonstrates potentially improved outcomes for Roboa in postpartum patients. It should be part of a comprehensive service that's offered to other specialties to provide temporization of hemorrhage, resuscitation, SICU care, and complication mitigation. Data will help us determine which patients can benefit. And of course, technology will expand indications, providers, and improve the safety profile. Thank you.
Hey, Megan, it's good to see you.
You too, Sheldon.
I just want to say thank you to Megan because she really helped us, along with Todd and Joe DeBose, get things started in New York. And it seems so long ago. We weren't even then talking about postpartum hemorrhage. We were basically focusing on trauma. And in conjunction with Laura's talk about the importance of the X-ray. So 2-3 weeks ago, as a postpartum hemorrhage was atonic uterus. The abdomen's not open. It's late at night. So I'm drawing a distinction between what you can protocolize, the protocol you made, and the emergency general surgeon running to the L&D suite. So there was no way to throw everybody out of the room to get the X-ray. It was disorganized, but it did work. So I'm wondering more about the emergency in the middle of the night in the L&D suite in a rarefied part of the hospital. It was 60 over palp. They hadn't gotten their MTP started. I mean, they were deep in a hole. She lived.
That's a great question, and I'm going to go into that in detail in my next talk this afternoon. But what it boils down to, obviously, just like anything, whether it's trauma or not, or this, is team training. So education and team training. So it's always going to be a disaster, right? It's the emergent 911 call, and you're also doing something else when you get the call. So it makes it even more important to get that team training done and go through these scenarios so that everybody knows, whether it's an overhead page or, you know, whatever your institution and its resources can provide. But we set that up at Riverside and practiced, you know, every Friday we'd get the overhead page and we would all practice. And after a couple of months, it just became routine that, you know, at 2 a.m. when we got the call, everyone knew what to do and everyone knew where to go and what to grab. So we can definitely talk about that a little bit more, but I'll cover a lot of that in my talk this afternoon. Thank you.
Hey, Megan.
Todd.
Sheath management, you know, as we try to demystify and make this procedure more safe for a broader group of providers, it strikes me that the things that you and I do when we put an endograft in, an EVAR in for an elective aneurysm repair, are really completely lost by the trauma and emergency care community. You know, how many times when you put in an EVAR do you ask for an ACT, activated clotting time, and how many times do you dose heparin? How many times does your scrub tech flush the sheath side port or your resident? I mean, it's just sort of part of normal sheath management is just, I think we overlook that. And I think we may have overlooked it as we just talk about REBOA, you know. And I wonder if, you know, either in future EVTM meetings or part of, as we train, you know, sheath management, understanding, does the trauma provider know what a sheath, what sheath size is? How many millimeters is a French size? Is it sized inner diameter, outer diameter? If you're going to give hep saline, what does that look like? Is it 1,000 units in a liter? Is it 10,000 in a liter? I know when we developed the JTS CPG for the Department of Defense, the Joint Trauma System, we spent a lot of time talking about sheath management. And I appreciate you bringing that up. I think it's going to be increasingly important, certainly in peripartum or postpartum hemorrhage in women who have smaller vessels who are in shock. But I think emphasizing that's really important. Did you protocolize with your study sheath management? You know, and if not, should we do that? You know, specifics about sheath management.
Yeah, it's a great question. And that's definitely something when we look back over the past 10 years, we certainly didn't, you know, focus the training or the teaching on sheath management, partly because we wanted to make it as simple as possible. But we also missed, you know, the opportunity to maybe reduce some of these thrombotic complications. So the fact that we've gone from, you know, 20%, you know, complication rate with the thrombus, with the CODA to 5% or 3%. Hopefully that'll get less, but it doesn't negate the need to do that, especially now since, you know, we're doing this in postpartum hemorrhage. So we didn't protocolize or mandate, you know, any dripping of the hep saline hep saline just through the sheath. That's just something I started doing. No data on that. Not that that's ever stopped us, but you know, it's something we need to look at. And especially as we collect data from other, you know, from cases, we need to really specifically ask the data on sheath management, and maybe that will help us provide a protocol later on. So thank you. Dr. Moore.
Great work, Megan, and I hope we continue to accrue some good data on this. But I want to underscore what you alluded to, and that is the incredibly dynamic coagulation system in the pregnant lady. And as you know, we've followed them and have shown that progressively in gestational time, they have increased hypercoagulability, increased functional fibrinogen, and increased platelet reactivity. What happens when they have a crash C-section, interestingly, we just published this, is that the placenta has a high concentration of tissue factor pathway inhibitor. So suddenly it looks like you can't generate thrombin, and then everybody has a response, let's give TXA, let's give cryoprecipitate. And that's exactly the wrong thing to do, because once the uterus is removed, TFPI has a very short half-life. Now they revert to a hypercoagulable state, and then we start seeing these sheath thrombosis events.
That's a great comment. Thank you. We look forward to really more data also coming from your institution about this, and hopefully in the Prego trial, we'll be able to collect some data and, you know, even try and just understand more of this coagulopathy in these women. So thank you.
Dr. Brown, I just have one more question. Okay. I was just wondering, because maybe I misunderstood, do you place these sheaths before you do the C-section, or is it done when the patient actually needs a REBOA?
No, so I place them once the patient is supine. Before we, we'll prep and drape the patient completely for both the Reboa and the C-section, and I'll prep and drape the groin as well and place the sheath
Right.
prior to the C-section.
And then, are those patients in any way included in the registry?
Yes.
They are, as non-Reboa.
Yes, it's a prophylactic and emergent use
Right. Yeah.
database, so we'll be able to collect both. Hopefully.
Great.
Thanks.
All right, thank you. Final speaker, it's my co-moderator, Dr. McGreevy, going to talk about Reboa and acute cardiac tamponade.
Okay, thank you very much. So no conflicts of interest. So we've starting to gain quite a lot of data on the use of in-hospital Reboa, specifically in trauma patients, also now more and more in non-trauma patients. But the data that we're gaining, and it's also still quite controversial, is the pre-hospital use of Reboa. There are a few studies out there, and there's been autopsy studies that have been suggesting, for example, that between 3 to 10% of pre-hospital major trauma patients may be benefited of the pre-hospital use of Reboa. However, it's still controversial. I mean, there's a lot of different issues into using pre-hospital Reboa, specifically because you might not know you could have penetrating thoracic injuries, but there's also other things like, for example, cardiac tamponade. Many of these patients, for example, blunt cardiac injury is quite common in motor vehicle deaths, and many of these patients unfortunately die at the scene. However, diagnosis of an acute tamponade on the scene pre-hospitally can be quite challenging, specifically because ultrasound is not always available. So one of the reasons for looking into this and is because not that I'm trying to discuss that you should be placing Reboa to treat a cardiac tamponade, but more in this case that if you were being placing Reboa pre-hospitally or maybe in hospital as well, and there was a cardiac tamponade present that you weren't aware of, what would happen physiologically? Because generally you would think maybe that this would actually deteriorate and be worse for the patient. So we did an animal study where we had randomized 14 animals, 7 in 2 groups, where we caused a surgically induced tamponade by using a cell puncturing the left ventricle and using a PCA balloon to create a small hole in the left ventricle, and then with a purse string suture closing the pericardium, and then allowing a tamponade to form. What we did then is we allowed these animals all to deteriorate, so they went down to a systolic blood pressure of 50, and then at that point randomized them into 2 groups, then Reboa and then a controlled group. The controlled group didn't get a Reboa. And then we followed them over the course of time to see, and specifically looked at systolic blood pressure, but also, for example, cerebral blood flow. What we could see then is both at baseline and when the animals deteriorated to a systolic blood pressure of 50, generally there was no difference in these 2 groups. The only difference was a lactate that was seen, difference at baseline, but there was no difference when they deteriorated to systolic pressure of 50. And already at 1 minute after randomizing and placing the Reboa in the Reboa group, we could see that there was a significant difference between the 2 groups, specifically in systolic blood pressure and in mean arterial pressure, but also in cerebral blood flow, being significantly higher in the Reboa group. We also then compared the difference in the both groups, compared them at 1 minute compared to when they were at a systolic blood pressure of 50, and we could see that there was a significant increase in systolic blood pressure and mean arterial pressure, as well as cerebral blood flow, and a decrease in end-tidal carbon dioxide, whereas there was the opposite for the non-Reboa patients or animals. So this is also the reason why we looked at this data at just 1 minute, was because after that, basically all the animals that didn't receive Reboa, they died. So about after 5 minutes, there was no animal left in the non-Reboa group that was alive, whereas the animals in the Reboa group continued to live to about 30 minutes. We could also see, and there was also a significant difference, as I said before, in the systolic blood pressure. And here you can see the same difference there as the cerebral blood flow. There was a significant difference at 1 minute. And then they maintained an adequate level of cerebral blood flow over a longer course of time. And then also this is just to graphically show the Kaplan-Meier curve of the survival between these two groups. So basically, conclusion from this study is not, and again, I stress this, is not that we're saying that you should place a Reboa if there's a cardiac tamponade, but just that if a Reboa would be placed pre-hospitally and there was a cardiac tamponade present, maybe that maybe it shouldn't be a relative contraindication in these types of patients. Thank you very much.
Any questions from the audience?
Hi, David, Jim Manning, University of North Carolina. Very interesting study. And it's consistent with something I had seen in my own laboratory where I had actually put a hemorrhage and pericardial tamponade and cardiac arrest. I was using SAP to resuscitate him, but actually found that you could get the heart beating again while the tamponade was still there. Now, the way I put this together, I just want to see what you think, is that your heart stops beating with a tamponade when the perfusion pressure to the myocardium is so low that you can no longer, you lose all your ATP, your heart stops beating. By using the Reboa early enough and maintaining the mean arterial pressure, you maintain perfusion to the myocardium long enough. And it looks like that's what you did here. If you let the pressure drop too much, they just arrest. But with Reboa, if you can actually keep their pressure up and maintain perfusion pressure to the myocardium, you can sustain the myocardial activity. Is that how you put this together?
Absolutely. Yeah, I would agree. That's definitely the same. I mean, we had a couple of animals that actually deteriorated quite quickly, and we actually never had the chance to even put the Reboa up because there was causing these tamponades is sometimes a little bit difficult to get them, get it all done in time. And we were seeing that the ones, exactly like you're saying, the ones that deteriorated way too quickly and we put the balloon up too late, we never got them to get back, and so they arrested and they continued that way.
Which is the point I would say is that you can't, if you put the catheter in and you're thinking you're going to use it, you can't wait until they arrest and then blow the balloon up and think you're going to get the benefit. You actually have to put it up early enough so that you bump the pressure up and maintain perfusion pressure to the myocardium. That would be the key.
And I think this is the whole reason why we wanted to do this study, is just because of the discussion with pre-hospital Reboa. If you're waiting with these patients until they're in hospital, that might be too late. So maybe pre-hospital Reboa and, in selected patients, the really bad ones, maybe we should be placing Reboa pre-hospitally.
Okay, that concludes the session. I think we're now lunch. No. I'm being told no. You don't get to eat yet.
The bell doesn't dismiss you, I dismiss you. So with having a little bit of fluidity to our talks, if the speakers are willing, we're actually going to have the last session now, Specialties in Education 3, have lunch at about the same time, and we'll finish up the day early. So if Dr. Holcomb and I think Omid is not, he's not here, correct, Dr.? Right. All right, and Dr. Ayerdi? We're doing things on the fly here, folks.
Good morning to everybody. I'm waiting for my slides. I take the opportunity to thanks again for the invitation. And my talk is about imaging technology and trauma. First of all, I want to keep in your mind the importance of imaging in trauma patients, and it is to improve management and to improve outcomes. What means improve management in stable patients to guide the treatment, and in unstable patients for a hybrid, even if you have an hybrid room available. improve outcomes with hybrid procedures and with the special imaging guided procedures that I'll show you in the next slide. So in that direction, imaging is at the core of the approach to trauma patients. And I highlight in my presentation then the role of a hybrid room and the role of artificial intelligence in ER. What about a hybrid room? Hybrid room is a common theater in which all of us knows that the damage control surgery and the transcatheter arterial embolization can be done together. And in some cases, you can do also CT acquisitions. All these actors play together in the same room and can they take decision together. In this scenario, the interventional radiologist should be available 24/7. It is known and it is already proven that the hybrid room improve outcomes and improve the efficiency of the center. In the next slide, I show you a case that we managed together with our surgeons. It is a transection of hepatic artery, and with the help of our surgeons that stretched the tissue, we were able to cross the section and to, like you can see in these images, the video doesn't work. Okay, no problem. But our surgeons stretched the tissue and we were able to cross the lesions and to put a covered stent. What about artificial intelligence? What is artificial intelligence, first of all? It's a science and engineering to making intelligence machines. Is the fact that you can create systems to perform tasks that usually are performed by human intelligence. What about artificial intelligence in IR and in trauma patients? First of all, you have to analyze the image analysis applications. And in that field, in my opinion, the most important things is the tools is the automatic vessel analysis. First of all, you have to have a COM-beam CT. All the angio suites all over the world nowadays have a COM-beam CT. And if you have a well-trained personnel, so nurses and technician, you can perform very, very quickly at the COM-beam CT also in these difficult patients, like you can see in these images. I want to highlight that in this way, you don't waste time, but you save time. The acquisition of a COM-beam CT lasts 4 seconds, and the post-processing system don't take more than 50 seconds, 1 minute. Trust me. This is our protocol, and that we perform an angio COM-beam CT when we have the catheter in the arterial that is supposed to be the culprit of the bleeding. And in this way, we perform an acquisition, and in the most cases, we can visualize the bleeding. And if we don't visualize, the bleeding, we can overload the images of the COM-beam CT with the pre-procedural CT, for example, like in these cases. And the software is able to visualize the route to reach the bleeding point, and the operator can visualize on live fluoroscopy the route, like you can see in these images. Very impressive images. So what about the support tools? Sometimes you are not able, I take an example, sometimes you are not able to reach the bleeding point. How can you do? Like in this case, you can use a real-time fluoroscopy with virtual needle path overlay without moving the patients, remaining in your angio suite or in your hybrid room. This is a case of a polytraumatic patient. During his hospitalization, he developed this pseudoaneurysm, and we were not able to reach it. Via transarterial. The video doesn't work, but believe me. And we perform a percutaneous embolization using the COM-beam CT and the virtual needle pathway, and we embolize it with glubrian, like you can see in these images. This is another application. It's called angioscopy that in the future maybe should be used also in trauma patients. This is a very impressive video. What about training and education? Training is a very important part of this to using these tools, because it is proven that it save time and dose during the procedures, and there is the possibility to upload DICOM images to obtain three-dimensional images, like in these cases, and to use augmented and virtual reality. What is augmented reality? Augmented reality is a system in which digital elements can be added to a live view of the real world, like in these cases. And using these special glasses, you can upload CT images and you can consult them during your procedures, or you can have a consultation from your mentor, from your senior colleague that is who is at home, for example, who is on holiday, everywhere. And like in these images, and we started to use this special system from 4 years ago with very great results. So in conclusion, nowadays imaging technology has a pivotal role in trauma management and may improve outcomes. I take the opportunity to invite all of you in Italy next January for the Italian chapter of Endovascular Resuscitation, our first edition. Thank you very much for your attention.
Questions from the audience? Are you using the virtual reality goggles to do simulation training?
Yes, we use. I have to be honest that it is necessary a long period for training, because especially during the emergency cases, it's not easy to wear the glasses and to consult images, to send images to your colleague who is at home. But we started of course in elective cases, and if I have to be honest, now we are well trained and we use them not always but often.
Very nice. That's great. We talked yesterday about simulation training.
Yeah.
And doing complex things that you do rarely, right? Simulation seems to be the way to help overcome those issues.
Simulation is important because everyone can handle materials, can handle device, and without the patients, and then to do the procedures you can save. In every case, you can save time, and you are more prepared to do all the things, to do all the steps of the procedures.
That's very nice. Thank you. Anything else? Okay, thanks. Dr. Manning.
Well, thank you very much. I appreciate the organizers inviting me to talk, and I'm going to talk about the creation of a course to teach selective aortic arch perfusion. First of all, I am the inventor on some patents that are assigned to the University of North Carolina. Department of Defense funding was used to actually create this course, and I'm also co-author of Resuscitate that's trying to advance SAP into clinical practice. So just quickly, selective aortic arch perfusion is a balloon catheter based endovascular therapy, but is primarily an extracorporeal perfusion therapy. It looks very much like a Reboa catheter, I get that, but it's a large lumen catheter, and the balloon was really designed. This was originally developed for medical cardiac arrest, and the balloon was just to limit all the flow to the heart and the brain. But it does also work for traumatic cardiac arrest. So it is primarily an extracorporeal perfusion therapy. There are 3 steps that can be used with the SAP catheter and sequential therapy. And so this is what we want to teach in this course, and the course is designed to do that. It's designed as a 2-day course that combines 5 short lectures and 4 fairly extensive skills sessions. The weight is toward the skills sessions because that's going to be the most valuable part of this. 2 of those are vascular access focused. The other 2 are resuscitation, SAP resuscitation related. In fact, when we did 2 test courses, the feedback we got from the course participants was mostly that we needed more emphasis on vascular access. And that is the first critical step. So we put a lot of emphasis on that. And in fact, we developed some teaching materials for the course that then were pulled together, and we created a review article on femoral vascular access. And it just so happens that all the co-authors you'll recognize there because they're all here, and we actually pulled this cohort of authors together at the Pan Am EVTM meeting in Denver. So continuity here. We have some of that being presented here. The skill sessions are the most important part of the course. And so, as I said, 2 are vascular access. One of these involves the vascular access model, which will have anatomic fidelity. The animal lab vascular access in pigs, you don't quite have the anatomical fidelity, but you have the tissue handling fidelity, and that's the value of that. Plus, we can also do a SAP demonstration at the end of it and show people what they're going to be doing during the next 2 resuscitation skills labs, which are really the focus of this. You see, during the skills labs, people can practice ultrasound-guided percutaneous access using either short axis or long axis, and get facile with that, and then use that in the resuscitation labs. Now, these are really, to me, this is the most impressive part of the course, is having an open chest model so that you can look at the heart and watch all the hemodynamics. Align these animals so you can watch all the hemodynamics. And so when you put the animals into a hemorrhagic shock arrest or a medical cardiac arrest, you can actually watch what's happening on the hemodynamic screen, and at the same time watch what's happening to the heart. So this is how we instrument it. We have 2 scenarios that we run. First is a hemorrhagic shock. We do it for purposes of this, we do a catheter hemorrhage so we can use the blood actually for resuscitation. But we rapidly hemorrhage them, and you can watch the hemodynamic changes, and you can also watch the heart and see what happens as the animal gets progressively hypovolemic, and you watch the heart shrinking down and the right ventricle collapsing. So once we get to the point of mechanical cardiac arrest, true cardiac arrest, you can then start the SAP resuscitation. And so this is just some pictures from a video that we created on this, and you can see where you watch the SAP begin with the initial bolus of fluid, and you can watch that on the video screen, but you can also watch the heart bulge as we start the SAP infusion. And then progressively watch to see return of electrical activity, which tends to occur before the mechanical activity, before there's contractility, then moving to contractility, and then progressively to return of circulation with good and viable normal pressure. The second scenario we run is a ventricular fibrillation cardiac arrest. And we do this because SAP is a therapy for both medical and traumatic cardiac arrest, and we're going to be teaching people to do both of these. So we actually put them into a VFib arrest. You can see it at the top. So we just easily initiate VFib, and then you can watch the energy pattern, the high energy pattern of early ventricular fibrillation progressively degrade to a less energetic pattern, and then begin SAP. Again, you see the pressure bolus increase, and you watch the heart bulge, and then watch as the VFib pattern actually steadily increases and actually reverts back to a high energy pattern, which is going to respond to defibrillation. And then the defibrillation and return of spontaneous circulation. And one of the things we want to do with this course is to teach people SAP, but we also want to be able to show people how this maybe is integrated into the broader picture of endovascular resuscitation. Because even though it's really a technique for cardiac arrest, it does overlap some with REBOA and ECMO or ECLS. And so trying to understand how we discuss all of these in the course in the hopes of having people understand how they can actually integrate these together. And the last thing is we created this as a standalone course. So it is a full 2-day course if you do it the way we've developed it. But it could potentially be done as virtual lectures at some pace, and then a 1-day very intensive set of skills labs. Or reality is that there are an awful lot of courses out there already that are teaching endovascular resuscitation. It's kind of unrealistic that as endovascular resuscitation continues to grow, that we're going to have 8 or 10 different courses that people all have to go to. So it makes more sense that we're somehow going to begin to combine these, integrate them in some way, but some are the existing courses. And some of this can be streamlined because vascular access is pertinent to all of these. And then hopefully be able to come up with something where, when SAP becomes clinically available, it will be part of a broader training course that people can take. And we'll determine that as time goes on. Thank you very much.
Yeah, Chuck.
Nicely presented, Jim. Since Gene and I had a hemorrhagic model in Denver, I'm curious because we went through several trials and tribulations trying to create the right amount of hemorrhage over the right amount of time without reducing the base deficit too much and creating death in the model. We used a ECMO catheter inserted in the femoral artery, but we had to, basically create something to be able to get the blood out and put into the blood bags. So I was wondering, what do you use to hemorrhage? What kind of cannula, and how fast do you do it?
Well, we did this actually fairly fast. I mean, we tried to hemorrhage them down because we're looking at the time frame. And what we try to do in, say, each of these skill sessions is, if possible, run a hemorrhagic shock arrest, then a VFib arrest. If the animal's still stable enough, try to repeat those if you can. And it depends on it depends on the participants and how much time they take doing vascular access at the beginning of the skill session, and how facile they are. If they're really facile, you may be able to get as many as 3 or 4 actual arrest scenarios out of just the one skills lab animal. But what we do is we put in a really large, cannula, and then we just do a catheter hemorrhage really, really fast and drop them down to, we've gotten them down to essentially no pressure in about 12 to 15 minutes. We allow them to completely arrest, and then they're asystolic for about 3 to 4 minutes, just to show people that you go to complete mechanical asystole, then start to do the SAP resuscitation. So it's a catheter hemorrhage, but we have to put in, a large, introduce like 14 French or something like that to pull the blood off.
18 French.
A 14 French would be sufficient.
Okay.
It depends on the size of the pig, actually. If you use an 80-kilogram pig, a 14 French or something like that will be large enough to actually pull the blood off pretty fast and get them to arrest.
Okay, I think these pediatric ECMO catheters are like 13, 14 French, so we're doing the same thing.
Okay.
Chuck, people have actually, Mike Dubik and Jill Sondine published in Shock about a decade ago using a pump and replicating uncontrolled hemorrhage. That pattern where if you have mils per minute or much higher initially, and then as the animal becomes hypovolemic, it slows way down. But you can recreate with a controlled hemorrhage model just through a regular cordis the pattern of hemorrhage and rate of hemorrhage, rate over time, volume over time of uncontrolled hemorrhage with a pump to suck the blood out.
Okay,
And
perfect.
when we've done our research studies where we're trying to do comparisons and stuff, we do something like that.
Yeah.
For this, which is more just arrest them, watch it, and then you can do it however you want to, really. There's the flexibility to sort of alter the pattern as the way you want to as the instructor, but you just get them down to a cardiac arrest state and then resuscitate them. It can be either way.
Jim, so we had the previous talked about simulation, and many of us grew up using animals to test these things and to train, right? To train. But the animals are, number one, expensive. You can only use them so many times, utilize them so many times for each procedure. Have you considered using simulation in this virtual reality method of training for this?
Well, we have, when we ran the course, we used a high fidelity vascular access model for the first of those skills labs. And it's fine. And it's actually anatomically correct. And it's actually getting pretty good to being sort of like tissue handling is somewhat similar. I just don't think simulations, especially when you're trying to do like a cardiac arrest and then watch the recovery and stuff, we're just not quite there yet. Eventually we will be, but for example, you can do it in a simulation and you can show the heart returning, recovering, and people go, okay, yeah, well, is it? When you do it on a real live animal and you watch the heart stop and it's flaccid and you start perfusing it, the heart actually starts beating again. There's almost nothing more impressive as far as drilling it into people what exactly you're doing.
The simulation world talks about suspension of disbelief, which is what you're talking about. If you really immerse people in the VR simulated world, there is suspension of disbelief. It does happen, but maybe combining the two together.
Yeah, eventually we'll probably get to where, and we'll probably get to where eventually this is done without animals at all. And when we get to that point, great.
I can't help but think about models in training for other areas of our practice, especially for those in the room who are endovascular surgeons. And one model that comes to mind is used by Silk Road Medical for their transcarotid artery stenting, or TCAR. And that's a brand new technology for surgeons. That technology of carotid stenting in the approach did not exist 7 years ago. And I think that's a case study in how to train up this sort of a hybrid, minimally invasive, open, but mostly endo technology that uses vascular access, small cut down, stenting, passage of a wire, imaging, and it's a case study because the company is called Silk Road Medical. I mean, you guys have probably been to the TCAR course. They have nearly perfected training and clinical support with that. What was a brand new technology or didn't exist 5 or 10 years ago, it is now, and they've got the training courses right outside of O'Hare Airport. You know, you fly into O'Hare, and it's well done. It's professional, it's thorough, it's effective at training, this sort of endo technology. So I think, and it's not live tissue.
Mm-hmm.
It's some didactics, it's simulation, a lot of simulation, I guess, but it just comes to mind. And I would encourage us to be mindful of that because, our first E-STARS course, we thought it was great to fly people in and take them to the animal lab at Lackland Air Force Base or at Fort Sam. Well, that's great for 3 or 4 people at a time. But, as you really want to try to permeate a practice community with this new technology, thinking of those who have gone before and done this effectively, I think is useful. So
one of the things that we actually create with this is we create some appended videos that actually, I actually just took screenshots of the video where you're watching the heart and you're watching the hemodynamics. So you can watch the two, especially maybe for people that either can't manage an animal lab or who have conscientious objection. And so it's just, but I agree with what you're saying. Yeah.
Well, and I think at some point, go to one. It would be impressive for you or some of the group who are working on this. Contact me or one of the group here, and we'll have you audit a Silk Road Medical TCAR course. And I think it opens your mind to what's possible in training these sort of technologies because I'm still blown away that they do it pretty effectively. You can like that technology or not for carotid artery occlusive disease, but their training model and how they have ramped that up so effectively is impressive.
I think like we mentioned yesterday, there's a lot of training in a lot of non-medical areas. It's all based upon virtual reality and simulation and done at very high fidelity. 2 comments, Todd, on your comment. Number 1, it's really expensive to build that capability in the simulation VR world, right? So those guys come in a lot of money. And 2, that from probably in the lifetime of many of the folks in the room, the regulators are going to require that kind of training when a new device comes out. It's going to be required. So the sooner we all kind of get on board and the companies start developing simulation, virtual reality to go along with their new devices as required by the regulators, I think everybody will benefit.
Yeah, but they won't let you use the device until you've done the training. It's that strict.
Absolutely. Yeah.
It's a different, but it's just a case study in the topic area that I think is useful perspective.
Yeah. Thanks, Jim. Okay. Next up, what do we got next? Dr. Goes. Oh, Dr. Robbie, sorry. Does Dr. Robbie know that we changed the schedule? Should we go? Yeah, it's not fair. We kind of moved him up 3 hours or something. But Dr. Goes, is Dr. Goes? There he is. Yeah. So can we switch slides? Thank you.
Hello, everybody. Just waiting for the slides. First of all, I need to make 2 comments. The first is to thanks Chuck for this nice invitation. And the second is that I must confess that now that I realize I'm sharing this stage with Dr. Holcomb, I have never been so nervous in my entire life, but in a good way. So my name is Adenauer. I come from Brazil, and I'm a vascular and trauma surgeon. And I will talk to you in the next minutes about carotid injuries. Where should I pass this? Okay, so we have both blunt and penetrating carotid trauma, but because I have only a few minutes, I will focus on penetrating carotid injuries in this presentation. They represent about 3% of all traumatic arterial injuries. The problem is not the frequency, but the severity of the cases. Fortunately, most of these injuries hit the zone 2 of the neck. That is most favorable for surgical approach. And regarding screening, most papers agree that CT is the exam to be performed in patients that are stable enough to do that. Of course, duplex scan can be useful, especially for zone 2 injuries. And there are different patterns of injuries, as you can see here, and I'm sure you are all familiarized with that. And reconstructions can show some scary scenarios like that. Before I continue, I should explain that, unfortunately, in my hospital, I work in the Amazon in Brazil, not in São Paulo or Rio de Janeiro, more developed cities. So unfortunately, we don't have any endovascular resources at that hospital. We are trained to do endo, we do at private hospitals, but we don't have the equipments necessary to do that at our trauma hospital. So we need to deal with everything in the old way fashion. The problem with penetrating carotid injury regards the airway obstructions, bleeding, ischemic stroke, and associated non-vascular injuries, since everything is tied together in the neck. Pardon for the problem of the lines in the wrong places, but literature, one of the things that is not clear in literature is regards shunting in carotid trauma. Classic works say it's not necessary in most cases, but some new works suggest it should be considered, especially when more prolonged reconstructions are necessary. Of course, there are endo solutions, but I don't have it at the trauma hospital. I treated this case by endo, but the pseudoaneurysm was there for 11 years. And planning access is mostly the collar incision or the longitudinal one. I prefer the longitudinal one that you can prolong with a variety of access. And these are the most access used. When planning arterial reconstructions, you can do arterial suture, venous graft, or patch. The literature recommends using always the Safin vein. I am a big fan of using the external jugular because it's right there. I do not recommend using the internal jugular because when you put inside the arterial flow, it becomes like a balloon. It's terrible. So some tips. You can use Foley catheters to control bleeding until you get there. If you find an arterial injury, search for the next injury because everything is right there, so it's highly possible. This can be useful in some situations. If you have an injury to the proximal internal carotid, you may ligate the proximal stump and perform an external carotid artery transposition, sparing one anastomosis. And I made that comment yesterday. If you know you only need proximal access and not a very large exposure, you may perform this upside down T partial sternotomy, and you are going to get this kind of access that may be enough for some situations. And my best regards from the Amazon to you all.
Chuck, you have a question?
Maybe provocative, but you didn't mention PTFE for the carotid. We looked at that in war injured patients and didn't really find a high incidence of infection at all. I feel very comfortable putting PTFE in the subclavian or in the carotid. Do you have an opinion?
Yes, my opinion, I know the data from the literature and I completely agree with you. And until 12 months ago, I worked at this hospital for 12 years. And until 12 months ago, we didn't have any kind of synthetic graft. Now we have only one Dacron graft available, no PTFE available. But sure, it would be my option.
If you were to use the Dacron, then do you feel like you have to soak it in rifampin or do anything special, or are you just comfortable putting in a piece of Dacron?
Well, if the patient is stable enough and they have a good vein, I would go for the vein and spare the Dacron.
Also didn't really find, unless it's the internal carotid artery, that the saphenous is really a great size match, and maybe that's why you like the jugular vein.
I agree with you.
Yeah. Yes, sir.
Chris Ramos, Atlanta. I've encountered a few cases where, penetrating trauma to a neg zone 3, the internal carotid artery is occluded. I've had both cases where patients come in asymptomatic and patients that come in symptomatic. What is your treatment algorithm? It's a difficult situation. If patients come in asymptomatic, do you treat them with antiplatelet therapy and cross your fingers and hope that they don't recanalize and stroke? I've had patients that do recanalize and stroke, doing an interventional procedure to declot them and then have them bleed, makes it difficult as well. So just wondering your thoughts, and anyone from the audience.
I think these high carotid injuries are difficult for everybody. That case I showed using the Foley catheter. Actually, I ligated that internal carotid artery. You can see in the picture the patient arrived with big hematoma and they already had the skin sutured. That injury happened 6 hours before. I always forgot to say that. I was planning to explain this in my pediatrics injuries lecture. I will show you the distance my hospital is and the size of the state I work at. So we are the only hospital with vascular surgeons available for trauma in an area that is twice the size of France. And it means that sometimes everything that survives comes to us. But sometimes I receive a case of carotid injury that happened 6 hours before. And if the patient, as that patient, arrives asymptomatic and 6 hours, and the carotid was completely transected in the base of the skull, and I'm doing that at 3 a.m. in the morning with the first year fellow of general surgery, because we don't have fellows of trauma or vascular surgery, I do not think twice. I ligate the carotid. And the patient went well.
Are you shunting these patients when you're doing these procedures? Are you monitoring EEGs? And what are you doing for antiplatelet or anticoagulation afterwards?
For blunt carotid trauma, I use, usually in the first days, I recommend regular heparin, because if it's necessary, I can reverse the effect. For penetrating trauma, well, if there is no other injury and the carotid is ligated in the first days, I also recommend anticoagulation. But if I reconstruct the carotid artery, the patient is on bed, we use only prophylactic doses for heparin. And we don't have any kind of surveillance for neural status and perfusion. We don't have any kind of this technology, unfortunately.
Thanks.
So, Gene, it's not a moose in the picture, but that's a really big fish, man. So tell us about this picture. What are we looking at here?
This is a fish called trairão, and it's once a year, my father and I and my father-in-law, we go for our spiritual retreat.
Yeah.
So this was in August for Father's Day.
Yeah.
Our annual fishing trip. That's the thing.
It's fabulous. Great
Thanks.
job. Yeah. Professor, tell us what to do.
I think it's time for lunch. Shram can speak when we pick up again after lunch.
Yeah.
I do have one question. I can't not ask this. Was that a spear in the first scan that you showed us?
It's a knife.
A knife.
Yeah.
Okay. It was very large.
Let's just get up on stage. Let's turn that TV around. That's not a bad idea. Sarah? Thanks, guys.
Yeah, I have Pilates
Wait, where are we going now? Where are we going? We have 6 seconds. Why are we just going?
Right.
I got dressed as stylishly. You're still not in there.
No problem. Need more people on. I know, I've been trying to get you guys to move this way a little bit the whole time. Everybody in? Ready?
don't know that I can sit in a ladylike way up here. Nope. John. This is so tall. There's really short. Jack.
What do you guys want to do? I mean, podium.
Sure.
Okay. Glad you did. So please, if you will.
It's very chivalrous of me, right? I mean, I'm vicious.
So this is.
Hey, Dave. How you doing?
So those of you that were at the mouth of the dragon at the Maddox conference, which is the epicenter of all Reboa hatred, this is the exact opposite. These are all
Believers.
Now that I said that, I've jinxed you and some major tomatoes.
No, I think we prefer that.
You like a little
action, yeah. A little controversy.
I don't think there's that much controversy around providing some mechanical control.
I would agree.
I mean, you might disagree about how you do it. What's the right balloon? But having like mechanical control for resuscitation.
I think in this group.
Thank you.
I think in other groups, there's still a really big discussion about
Right.
Unfortunately. It's all right. I think that's
Well, they're giving me a promotion. Apparently, the director of acute care surgery. It's trauma PI. I saw it. So it was funny because when that came out, I was like, that's odd. Gotcha. I mean,
So why don't we start the lunch session since everybody looks like they're eating lunch? So it's awesome. That's great. So we have a Reboa lunch kind of like clinical educator, clinical excellence session. And really what we want to do is get to them. So I'm going to get out of the way. But we have Jill, Jonathan, and Ryan who are going to be speaking about cases and experiences that they've shared. And I have just a few slides that are introductory slides. And where's the advancer? Let's see. We're working this out. Thank you. And there we go. And I have a few slides that most of you are so aware of that are. So we know that bleeding, hemorrhage, shock, is an enemy. When it's an enemy, it's something we're trying to manage. And I think everything's negotiated with how much shock you have, how much bleeding you have, and what you need your catheter to do. But I think the Reboa family has really tried to adapt to that so that you can manage hemorrhage and you can manage resuscitation at the same time. The partial Reboa, which is part of this narrative, is the ability to have like blood pressure control, proximal control, and still perfuse the kidneys and the gut. And that's really an important part of what the design, what I would say intelligent design is. is so that this thing can allow you to take care of patients for a prolonged period of time. The term dimmer switch is something it's like you can turn the lights on or you can turn the lights off, but you can also dim them. And that's part of the intelligent design of this. When you think about where Time has gone with this, and I actually think as a community we need to go, is a culture of good data. I think Todd Rasmussen really highlighted that with his presentation, but getting good data that we can collate and we can collect and present and share with the rest of the world. And I think this community is incredibly elite in being able to do that. So there are centers of excellence at Time. And it's to be able to define, how do we do this? How do we take care of these people? What are the issues? What are the complications? But these centers of excellence are incredibly valuable. And I think some of the panel here really represents that. And then, when we think about, we have 7 alpha centers that are centers of excellence, but we have lots of centers that have used Reboa, and I think there's Reboa that's being now used widely. And as a community, we need to make sure that people understand how to use it, when to use it safely, what are the access issues, what are the removal issues. And so this is really becoming a challenge for this community. And then I would like to, so I'm a physician, scientist, surgeon, innovator, and I think one of the really challenges and champions for this is to transition from anecdote. It just can't be a case report. It just can't be like, oh, I had this cool case that I did, and I'm talking about it at the bar. Somebody said that, I think, last night. To data. We need real data, and we need real coherent data to be able to describe what we're doing and how it makes a difference. And so I think the panel here is gonna lead to that. And with that, I think we're gonna go to the transition from breaking the 30-minute barrier, which is the ghost of like renal artery and visceral artery occlusion, to things that, like, what can you do with partial Reboa? What can you do if you can open and close the balloon? How do you manage all of these things that perfuse the distal circulation while you still maintain like the hemodynamic control of the proximal? When I say proximal, cephalad circulation. So we're going to go into the case presentations, and we're going to start with Jill, if you're willing. If you're willing, okay. So I'm going to hand the
Good afternoon. So we'll do a little case to run through how we've utilized Reboa as an adjunct in our blunt agonal resuscitation, and talk a little bit about how partial occlusion helped identify bleeding sources. So just to give you some case background, this was a level 1 activation with an ETA of 6. The only information that we received was a 31-year-old male who was a pedestrian struck. His airway was unsecured. He had reported head trauma, hypotensive, and a GCS of 3. No vitals reported on the initial page. During our little pre-brief, we did get some additional information. The injury had happened approximately 20 minutes prior to the page, and the pedestrian was struck at about 40 miles per hour per report. He was unresponsive on the scene and was reportedly profoundly hypotensive. That was the only information that we received in terms of hemodynamics. So on arrival to our trauma bay, his airway was not secured. He was being bagged, but did have breath sounds with assisted ventilation. He had a faintly palpable femoral pulse, We were not able to auscultate or palpate a manual blood pressure. GCS of 3, he had some lateralizing signs with a non-reactive left pupil. His right pupil, though, was reactive. He had significant facial trauma as well as a femur deformity. So this, kind of standard severe blunt trauma patient. So we went through our standard blunt agonal resuscitation. We placed bilateral humeral interosseous lines for access as he had arrived with nothing. We started our blood product resuscitation, proceeded with finger thoracostomies empirically, and then gained right femoral arterial access with a 4 French micropuncture. All of this is happening within the first few minutes. Our initial arterial blood pressure was 36/21 with an excellent waveform. So this patient obviously in extremis. After he got a couple of units of blood in, we proceeded with intubation that was uneventful. We then moved on to our cavitary triage. His chest x-ray was negative, no signs of wide mediastinum or blunt aortic injury. His pelvis x-ray, which you can see here, was also negative. We had obtained our FAST prior to or sort of during intubation, so we knew that was positive, and we had planned to place a zone 1 Reboa. So what you can actually see here is the femoral sheath in place. We had already upsized while we were obtaining our x-rays. This is the Vanderbilt institutional protocol for Reboa. So, our patient met our criteria in terms of having a pulse. We do not place Reboas for pulseless patients, and then he was hypotensive. So place our arterial line, assess adequacy of response, do our cavitary triage to determine zone 1 versus zone 3 placement, and then upsize and place our catheter. So he was upsized to a 7 French sheath, and we placed a zone 1 Reboa. He's a relatively small guy, so 5.5 cc's in the balloon improved his systolics into the 100s from that initial 36/21. And we're, again, using that P-tip pressure sensor to guide our inflation volume. Here's actually what it looked like on our CT scan, so I'm going to call that adequate placement. So in the trauma bay, he received 4 of reds, 5 of plasma, some calcium, and some 3% for those lateralizing signs before we proceeded to our CT scan on the way to the operating room. Time from his initial arrival, just crossing the threshold to Reboa inflation, was 22 minutes, which wasn't bad. And then time from the Reboa inflation to the images actually obtained was 9 minutes, which is about standard for us. Our average is around 8 minutes from the time that we kind of move over and get our images. So let's see if this will play. It should. So here's his scan. You see our catheter in place, some kind of small volume hemoperitoneum. He had some low grade solid organ injuries. And then it had some, as you come down here, some pretty significant pelvic trauma with some active extravasation from the bladder, as well as a small extrav in the left pelvis. So one of the things we do to obtain our images is, let's see if I can go back. As you notice, there is contrast. I'll see if I can get it to go play one more time. Probably not. So the way we do this is that we obtain our head and C-spine imaging with the Reboa balloon inflated. And then as you inject contrast for your CT scan to get the chest, abdomen, pelvis, we have somebody deflate the balloon. That results in about a 60-second period of hypotension. We're prepared for that. The team's prepared. It'll be fine. The balloon will go back up. They'll be fine. So as soon as the images are obtained, we've got someone there to reinflate our balloon. At that time, we were doing full occlusion and then transitioning to partial. So this is his operative course from a hemodynamic standpoint, which I think is kind of interesting, as well as a list of all of his injuries that we ultimately identified. So the pink kind of at the bottom was our distal sheath pressure, And then the lighter purple was our P-tip pressure. And so as you can see, we had occlusion for full occlusion there. And then shortly after, we made incision about 15 minutes or so, packed, identified that we didn't have any, ongoing huge hemorrhage that we needed zone 1 occlusion for. So we transitioned to zone 3 partial occlusion at that point. And you can actually see hemodynamically the point at which we do this. So their distal pressure jumps up, kind of minimal impact on the proximal. And then our balloon was fully deflated after another few minutes, which you saw no effects from going from partial to complete deflation of the balloon and removal. And that was our incision time was right there. So overall, he had 57 minutes of total, of complete occlusion, and then a 41-minute partial Reboa time for a total of 98 minutes. He had a really complex intraperitoneal bladder injury, and that's what was the predominant source of hemorrhage. So we did a bladder repair there, took out some bucket handle injuries of the ileocolic and sigmoid, took out a spleen. After that, he went to interventional radiology and had a little gel foam embolization of the left internal iliac artery. That was really not actively bleeding anymore at that point. So kind of course overall. So initial placement of zone 1 to complete inclusion, take our balloon down to obtain our imaging, which guides our operative course, helps us focus in very quickly on where we need to be. We, at the time, were reinflating to complete occlusion and then going down to partial in the OR. We've really changed that practice. Now we're trying to go to partial right after the CT scan or even initial partial occlusion with the new catheter. So we've changed our protocol a little bit. He had no Reboa-related morbidity. Unfortunately, because of his prolonged downtime, he had had a pretty significant anoxic injury. So the family ultimately decided to withdraw. But I do think that the Reboa certainly facilitated us, number one, getting imaging to rule out devastating intracranial hemorrhage before we devote a lot of time and resources to these patients. So for us, Reboa really helps get that head CT safely. And then also obtaining our imaging to guide our operative strategy. Again, it's not replacing going to the OR, it's just additional information we obtain on the way to the operating room.
So, excellent presentation. If you're I have two quick questions, or maybe they're pair in pair. So deciding if somebody's like brain dead with imaging, I don't know. I don't know how to do that. It's a clinical diagnosis. It's not really an imaging diagnosis. Yeah. But if the catheter's up, how do you negotiate with radiology around how to get the rest of the imaging for the visceral aorta? And that's just, so do you put the catheter down for a couple of minutes, get the CT? Do you just, it's just an interesting kind of, how do you do that?
Yeah. Our system evolved and, frankly, we didn't negotiate with radiology. We just told them what we were going to do because they're not in the scanner. So the whole point is the team is in the scanner making these decisions and managing the catheter and the balloon. So, the head CT and the C-spine are pretty quick and easy to get. And there's really no point in getting CT imaging if you're not going to have the contrast. I mean, yes, it might show you a few things, but the reason our protocol evolved was we could not get our interventional radiologists to come in without imaging. I would love if they would, but they just wouldn't. And so we had to figure out a way to safely get the imaging with the Reboa catheter, particularly the bad pelvis, zone 3s. And so, we just kind of worked it out. And honestly, it works relatively well. Just put the balloon down, wait the 1 minute, then put it right back up if you need to partial or full as they tolerate.
Other questions from the, I see Dr. Moore coming or Dr. Rasmussen, either one.
Question about your pressure monitoring. Did you show pressure above and below the balloon? And do you do that? Do you assess below as well?
Yeah, so the distal arterial line's off the sheath, and then the proximal is in the P-tip.
Gotcha. Do
We
you find that useful? And then I'll sit down. Maybe you could comment on your transition to the IR embolization of the left internal iliac. Did they use your sheath? Did the balloon come down, and how that went?
Yeah. So we took the catheter out completely in the operating room, and then our interventional colleagues will use our sheath or exchange our sheath. We've kind of worked out a relationship with them that they will let us always manage our own sheath. But so they did utilize ours to do that gel foam on the left.
That's been my experience as well. Interventional radiology is not willing to use catheters that we have placed. Our vascular colleagues that we work with very closely, they're willing to use our sheaths because I don't know what the hangup is or what the difference is, but that's been my experience as well. I don't know if Jonathan has the same.
Yeah, for whatever reason, they prefer to re-stick, even if it's in like the affected side or whatever.
Mhm.
They want their own stick. I think it's so they can manage their procedure from start to end.
So, Gene, you look like you have a question.
Yeah, well, it was a nice presentation, Jill, but I would call your attention to the waveforms up there. We've discussed this several times at this meeting. If I interpret that correctly, your initial proximal aortic pressure is 170. That's neither good for your brain,
right?
And if you got a torn aorta, it's going to blow it right out. I've seen that happen. So I just caution us, and it raised the question of, do we inflate the full inflation, come down, or we do partial and go up until we achieve the appropriate level? And this would suggest that, again, in blunt trauma, I don't care if a guy with a bullet through his iliac artery has a pressure 170, but in blunt trauma, it may be better for us to be inflate to target rather than going full, unless they're undergoing CPR.
I totally agree with you. And that we've changed. We are inflating just to the proximal goal of about 90 to 100. I don't want to shame our anesthesia colleagues. They were confused as to which pressure they were looking at. And so the reason that proximal is so high is they saw the distal of 50 and gave some pushes of things I would have preferred they didn't.
So I think that's an excellent comment about if you have too much monitoring, anesthesia, and sometimes you need to make sure they know what they're looking at.
Yeah. And this was
So-
November of 2021. So it was very early in the partial, kind of practice. And so we have worked out some of the kinks here. And so it was a third-year resident who looked at a systolic of 50 and gave a big slug of little baby epi.
So Greg, a quick comment maybe, and then we need to be sure we move on to our next speaker so we can.
Yeah, just my only comment was, when we're clamping the supraceliac aorta or putting a balloon up for that period of time due to whatever reason, surgical misadventure or aneurysm that's difficult to fix or whatever, we see almost universal, like 100% shock liver, severe liver shutdown, renal failure, et cetera. And when you have clamp time or balloon occlusion times like that, how do you do that and avoid that problem?
Yeah, no, I think that's an excellent point. That's why the 30-minute barrier was there, obviously. And we have not found the shock liver and the acute kidney injury in clinical practice for us. But I think one of the predominant strategies is going to that initial partial with just a targeted pressure of 90 to 100 rather than the full occlusion. And we have moved our protocol that way.
So thank you. Respectfully, we're going to move on to our next speaker. If we can get those slides queued up. I'm just not sure if we got all that set up. Let's see.
Thank you all very much for the opportunity to present here. So our patient similarly is a 33-year-old male. He was involved in an MVC. He actually came to our emergency room and trauma center as a level 3 activation, being the most lowest tier activation for trauma. And all he had was an isolated femur fracture. But during the initial workup by the ER, they found that he had a systolic in the low 90s, repeat is still low 90s, and so they activated us a few minutes after he came in. His chest x-ray, pelvis, and FAST were all negative. And so they initiated 1 unit whole blood while they did their initial triage. He stabilized out and he went to CT scan, in which they found a proximal femur fracture, some involvement of the acetabulum, and a T12 compression fracture. This was all read by the radiology residents at the time. So they put him back in the room. They do their thing. They call ortho to come put the leg in traction, et cetera, et cetera. And we get a phone call about 2 hours later on saying his systolic is now 80. His heart rate's 120. And because of our guideline, it says that if you drop your pressure, transient responder, we think that you may have truncal hemorrhage, you get common femoral artery access. So we do that while the rest of the team is putting in, while the team is putting in the common femoral access. We refast him, it's all negative. We reshoot his chest x-ray, make sure we haven't missed something, that's all negative. However, we go back with the attending radiologist and we look at the pictures on the CT scan, and we actually find that he has extravasation from the pubic symphysis, and IR is activated. And so if we take a look back in a couple slices, we don't have fancy CT scanners like Vanderbilt does, so I can't scroll. But you have a small to moderate hematoma and then those active areas of extravasation. So what do? We gave him another unit of whole blood to resuscitate him. We called in IR and we packaged him up and we're waiting there and we're waiting. And we're like, why haven't they called yet, right? Well, then his blood pressure drops again to systolic at 88. We call our MTP. We say now he's bleeding from the pelvis. He's dropped his pressure twice now or 3 times now. And we start transfusing him we start bolusing that unit of whole blood. And at this time, we call IR and say, are you guys ready to go? Where are we going from here? We have a patient who's dropped the pressure a few times. We can't stay in this, the trauma center anymore. Are we going to IR or are we going to the OR to do some sort of pelvic packing, XLAP, et cetera, et cetera? But it turns out the IR is actually called anesthesia and said, well, the guy's sort of hypotensive and maybe we want some additional help in IR to do the case. So knowing that it's going to take a few minutes to get IR ready, knowing that we have partial rabo available to us, we decide that because he has a more isolated pelvic injury, the best place to go is actually IR in our institution where they can actually do all the procedures. And so we place the partial rabo up to zone 3, and we actually increase the balloon to get a partial occlusion only. And so very similar to what we just discussed, instead of going to complete occlusion now, we actually target for partial occlusion. We want a proximal pressure just enough to stabilize the patient, but also allow some flow to go through. And so we put him up over 100. The distal map happened to be less or around 35. And the patient was taken to IR shortly thereafter, about 15 or 20 minutes. During that time, we titrated the occlusion. And within 30 minutes, we started to titrate down our occlusion. And within 90 minutes, the rabo balloon was completely out. During the 2-hour procedure, he got an additional 4 units of blood, 2 packed red blood cells and 2 plasma. And so what this showed us was that we can have an extended safe occlusion time and allow for additional time for endovascular definitive hemorrhage control. So when we're looking at a patient, our institution, we don't have ready access to a hybrid room 24/7. It sometimes takes IR quite a while to come in. But with partial rabo, we now don't have to rush to the OR and pre-peritoneal pack everyone or XLAP everyone. We can give our anesthesia colleagues and IR colleagues an opportunity to mobilize all the resources, get all their stuff set up in IR in order to receive our patient and give them what we feel like is the best treatment option, which is the endovascular approach to stop an isolated arterial bleed in the pelvis. We learned that instead of going from complete down to partial, if we can just get a partial occlusion, which is keeping them safe and minimizing the amount of blood loss, then we can actually get them there without having those complications like we spoke about, which is shock liver and everything, because there is no complete occlusion time anymore. There's only partial occlusion. There's still always partial flow. How much flow is required? We're not sure yet, but there's still always some sort of flow going across, and ultimately allowed us to stabilize the patient for IR. Thank you.
So, thank you for a great presentation. You know, I'm struck by those of us who've learned how to cut people in half. Like, we shouldn't be afraid to use a catheter. You know, it shouldn't be that hard of a barrier, and we just need to get people trained to do it. So I think it's like a great discussion. Like, do you need to bring in IR? You know, probably you're technically competent enough that you probably don't. You know, and then I just mean that's so. Questions from the audience, real quick, and then we want to make sure we have time for our last presentation.
I have one for you.
Yes, ma'am.
How do you manage your balloon in IR? Are you titrating it down, or do you let them use your balloon?
Oh God, no. We send the resident in there. There's too much radiation now. So we do it. So every so often we just check in and see how they're doing. And the other thing we learned even from our Roboa days is that waiting for definitive hemorrhage control before coming off of the balloon is too much time. And so once we're in a safe space, we start deflating. And so we send the resident in there, me in there, and we come down 1 cc or 2 cc's at a time, stabilize, come back in 5 more minutes.
So that was one of the issues I had with one of our talks earlier today is not the in part, which and the drama part, which is, but it's the getting out part. And I think we need to be sure we pay attention to that.
Absolutely.
Thank you. Okay. So thank you. Great presentation.
Okay, I'm going to describe a patient from my time at Denver Health. This is what I thought at the time was a 60 to 65-year-old male that was presented after a high-speed motorcycle crash without a helmet. He was unresponsive at the scene, and his airway was actually obstructed at the scene. He was driving down, had a skull cap on. Skull cap came off, and he swallowed his cigar. Or didn't swallow, he inhaled his cigar. And so the medics in the field, they were able to get the cigar out in the field. His initial blood pressure was within the 70s over 40s. He was bradycardic. He came in with scalp lacerations, had a suspicion for a traumatic brain injury. On our evaluation, he had bilateral pneumothoraces that we found on EFAST, but also on chest x-ray. So we immediately placed chest tubes in the trauma bay, and trauma is a recurrent disease. So he already had a chest tube scar on the left side. So we went above that, and we were able to get decompress both bilateral pneumothoraces. At the same time, we placed left subclavian cordis to start our massive transfusion protocol. We were obtaining right common femoral arterial access, and he had an inadequate response to his resuscitation. So this triggered us to put in the P-Roboa Pro. And my practice in this sense, he had a negative fast at the time, but I was going up to zone 1 first. I wanted to reestablish blood flow, so I started in zone 1, and as I described earlier, slowly titrated and inflated the balloon and watched that pressure increase. So we put it into zone 1, and we really did this as we were resuscitating the patient with our massive transfusion. So that includes 4 units of low titer whole blood, and then 4 of red, 2 of plasma buckets that come after that. I didn't want to intubate him. Yes, he had a lower GCS, but he still had a SAT that was fine. I didn't want to intubate him and give him the medications because I didn't want him to arrest. I knew that I had bilateral pneumothoraces, but I didn't have a chest that was full of blood, and I didn't want to make a hole in a chest I didn't need to. So we resuscitated him, got him to a point where I got the Roboa into zone 1. We gave him the induction medications, started to see his blood pressure drop, and inflated in the balloon. We were able to intubate him, and we did a more thorough exam, and he had a palpable defect along his thoracic spine. I'll show the CT scan in a minute, but anyone in this room that's felt that step off, we always run our hand down the back. And we're like, oh, no step offs, and keep going. I stopped and audibly gasped when I ran my hand down this gentleman's spine. We used zone 1 occlusion to really enhance our resuscitation in the trauma bay, as I said, to get us to that point of intubation, but then also to get us to the point of, am I missing something else, right? I got bilateral pneumothoraces, nothing operative that I know of. I still have a hypotensive patient. This is, in my opinion, sickest patient in the hospital with a clamp on his aorta. I need to go somewhere. And that pit in my stomach is there, listening to all my mentors, some that are in this room that were like, you need to go to the OR. But I didn't know what operation to do yet. So it did facilitate us getting to the CT scanner. He got packed red cells, plasma, whole blood. And while we were resuscitating him in the bay, I got to the point that I could move that balloon from partial zone 1 to partial zone 3. So we got to the CT scanner, and you can tell I'm in partial zone 3 here, because as you can see down the left common iliac, there is contrast there. And I did not augment the balloon in the scanner. I knew I had partial because we had a palpable pulse on that side, but also we had sheath pressures, as I was talking about before. I don't have fancy imaging to show you the tracings. And again, I don't target something below the balloon. I just like to know that there is flow below the balloon. And this kind of shows that left iliac lighting up. But here's the CT scan that shows he has a nasty thoracic spine fracture, but he also had a severe traumatic brain injury. And this subdural hematoma was in different spots than I'm used to seeing, right? We see subdurals all lateral and kind of compressing the brain laterally from one side. His was like posterior and superior and was pushing down. So our neurosurgery APPs were in the CT scanner with me. They gave a call to their attending at home who was reviewing the CT scan. And in the meantime, I took the patient up to the ICU to continue our resuscitation. And what you can see on the far right is that he had a bad pulmonary contusion on both sides, and he still had a little bit of a retained hemothorax on the right. And I'll talk about that in a moment. So in the ICU, we started vasopressors. I knew I had neurogenic shock at the moment. We were hypotensive, bradycardic. We got the Reboa down and out. And then the neurosurgeon said, hey, let's take him for a cranie. On the way to craniectomy, he dropped his pressure again. I reinserted a different Reboa because I already took that one out, threw it away. So I had to put another one in. And we started with zone 3. And I and my fellow went to the operating room with the patient. We managed the Reboa in zone 3 and kept it partial, like a little more partial, a little less partial. We never went to really full occlusion in the operating room. And the anesthesia continued to resuscitate the patient, and he required another vasopressor. And this, to me, should have tipped me off at this point. About a half an hour later, they're done with the craniectomy. They had gotten an ABG. It came back, and he's got that base deficit of 9. And boy, does that really put that pit right back in your stomach. So at that point, chest X-ray was done. I didn't have the ultrasound ready in the operating room, and it showed this chest X-ray. And you can see I have a massive hemothorax on the right side, despite a well-placed chest tube by our senior resident. That chest tube hadn't drained anything, and this triggered us to say, okay, we still have a live patient who they've done the craniectomy. He has not died from his craniectomy. I did a right thoracotomy, and he had 2.5 liters of blood in that right side. I put a chest tube in first to kind of get us to the prepping point. What I found was that the thoracic spine injury actually decompressed itself into the right side. He had no chest wall injury, no pulmonary injury on that side that was actively hemorrhaging. His bony fractures were actually bleeding into that right side. So I bring this up as a case to say, hey, yay, we got the Reboa, partial Reboa got me through to the CT scanner, got us through intubation, got it as an adjunct, and then got me to the operating room. But to not forget our principles that our mentors have always put into us, right? Get that base deficit. Always think that the patient's hemorrhaging, despite somebody being bradycardic and on pressors. It's something that I kind of took away from this. So if we look at the same kind of graphically, he had 93 minutes of partial Reboa between the trauma bay CT scanner and ICU, and then he had 97 minutes in the operating room in zone 3, and really only 4 minutes of complete occlusion. And that complete occlusion was right at intubation when he dropped his pressure. I went all the way up to complete, let him recover from the induction medications, and then I came down to partial there.
So great case, and thank you for sharing that. And I would just say anything worth doing once is worth doing twice. That's my questions from the audience or the panel here, or comments?
I'll shoot one. Thank you. So I think in both y'all's cases, we've seen the use of Reboa in the CT scanner. You've mentioned going to complete occlusion, then dropping it for your images. You did it straight with partial and never dropping it. Is there a discussion or an algorithm or a change in how you guys run that CT, or is it just a standard protocol and you still get the same fine images?
So far, we have not augmented the protocol, the timing between contrast installation and the CT scan. They haven't found that they've had to change that. But again, they're targeting that right at the arch, right? And so they're just getting the CT. So I haven't seen any decrease in the quality of the CT scans below the balloon. And when sitting with our radiologist, because we walk right over there after and go to the CT, go over the CT scans, they haven't said anything differently. We've seen extravasation, we've seen everything light up below the balloon.
But I would say this is kind of a recurrent theme that I didn't appreciate until even this discussion. So I work very closely with one of our IR folks at Duke, and like developing the sequencing and timing of how they shoot and how they cut, the contrast and how they is actually really important to get information. And I think Reboa adds a new wrinkle into those kinds of imaging protocols that I guess I didn't really appreciate. Yeah. But yes, I think it does.
So Ryan, you said 2 liters of blood came from the spinal fracture. My question is, how did you manage the spinal fracture regarding bleeding? What did you do to make it stop bleeding?
changed my pants first.
Okay, good idea.
And there's nothing to sew, right? And so I called my neurosurgery colleague back in. I said, "Hey man, straighten out the spine, just femur fracture, right? Bring it out to length. It slows down the bleeding." He's like, "No, it doesn't work in the spine. Take bone wax." So we shoved a bunch of bone wax back there. We put some Everest. I tried to close the pleura, but it's all friable and everything's sticking out in front of me anyway. But it really tried to stop it with topical, didn't do everything. And then the bone wax helped. It allowed us to put 2 chest tubes in and close the chest.
Thanks.
How did you manage, or how are all of you managing the sheet? We talked about it before. It's sort of simple,
Right.
but maybe not simple. I mean, how do you do?
So Todd's not at the microphone, but the question, if people couldn't hear it, is how do you manage the sheet? Sorry.
It's a great question. It's something that we've talked about amongst centers, right? So it's just like starting fentanyl, right? It's easy to start it, hard to get it off. So it's easy to throw on the next presser. It's really hard to take them all off, right? So how do we skip the boring part, like closing the abdomen and getting out the sheath, falling into that part? I think guidelines and using technology to our advantage. So one of the things that we implemented before I left Denver was that putting a epic order in that said there's a sheath in, and it triggered a whole cascade of stuff, right? So we ordered the Reboa sheath, and it triggers the nurses to get triggered to call the residents at 4 hours. The trick now is to get that order placed. And so somehow we have to make it really automated that when you're in the trauma bay and you put a Reboa in and they put it in the trauma timeline, that it's a checkbox and that just populates everything else so that it's dummy proof. But I think we own it.
Yeah.
I think we own it.
Yeah, we have a removal protocol. We don't remove it in the OR, the sheath. We'll remove the catheter, but we'll check our coags, remove it in the ICU, and then it's just a standard protocol. It's pulse checks every 15 minutes, then for an hour, then every 30 minutes for 2 hours, and then a duplex at 24 hours. And I agree with you. The sheath management is where I think a lot of the complications that gave Reboa a bad name in 2014, 15 was sheath complications.
Things to remember with that sheath, though. You got to keep something running through that side port. I mean, this is for the non-vascular surgeons, right? Vascular surgeons know all this stuff. Trauma surgeons, we always hooked up the sheath to an A-line, right? So there was always some sort of flow that was going through it. But if you put the Reboa in and you don't keep flushing that side port, you can get complications from your sheath.
So I think sheath management is one of those things that has given the whole Reboa narrative. It's because a lot of people don't. Interventional cardiology or interventional radiology learned this 20 years ago. Vascular surgery learned this like 10 years ago. Like we just need to kind of get trauma respectfully to kind of, which sheath management, sheath access, entry, closure, and I think which Gene highlighted, which is, this kind of wave of thrombotic kind of cascade that happens. And if you just leave a sheath in when somebody's got this inflammatory syndrome, you're going to get and it has nothing to do with the access. And it has nothing to do with the fact that you save this patient's life. But you're still going to deal with some kind of sheath problem. So anyway, it's a great discussion and something we just need to get kind of our head wrapped around. One final question.
Chris Ramos, Atlanta. Obviously, the access is obtained when patients are in extremis. Do you guys obtain access site angiograms when you're done? And depending on the location, do you consult your vascular interventional colleagues to do a percutaneous closure?
I have not done routine angiography after removing the sheath. What we have done is even before, we have not done angiography. But after removing the sheath, we've done bilateral lower extremity duplexes to compare the sides, thinking that there could be, if you put the Reboa in, there could be an iliac problem on the other side as well, or even with just putting the sheath in. So we've done bilateral duplex arteriograms within 24 hours after removing the sheath. If something's found there, then we either move to CTA or to formal angio.
So great questions. Thank you all. And respectfully, congratulations to this very distinguished panel. We need to wrap this up because I think the meeting, we're beyond the hour. And I want to thank everybody for participating. Great discussion.
No, I understand. Yeah, certainly. Is that right? Is that right? So you put it in this. What size
you think it's an accident, just come down.
Yeah, I'll introduce. So it'll be Justin and then Farhan and then Justin. Oh no. He's trying to get his presentation all set up. All right. In my ongoing effort to disorient and confuse, we are going to pick up with innovation in resuscitation and critical care as on the schedule. And Dr. Araby will be speaking in this session. But first, we have Justin Richards speaking on organ dysfunction after endovascular resuscitation. What happens after the balloon is deflated?
Good afternoon, and let me speed the next one to just thank Chuck and Rishi for organizing this event and for the wonderful evening last night. So again, talking a little bit about organ dysfunction, organ failure after the balloon is deflated. So I have no financial conflicts of interest to disclose, and so some of the brief objectives, at least in the next few minutes, being to review organ dysfunction, multiple organ failure after trauma, identify how reperfusion upon balloon deflation can affect specific organ system function, and discuss some potential early management strategies of organ system failure after endovascular resuscitation. So really, I think with organ system dysfunction, it's all in how we define it. And at least when it comes to single organ system dysfunction, there are a lot of very well-known, well-utilized, well-described common single organ system dysfunction scores. However, when we're talking about trauma patients, it becomes a little bit more confusing because there are a few different scoring systems that exist when we actually consider patients as having organ failure as another complicating factor. But at least I want to give credit and acknowledge Dr. Moore and their group in Denver with the Denver Organ Failure Score that they described a little more than 15 years ago, almost 15 years ago now. Because I think that's at least one of the most well-validated scoring systems for trauma patients. And it's been shown to correlate very well with mortality. And this is calculated as a summation of organ system dysfunction scores from the cardiac, pulmonary, hepatic, and renal systems. And it's calculated at least 48 hours after ICU admission. And from their work and the work of others, we've known that the incidence of multiple organ failure in trauma patients, moderate to severely injured trauma patients, is about 10-15%. We've shown that at our institution as well in a study we published just a few years ago. But what's a little bit more discouraging is from Angela Swaya's work, which showed over about a 2-decade period that the incidence of multiple organ failure in trauma patients was decreasing. The mortality attributed to multiple organ failure actually really hadn't changed in 20 years. So this is still a very morbid and burdensome problem. The other challenge when we talk about organ failure in trauma patients is that we say, well, patients have to live long enough to get multiple organ failure. And oftentimes the converse can be said of, well, the patient gets more, organ failure, but at least they're still alive. And again, at least for a lot of these organ failure scoring systems, they're calculated a day, 2 days after admission. And we say that organ failure, organ dysfunction, abnormal organ laboratory values within the first 24 hours is just a function of resuscitation, or it's a reflection of the severity of injury. That's not really organ failure. And when it comes to hemorrhage, and specifically with patients who receive endovascular resuscitation, these patients are dying really early. A majority of them are dying in 24 hours. So they're never actually living long enough to be captured as having multiple organ failure. I think back to a few years ago when during one of our Monday morning conferences with Dr. Scalea, we were discussing a patient who had multi-system injuries, had gone to the operating room multiple times in 24 hours. They were acidemic, had a bunch of electrolyte abnormalities, weren't making urine, they were coagulopathic on multiple vasoactives, and they ultimately end up dying. And I said, this is multiple organ failure. It's just never going to be captured and recognized as multiple organ failure because we say trauma patients can't get multiple organ failure this early. And Deb Stein and I looked at each other and said, this is hyperacute multiple organ failure. And so this concept of, these trauma patients with hemorrhage are dying early because it's failure to resuscitate, I had a really hard time understanding. And this concept of hyperacute multiple organ failure and trying to define what the organ system dysfunction is going on really early after injury, I think has become really interesting and important. So some of the things that we know that go on, at least during the reperfusion stage of endovascular resuscitation, and from some very good animal evidence, and this coming from the group in Sweden, where they exposed, and this was zone 1 Reboa in a pig model, but they exposed the animals to 15 minutes of occlusion, 30 minutes of occlusion, and 60 minutes of aortic occlusion. And they measured their biochemical markers after each time point. And they found that, not surprisingly, there was worsened systemic pH, but that specifically this did not normalize in the animals that were subjected to 30-minute and 60-minute occlusion time. Same with worsened liver function, worsened renal function, and worsened markers of oxidative stress that continued to increase significantly in specifically those animals that were subjected to 30 and 60 minutes of aortic occlusion. So what does this mean clinically? Because I think this is actually a really hard thing to study in not only our patients, but those patients who are being being subjected to aortic occlusion. There are a lot of confounding variables, which we'll talk about in just a moment. But specifically the cardiovascular system, and I include blood failure. There was a talk earlier today on coagulopathy. I'm not going to discuss the specifics of coagulopathy, but I think it's really important to at least recognize that coagulopathy is organ system failure. Whether it's a cardiac system failure or hematopoietic system failure, it is still an organ system failure. The Thor Network has been really, I think, at the forefront of acknowledging that blood failure, coagulopathy, is an intrinsic part of the organ system failure that's occurring very early in these trauma patients. And I also include vascular failure because the blood vessels are failing in these patients. We oftentimes think that blood loss is just vasoconstriction. But in fact, we've known for almost 100 years that hemorrhage, hypotension is not vasoconstriction. In fact, it's vasodilation. Carrie Sims' work looking at early vasopressin administration in trauma patients, I think, has kind of highlighted the fact that we can potentially administer a medication, an intervention to counteract some of this vasodilation. Doesn't really improve mortality, but it might have other improvements in terms of fewer and volume of blood product administration, overall volume administration in the first 48 hours and out to 5 days in a lot of these patients. I'm going to skip over talking about the pulmonary system, if only because I think it's pretty well known that at least the pulmonary complications we see after trauma is really a reflection of the severity of pulmonary injury. And at least a lot of the animal data that we have with aortic occlusion is showing there's not much of a change, at least very early on in these animals and their pulmonary system function. But when it comes to the hepatic system, this is something that's not very well described. Not very well described in trauma overall for patients who go on to develop hepatic failure, but in fact have not had an acute liver injury or specifically a traumatic liver injury. It still ends up occurring in about 10% of patients. And this is some older data, but admittedly, it's some of the best data that we have. Not surprisingly, these patients have profound shock. They're hypotensive. They have an elevated lactate. And interestingly, in one of these case reports from a handful of years ago, was that all these patients with hepatic failure who had non-hepatic trauma ended up having a pelvic fracture. That's not to say that all patients with a pelvic fracture end up getting hepatic failure or that all patients with a hepatic failure must have a pelvic fracture. But specifically when it comes to REBOA and endovascular resuscitation, I think there's a common theme. A lot of these patients with a pelvic fracture are likely to potentially get endovascular resuscitation. And what are some of the complications, regardless of whether they get a REBOA or not, are we seeing in these patients when it comes to liver failure? How can we treat it? I think there's a lot of enthusiasm for extracorporeal support. We described at our institution a few years ago, at least the use of molecular absorbent recirculating system for severe liver trauma. It was a small number of patients, but described at least a 60% survival rate in those patients. Still don't know the time to institute that therapy or exactly in which patients. And as Tim Williams described yesterday when talking about some of the automated intelligence use of endovascular resuscitation, but the renal system, renal failure is probably the best described, at least complication in terms of endovascular therapy, partly because of the aortic occlusion, potentially because of the increase in afterload, the cardiovascular effects, increased atrial natriuretic peptide perhaps, and all of that potentially being theoretical. But the impact of aortic occlusion on the renal system has been pretty well described. Depending on how you define, again, this is all about how you define organ system dysfunction, somewhere between 10 to 20% of patients who are receiving a REBOA end up having some type of acute kidney injury. Joe DeBose's work showed about 4% ended up going on to have dialysis, but in fact, is it the REBOA that's affecting renal failure, or is it the fact that these patients are just really severely injured? And this paper from the group at Yale, which looked at the National Trauma Data Bank, I think really identified that, there are a lot of complicating factors that are going on in these patients, things that we just can't identify, unmeasured confounding variables. And is it that they had a REBOA for how long they had it, or is the fact that they're just really severely injured, which we know these patients are getting REBOA, they're getting endovascular resuscitation because they're in hemorrhagic shock, because they're severely injured. And again, there are a lot of other confounding factors that we can't identify. And I think what's really important and helpful to realize is just because these patients are this severely injured, we're already being set up at risk for certain organ system failure. So I think the things that we need to be looking at in the future, one, I think we need to be able to better define this early organ system failure. This is occurring. This is not failure to resuscitate. This is hyperacute multiple organ failure. I think we need to recognize this organ system dysfunction. And just like we've talked about today, trauma is a time-sensitive disease. Hemorrhage is a time-sensitive disease. Multiple organ failure is a time-sensitive disease. And if we can recognize this early enough, are there potential therapies that may help manage that organ system failure, or at least give the body a chance to recover from its initial insult? So with that, again, thank you so much for the opportunity to discuss this, and look forward to any questions and/or discussion.
That's a great talk. Lugna from Wake Forest. One of the things that had been seen clinically, I know out in California, when they started doing at least partial and prolonged occlusion times, was pretty profound hypoglycemia. And I just was curious, in your review of the literature and what's out there, have you seen that as a refractory hypoglycemic state that is very difficult to manage. And then also thinking about, your point about how to ameliorate the ischemia reperfusion injury is a great one in pharmacologic adjuncts. Anything in your sort of review of this about mitochondrial dysfunction and how to lessen the overall burden of that?
Yeah. So to your first point and question about the hypoglycemia, clinically, do we see hypoglycemia? Yeah, especially in those patients that have had the profound liver injury insult. And I can think of a few cases in the last few years that we've had, not even necessarily patients that got a Reboa, but those that went on to have profound hepatic dysfunction. Kind of the first thing that set us off was all of a sudden now they're profoundly hypoglycemic. And we're really having to support that. Then we see their liver enzymes go up. And I think that's an early marker. Unfortunately, when it comes to the critical care literature, we look at hyperglycemia. That's in fact, that was our study on organ failure that we started to see, our incidence of organ failure is pretty much the same as what the Denver group described. But we're not looking at hypoglycemia. We're not looking at the variability in blood glucose. And that's probably the biggest marker for some type of inflammatory response or organ system dysfunction, is that variability, not necessarily the hyperglycemia, but the glucose that goes from 40 to 180, then down to 100, back up to 250, and that variability. The mitochondrial dysfunction, yes, it exists. Ways to ameliorate it, I don't think we've entirely been able to show it. I think there's a lot of interest, and I've kind of fallen into the boat of, yeah, this is a function of blood vessel failure early in trauma, endothelial dysfunction, failure of the glycocalyx. That leads to coagulopathy, worsened acidemia. Whoever can figure that out is going to enjoy retirement on a beach in the Caribbean.
Todd, I think keeping in mind, I appreciated your point about the baseline level of organ failure in these patients, even without Reboa or some of our resuscitative adjuncts like this. It drew to mind a paper by Kevin Chung and Ian Stewart. Some of the group knows, or some in the room know this. They did, I just looked it up, and they looked at combat casualties, severely injured combat casualties over a 5-year period. And this was not Reboa, this was sort of a registry-based study, and the incidence of AKI in injured casualties was about 15% baseline. Those are not necessarily patients who had Reboa. It's just, it goes to your point of these patients, a subset certainly will develop this multi-system organ dysfunction, if not failure anyway. So it's a good point. I appreciate that.
I think the hard part to that is we know just by nature of these injuries, it's almost like traumatic brain injury. We can't do anything about the primary injury, but we can help mitigate secondary injury. And I think when it comes to organ failures, we know there are certain patients who are going to go on to develop pulmonary failure, renal failure, hepatic failure. We haven't described it all that well. The challenge is you get a group of intensivists and nephrologists together and say, when should we put people on renal replacement therapy? And there's a lot of disagreement. And that's kind of the challenge, is how we can identify them early and when right patient at the right time with our therapies.
Justin, as you know, we've seen a little mini epidemic of very severe refractory hepatic failure in patients that just haven't had liver injury. And it strikes me that some of this is that people are living that used to die, right? We now, not routinely, but we commonly salvage people with a pH, an initial pH of 6.7 or 6.8. And that wasn't a thing until recently. And I think some of this is not, maybe most of this is earlier use of blood and not so much crystalloid. So these people are getting through the resuscitation in a different way. And so, it makes me wonder how much of this is really ischemia, how much of this is reperfusion. And, the follow-up question then is should we have a bigger role for earlier mechanical support, if for no other reason than to sort of try to modulate the inflammatory system, which, as you know, I think CRT does. And is that a better strategy for trying to salvage these really sick people, Reboa, no Reboa?
I think you're exactly right. And I had a
Of course
similar
I am. Yeah. You work for me.
I do have to go to work tonight. I had almost the same discussion a few weeks ago when we had the patient on 5 South who had liver failure. He was there. It was a gunshot wound to the abdomen. I don't think it was actually a liver injury. But actually 2 bouts of severe hepatic failure, recovered from the first one, ended up getting septic shock, and a couple weeks later The embarrassing part is I admitted him the first time I was in the intensive care unit, then he died the next time I was in the intensive care unit. But he ended up going on to get this profound hepatic failure. And the nurses were asking, all this extracorporeal therapy, why are we doing this? And I said, actually, I think the answer to this is probably doing it a whole lot earlier. It's just trying to figure out who those patients are. And I wonder the same about some of these people with bad pulmonary injury, long bone fractures, putting them on ECMO as soon as you can to at least let the lungs heal, fix your extremity injuries. Do they need renal replacement therapy? They might. I don't know who those people are exactly. I think there's a lot we can work on in trying to figure it out.
Yeah. There, for the residents, there are 4 or 5 research projects for you. Hop on it. Make you famous. All right.
All right.
Thank you.
Thank you, Justin. So for the next talk, we'll invite Dr. Arabi to the podium, who is going to help us answer the question on everyone's mind: who should be doing Reboa?
All right, thank you. Just wait for the slides to pull up. All right, so a bit of a controversial topic. Thank you for everyone for the invitation to speak. Thank you to Chuck and Rishi for inviting me here. I have no disclosures pertaining to this talk. So in 2017, as I'm sure everybody in this room knows, a lot of the people who wrote this are part of the society as well. There was a joint statement by the Committee on Trauma, the ACSCOT, and ACEP regarding clinical use of Reboa. And some of the highlights from that were that Reboa should be performed by an acute care surgeon or an interventionalist, namely vascular surgeon or interventional radiologist trained in Reboa. Acute care surgeon must be immediately available to definitively control the source of bleeding. Reboa protocols should be developed in conjunction with vascular surgery. Reboa should not be placed in EDs in institutions where the patient cannot receive definitive surgical care, and that formal training really requires attending the ACS BEST course. So not surprisingly, this raised a flurry of written and other responses. Allen et al. Said ACEP would do well to advance the care of traumatically injured by rejecting the limitations recommended in the statement. DeBose et al. Asked for more participation from military data and unique perspective in the analysis. And Lassim et al. Said that citing only one proprietary training course, the BEST course, that does not currently accept civilian emergency physicians, negates the role of other appropriately designed inclusive military and civilian courses. So this started a bit of a discussion. To their credit, ACSCOT and ACEP, as well as others, revised their joint statement and released this in 2019. A couple notable things from the revised statement were that they expanded Reboa recommendations to be any physician trained and qualified in Reboa in direct consultation with the physician who will provide definitive hemorrhage control. That the team-based approach should be multidisciplinary for the development of Reboa protocols. That the team caring for the patient must anticipate and be prepared to manage the complications, and that skills training can be achieved through various means. So this started me looking at the data on, if there are better outcomes depending on who's performing it, the volume of the hospitals performing it. So just wanted to highlight a few papers that I thought were useful. Again, a lot of the authors on these papers are sitting in this room, are part of the society. Overall, the data is sparse on this topic, but this is a paper from the European Journal of Medical Research. And they did a meta-analysis for pre-hospital Reboa. And the summary of their findings from the systematic review was that Reboa procedures found in the systematic review are performed by physicians with multi-specialty backgrounds. All procedures are performed by attending physicians, and that the pre-hospital Reboa placement is part of a well-integrated and well-equipped pre-hospital system with the emergency healthcare system. paper by the AAST Aorta Study Group that is well known, practice, was looking at volume of REBOA performed at an institution and then looking at outcomes based on this. In this paper, they found that although there's more likely to achieve hemodynamic improvement with REBOA inflation at high volume versus low volume centers, mortality and complication rates were unchanged. The number of REBOA procedures a hospital must perform, the authors concluded, is as of yet unknown. And the summary from this paper, which I think is very useful to review, is that hospitals with the greatest success likely represent multiple contributing factors, including surgeon skill, familiarity with techniques, well-developed algorithm, easy access to necessary equipment, and ancillary support. So the same authors, AAST Aorta Registry, just discussed at the Western Trauma last year, a more nuanced look at this, dividing up hospitals into high, middle, and low volume for REBOA. And when looked at it this way, the data support a modest improvement in mortality in high versus low volume centers, but no statistical significance in complication rates. And then finally, the ABO Trauma Registry, an international trauma registry with representing over, I think, 15 countries, Tal Horer being an author of this paper, looked at REBOA being performed by medical specialties, so surgeons versus non-surgeons. And, I think this paper is interesting, if only in part to show the heterogeneity between the two patient groups. So the non-surgeons were generally performing REBOA on older, sicker patients, and not surprisingly had higher mortality and complication rates and faster time to REBOA. The authors said that surgical and non-surgical medical disciplines are successfully performing REBOA to an almost equal extent. And very hopefully, in my opinion, they said the discussion of who should be performing REBOA should end, which obviously it has not. So just briefly, the hospital I work at is Highland Hospital. It's a level 1 trauma center in the east part of the San Francisco Bay. I want to give this as a case study because we do not currently perform REBOA, but we are coming up with a protocol to do so. And so what better place than the population in this room to give some feedback on that. But Alameda County is a large county. Catchment area is over 2 million people. It's the only level 1 trauma center in the area. Our penetrating trauma rate historically over the last 10 years has been 15 to 25%. Lately has been closer to 30%. And we've only been a level 1 trauma center since 2017. The last point I bring up, that we're in the top 25% of trauma centers for risk-adjusted trauma patient mortality, not as a bragging point, but really as a point that we're not a referral center. So our patients come from very close to the hospital, which gives us an advantage in terms of mortality and time to hemorrhage control. We have a busy emergency room, high volume of operative trauma cases, and most of our patients are uninsured, and the county hospital obviously has some limited resources. So for me, all politics are local. The math for REBOA in my institution, we do about 30 ED thoracotomies per year. We have 3 departments interested in doing REBOA, and that means 10 trauma surgeons, 3 IR docs, and 26 ER docs, 1 vascular surgeon, me, and many surgical and ED trainees. So for me, this equals not enough cases for competence. So how do we fix this problem? The things that we've discussed are expanding the indications. An obvious place are patients who are hypotensive with pelvic fractures. I think those patients right now get rushed to the operating room or to IR, but those would be great patients to place a sheath early on, and you can also get practice for the providers. Limit who performs the procedure to attending surgeons, or I should say attending physicians. Wider training for vascular access, although I will say getting trauma or ED attendings to come and do varicose veins is kind of a tall order, so that has not been successful yet. And then, of course, courses and simulation. So conclusions, I think my conclusion is it depends. Who should be doing REBOA depends on improving technology. I think the complication profile is getting better as the catheters are getting smaller, and we have partial REBOA now. Location of where REBOA is going to be placed. Institutional case volume obviously makes a difference. Available training, departmental staffing, And always motivation and interest is key. I would say at least we can maybe agree on the need for multidisciplinary buy-in to planning and implementation from ED, trauma, vascular, IR, nursing. The need to tailor to institutional specifics, that there's probably no one-size-fits-all approach. That whoever is performing REBOA needs to have ongoing practice, and that there needs to be an established and timely plan to identify and manage complications. And these are the references. I'm happy to take questions. Thank you.
Dr. Tepperman.
Hey, Tom, I see you've got the pink on.
I do. Worked last night.
So our moderator, Dr. Sclia, has been at the forefront of, I would say, bridging the gap between surgeons and emergency medicine physicians. But I remember the controversy when the position statement was first released and then modified. But I just want to go back to the modified version, which you correctly pointed out has the phrase "in consultation with," right? So in consultation with us, right? We're the people that have to stop the bleeding. And what I would suggest going forward is that we study this, because my experience is we say in consultation with, and then no one talks to us. So once we open the floodgates to this, there will be people flying to us from all over the place with REBOA in place that we would not have indicated, that we would not have wanted, and that we are stuck with. So I would just say, and people in this room are influencers, that this be watched carefully, that we insist on the in consultation with.
Yeah, thank you.
Chuck?
When we implemented our program in Denver, we decided that the trauma surgeons would do it. I think it was useful to have me as a vascular surgeon proctor trauma surgeons through the process until they acquired the skills needed to include very good access techniques. But having others do it that aren't at the bedside, that aren't invested in the care of the patient, that aren't going to see the patient through their hospital course, I think is a bad idea.
Yeah, I will say our biggest challenge right now is that the ER is very much wanting to place REBOA.
Yeah, I'll go back to February 2013 in Houston, and Brent Eastman got up and was very passionate about saying, if you're going to pick up a catheter, you have to peer review your results, and you have to compare your results against the local experts, in this case, vascular or interventional radiology, because if your complications are higher than theirs, then you're going to have trouble convincing people that this is actually okay. And we don't do that as well as we should. Rishi?
Thank you.
I actually just want to echo what Dr. Tepperman said, insofar as we've been talking a lot about how the rate limiting, the most challenging part of REBOA placement is femoral access. And I don't think it is. I think it's judging appropriateness. If you look at really high volume REBOA centers around the country, and then you hear the cases what cases they're using the REBOA for, the number of comments which go along the lines of, well, that person in my institution wouldn't have gotten one, is enormous. And so I think that even though we have, stated criteria, the rate of divergence on either side from those criteria in an individual center is anecdotally enormous. And I think that teaching someone the technique, fine, okay. But having them decide appropriately who should get it is really, I think, going to be the difficult part.
Yeah, I mean, that's a great point, especially since, whether it's transferring hospital or the emergency room, they're getting to the patient much faster than you are. So how to do that probably requires a lot of relationship building before implementing a program.
So actually, I'm not following the arguments or the controversy here when you're talking about it, who should put it in. So when we did it in Örebro, me and Tal, who's going to put it in? Obviously, those who put small lines in our hospital are anesthesiologists. They were the best ones with the ultrasound. But the question is not who's going to put it in, because the person that puts it in, he or she is going to follow the patient to the OR, doing the partial, doing the total or whatever, and then, as discussed here, has to take care of the sheet in the ICU to take it out. So I'm not following the discussion that you say your ED doctors wants to put it in. Are they going to follow the patient up with the balloon, do the partial thing, and take care of the complication? I don't follow the controversy. You're just talking about putting it in, and then what? Then goodbye, I'm going to go to see my next patient.
I'll invite you over to talk to them.
You're following, it's just fine.
Dr. Schreiber.
Do your emergency physicians want to place them because they want to get in on the fun, or because they think it needs to be done at an earlier phase before anyone else that could do it is there? Again, if an emergency physician does RSI, which used to be a big controversy, only anesthesia could do RSI, that emergency physician doesn't go to the OR with that patient. They stay in the emergency department. They do RSI because that was found to be the safest, most effective way to do RSI. So having an emergency physician give deep sedation or paralytics, that was something that, again, when I started my training, was still kind of in process. So now that's gone. So the fact that emergency physician, again, if the trauma surgeon, remember in the very beginning, it was trauma physicians, surgeons that were trained in vascular surgery. That was the only people that were placing them initially, a handful of them. And then it was okay, then it was vascular surgeons, non-trauma vascular surgeons, and trauma physicians, surgeons that were not vascular. Now it's spreading more and more. But for an emergency physician to do it should be if they're trained and they're facile with percutaneous techniques, which they should be, and then if they're the first ones there when it needs to be done. That's the bottom line. If it's good medical care in one center, it should be good medical care at other places within that center, not only in the TRU, but in the emergency department, if they're the physicians there at the first time.
Yeah, I think that would be my observation. That, you know, it's the appropriately trained person closest to the hemorrhaging and dying patient. And I think because otherwise it's difficult to reconcile sort of this by making this a surgeon-centric link to the surgeons. We know that's defeating in a large part the whole reason to consider it, is that we know that 30 to 40, 50% of patients, you know, the surgeon exclusive or surgeon centric approach doesn't work, you know. So it's, I think you sort of have to, I think we have to enable those who are closest, just like the patient who doesn't have an airway. You know, if we waited for them to be intubated by a surgeon, that just wouldn't work. We'd lose patients. So I think it's difficult to link this too concretely to only surgeons can do it. Difficulty is training expertise in the other specialties.
Yeah, I would agree with Todd. I think this discussion's gone on long enough. It needs to be over and done with. It's kind of ridiculous. I was going to use the same example of the airway. In my lifetime, only anesthesiologists could come down from the operating room to intubate patients in the ED. Well, what happened? Those patients didn't do very well without an airway. And so now that's kind of gone away. If we persist in this as a specialty, saying this is our thing and you can't have it, right? It's like your children in the sandbox, literally, because this device doesn't belong to surgeons. It belongs to the hospital that's paying for them. And you can put them in the ED, you can put them in the OR. And as long as the training happens, right, in the agreement of what patient needs the device, then having a multidisciplinary approach to this problem for the patient's benefit makes a lot of sense to me. And I think at a larger level for societies and specialties to say you can't have this thing, you know, is not really the right way to go. All right, Zap, your turn.
I like how many of the authors of the statement are up here at the microphone. But when we put together that statement saying in consultation, I think people are forgetting that not only is this a local hospital thing, but this is a systems level discussion. If your system is feeding you in patients that are suffering non-compressible torsi, and there's a potential to safely place Reboa at those, that needs to be sorted out at the system level. You can't be, if they're placing it without telling you, then that's a failure of your system rather than a failure of that individual hospitals. They're trying to save that patient's life. And if you haven't figured that out within your system that you're going to be getting those, then I would say that's a systems problem that needs to be fixed.
Dr. Brennan.
So nobody owns Reboa.
No company owns the procedure. None of us own it. No hospital own it. So the reason why all these guidelines were drafted and published in the first place and why courses were developed, it's to roll it out safely. That was the key goal with every single thing that we did when we wrote, when we taught, when we studied it, is to roll it out safely. If we had just let everybody do it the first day that we did it, that would be probably the fastest way to shut Reboa down initially, is there'd be so many complications. So really the goal with all of those guidelines, and they continue to roll out, is really to make it as safe as possible. However that's done, with whatever group, whatever department, whatever, specialty wants to do it. So, Reboa can be used for things other than trauma, right? We all know that, and we've been using it for many years outside of trauma. So there's nothing that tells the ED, well, they can't just start buying a catheter and doing it for non-trauma hemorrhage, right? There's certainly nothing out there that prevents that. But, our whole goal with the trauma aspect of Reboa was to roll it out safely, and that was the purpose of the guidelines.
Before you go away, Megan, safely, what does that mean? How many? How often? Where? How? Why?
Yep.
You wrote it.
Questions we are still struggling with, to look at, hospital credentialing for endovascular procedures. How many of X, carotid stenting do you have to do to keep your privileges, that kind of thing. Well, is Reboa as complex as placing a carotid stent? Not necessarily. So the answer is still out there. We don't know. If I look at the other COT courses, how many times you have to take ATLS or ACID or ATOM to be still credentialed? There's guidelines for that, and your student card expires after X number of years. But in terms of Reboa, if you're placing common femoral A lines routinely in your practice, there's no reason why you need to take the best course every couple of years just to do that.
Yeah, and I think with numbers, I think we all have to be careful. Like, how many ED thoracotomies do you have to do a year to be proficient in that? I think it's difficult, right? We have to it's not easy. And I think we have to be sort of accommodating with the realities of our practice as technologies change. Because if I was graded on how many ED thoracotomies I've done in the last, would I be credentialed to do it? We all go through our credentialing lists and see procedures there that it's been a little while, since you've done a vagotomy and an antrectomy, or even an open chole, for example. So.
Hi, I agree with most of what's been said. Just let's remember one thing. The key thing here is the access. And femoral access does not belong to vascular surgeons. It doesn't belong to cardiologists. It doesn't belong to IR or even to anesthesia, right? It can be done by several other people. I agree. If there's a complication, vascular surgeon is going to be called. Nobody else is going to deal with it. But the key has been said here before many times. Get the arterial line early. Get it at femoral arterial line. And then if you need the Reboa, you can do it. I just want to push back on something that's been said, the airway, which blew my mind because I thought everybody did it the same way. I'm from Puerto Rico. Once a patient comes into our trauma bay, we take care of the patient. Surgeons manage the airway. We do our own intubations. We do the advanced airway. So it blows my mind that that's been shunted to ER or to other people. So if you want to learn about that, come to Puerto Rico. We'll get you in shape.
All right, great conversation. We're going to invite Dr. Justin Richard back to the podium to talk to us about the role of transesophageal echocardiography and endovascular resuscitation.
Thank you again, and I'll emphasize that I have no financial conflicts of interest regarding this talk and this topic. But my disclosure is I'm not a cardiac anesthesiologist. I don't want to be a cardiac anesthesiologist. I do trauma because I didn't want to do cardiac, and then found out that all these people have heart problems anyway. But you can interpret that I'm not a cardiac anesthesiologist in two ways. One, I have no idea what I'm talking about. Why are you going to listen to me? Which might be the wisest course of action. Or the converse being, okay, here's actually just a regular anesthesiologist, and here's some of the utility, I think, of transesophageal echocardiography, at least certainly in this patient population. So objectives, again, briefly, just to review the utility of TEE and some endovascular therapy, and a lot of this being specifically related to the aorta, and I'll talk about that in just a moment. Describe some of the basic TEE views relevant to endovascular resuscitation and a brief case discussion. So the first question I think to ask is, at least specifically in talking about transesophageal echocardiography, is why not just do transthoracic echocardiography? Fairly easy to do. Pretty much everybody can use an ultrasound now. It's incorporated in terms of the FAST examination. All the residents love to do it. They want to come in and be able to do echocardiography, and they're getting pretty good at it too. But if you look at these two images here, how many of y'all have experienced these situations in the resuscitation bay where everybody's crowded around either the torso or the head? You're not going to be able to get to the chest to actually do a transthoracic echocardiogram. Or if you're in a hybrid operating suite where you've got the fluoroscopy arm that's rotating around the head or the chest, you're not going to be able to do transthoracic echocardiography. So transesophageal echocardiography, because of the anatomic relationships of the esophagus and the heart and the aorta in the mediastinum, the esophagus is sitting right behind the heart. And so it gives you a whole wide array of acoustic windows without necessarily some of the interference that you're going to get from the air-filled structures of the lungs that you would be if you were doing transthoracic echocardiography. And again, you have these whole wide array of windows going from the upper esophageal, mid-esophageal, transgastric, and deep transgastric views to be able to look at different planes and images of the heart. And so at least in terms of the American Society of Echocardiography's guidelines for imaging the aorta, and specifically for transesophageal imaging of the aorta, they list a few, I think, very important, unique advantages of TEE when it comes to being able to image the aorta. The first of those, it's highly accurate for being able to identify the aortic isthmus. If you think about where most blunt aortic injuries are going to occur, it's going to be in this location. It can be performed in the operating room, outside the operating room. Most of the time, we're wanting echocardiographic images and evidence of heart function in a lot of our patients. I mean, shoot, most say older adults, however you want to define that at our institution, are getting some type of echocardiography. So it's nice to have this type of information, not only of the heart, but also now being able to extend this to the aorta. Some disadvantages. You're not really going to get great images of the aortic arch and the proximal aorta. And that's because of the anatomic relationship of the left main stem bronchus, the trachea, as it's kind of going over to the left side and over the aortic arch. You're just not going to be able to penetrate that air-filled structure. As Dr. Stein said yesterday, she doesn't necessarily believe in pure indications and contraindications. It's more so risk-benefit relationships. And I mention that from the context of oftentimes we'll get comments and responses from our cardiology colleagues about doing a TE. This person has a cervical spine fracture. That's contraindicated. It's not contraindicated according to the American Society of Echocardiography. It might be a relative contraindication, but I think you have to put that in the context of your risk benefits. The one thing I think is really important, I say this specifically because there have been some discussions on utilizing endovascular therapy for penetrating trauma, but understanding the trajectory of the injury, especially as it's going through the mediastinum, because if you're at risk for an esophageal injury or esophageal perforation, that's a situation where I would not be placing a TEE probe. But probably the most common reasons and disadvantage, I'll say, of not being able to TEE is what's listed there in the middle in terms of just operator dependency and operator availability. Depending upon your institution, who's credentialed to do transesophageal echocardiography, who's comfortable in doing it, do you have the equipment available to do it? And this is probably one of the biggest limiting factors in terms of the utility and the common utilization of it for aortic injuries. TEE has been described with endovascular resuscitation. This is a case report out of Japan from a few years ago, where they describe using TEE to confirm balloon placement during an endovascular resuscitation, and using TEE from this mid-esophageal long axis view of the aorta, are able to visualize the balloon being inflated. This was a feasibility study from our institution by Dr. Teeter showing that TEE can be utilized in a porcine model of hemorrhage. And they observed cardiac function at different time points of aortic occlusion after 2 hours, 3 hours, and 4 hours. And I highlight there in the red boxes what I think is interesting, and it's kind of one of the questions that keeps coming up about aortic occlusion, specifically zone 1 occlusion, where you have a higher balloon location, increased afterload, increased cardiac work. Really, what are we doing to cardiovascular function? I think oftentimes we'll say, yeah, cardiovascular function might actually be decreasing. We're going to be distending the heart with a great afterload. And in fact, what they observed was the opposite. These folks appeared hypovolemic and hyperdynamic. And that was even out to 3-4 hours of aortic occlusion. The other part that really doesn't get discussed, recognized, is that the longer that it seems that these balloons are inflated, the more diastolic function these animal subjects were experiencing. I think that's something that, alluding to some of the talks yesterday about stent placement in these younger folks, more likely to get hypertension, that's going to affect cardiovascular filling, and that's a function of diastolic dysfunction. There's some basic views that the American Society of Echocardiography at least states that, yes, if you're going to have basic competence in perioperative TEE, you should be able to obtain these views. And I've got 4 of these here that I think are relevant to at least aortic endovascular resuscitation. You've got your mid-esophageal 4-chamber view where you can see all 4 chambers, left atrium, left ventricle, right ventricle. Your transgastric mid-papillary short axis view. It's going to show you at least coronary perfusion of your major 3 coronary arteries. Up top is your inferior wall. It's going to be your right coronary artery. Kind of your between 2 and 3 o'clock position, your circumflex. And then somewhere between that 3 and 6 o'clock position is going to be your left anterior descending. So this is your best view to be able to look at coronary ischemia and coronary perfusion. You can also calculate a fractional area change, which is at least a surrogate for left ventricular ejection fraction. And then the bottom 2 views being your descending aortic short axis on the left, and then descending aorta and long axis on the right. So I want to at least present with you, discuss with you in the last few minutes, a brief case we had almost 6 months to the day now. This is a 69-year-old gentleman who was transferred to our facility, had a history of hypertension, end-stage renal disease, was involved in a motor vehicle collision, a pulmonary contusion, a rib fracture, severe grade 3 diastolic dysfunction, and a blunt aortic injury. His admission troponin was elevated, had a plateau at about 0.37 and started to decrease. Cardiology saw him, say, we don't think this is acute coronary syndrome. Still got his preoperative TTE, and again, had diastolic dysfunction, some trace aortic regurgitation. So this is just his CT image showing his blunt aortic injury. So I decided to do an intraoperative TEE for the gentleman as he was getting his TVAR, really for the reasons of from monitoring purposes. Because of his elevated troponin, he's certainly at risk for coronary artery disease. You know, he's got some diastolic dysfunction, this aortic regurgitation. Was also worried about right ventricular function, specifically because he had blunt chest trauma. And said to our endovascular surgeon, like, hey, I'm going to be doing a TEE, at least to monitor his cardiac function. Let me see if I can also see this aortic injury. So I want to share with you all some of the views. And if you can play this video just in sequence here. This is your mid-esophageal 4-chamber view, just to kind of give you an idea of overall global function. But at least you can see all of the chambers of the heart. This being not one of the standard basic views, but a mid-esophageal aortic valve long axis view to, just let me go back. If we can replay that a couple times, please, to show you that aortic regurgitation, trace aortic regurgitation that he has there in diastole. And if we can play this video as well, please. But this being the mid-esophageal descending aorta short axis view. And hopefully with that color flow Doppler, you can see the color and the blood extravasating out into that pseudoaneurysm. So we're able to kind of nicely identify this injury with echocardiography. And this was after the endovascular wire was placed, which you can kind of see there in some of the reverberation artifact at the bottom of the aortic image. This is just a still image showing, again, the kind of periaortic hematoma around that aortic injury. This was, again, same view, but after the stent was placed. So if we can play this another couple times, we put color flow Doppler on it, and now you can see that that blood flow was restricted and is no longer going outside the stent. It was kind of cool, at least, to be able to get to see not only here's the injury, here's the evidence of the blood flow going outside the aorta into the pseudoaneurysm, but what it looks like after the stent deployment. So I think, where can we go with this? Limitations being not only trying to find somebody who can do the imaging, but then trying to actually get the echocardiography probe into a room. This is a big, bulky structure that we were talking about, kind of design of hybrid rooms yesterday, but now trying to fit that big, bulky thing into the corner of a room where you also have your C arm or your fluoroscopy arm. But we're coming out with lower profile devices. Some of these that are being used in the intensive care unit are actually staying in patients for a number of days just to monitor their cardiovascular performance. I think we need to better describe some of the hemodynamic characteristics that go on, not only during balloon inflation, duration of inflation, but also what happens during balloon deflation and reperfusion, going back to what we were talking about previously with organ function. And we need to be using it more. I think it's something that's easy to forget about, especially in an acute emergency when you're dealing with a whole bunch of other things, blood product transfusion, getting a patient to an operating room, having multiple infusions, trying to figure out what your priorities are. But I think this is a really, really valuable tool to be using not only acutely, but also in some of these TVAR procedures. So with that, happy to entertain any discussion and or questions.
Justin, give us a sense as to how available is TEE in American trauma centers, and what's the plan if this is so much better? What's the plan to try to get this more out in mainstream practice?
So it's going to be a little bit of a complicated answer because it's a little bit of a sensitive topic. I mean, when it comes to transesophageal echocardiography, this was something that was even going back to TVAR, this was kind of owned by the cardiac anesthesiologists. Now that echocardiography is becoming a whole lot more widely available, yet we've got general anesthesiologists and the National Board of Echocardiography, they're the ones who kind of at least own the examination process. This is being disseminated out not only from anesthesiologists, but to intensivists. There's a critical care echocardiography exam, which most of the people actually taking that exam were pulmonary intensivists. So this is being disseminated to a lot of different specialties. And I think the idea being if most anybody in an intensive care unit, in an acute situation, resuscitation unit, should be able to perform some type of basic TE. The training and the pathway is there. I think what's going to be a limiting factor is where you are, the people who are interested and willing to do it, the people who are available to do it, potentially coming in from home to do it. Those are some of the barriers. And I'll say that's some of my opinion, but at least the barriers that I've experienced.
What would be your guess as to how many trauma anesthesiologists in the USA can do TEEs?
Depends on the institution, and that's my trying to be
rare.
politically correct answer. Because the other part to it is it really does depend on the institution and how they are credentialing people and allowing them to do TEEs. It's not risk-free, but the risk is really, really low. Probably the biggest thing to know is with any device, whether it's pulmonary artery catheters, the Vigileos, continuous cardiac output monitoring, is how you're using the information. Anybody can place a TEE probe, but it's how are you going to use that information? And so I think most, at least acute care anesthesiologists, trauma anesthesiologists have the capabilities, they should have the capabilities based on training to do a basic TEE for monitoring purposes. Have they all taken the exam? No, and that's going to be something that's going to be probably pushed pretty hard because so many other specialties, going back to how are we training, credentialing, and making sure this is done not by a specific specialty, but making sure that it's being done safely and in a coordinated, effective manner.
Great, thanks.
Thank you.
Thank you. Dr. Dua already gave her talk earlier today, so this concludes the session. Thank you.
All right, everyone. Moving on, our next session is entitled Reboa, the Past and the Future 2. And our first speaker is Dr. Raza.
Assuming this is from pressing me forward. Yeah, absolutely. Thank you very much, everyone. Thanks to Dr. Fox and Dr. Kundi for the privilege of the podium, and to the moderator. I have nothing to disclose, except after listening to Dr. Rajani yesterday and looking at all the bright minds here, I do not have all the answers, so please be kind. One of the major determinants for ischemia reperfusion injury is the maximal duration of aortic occlusion. We've seen many techniques come out for mitigating this, intermittent deflation, partial deflation, and the new repeatable catheter. All of these have somewhat limitations in the sense that, we've seen for ER-Reboa, inflation profile is not the same as deflation profile. And both catheter, whether you're using generation 1 or generation 2, the Peter-Boa, deflation is predicated on acceptable hemodynamics above the balloon, as evidenced by the data earlier today, up to 15 to 20 minutes before you start deflating in some cases. So along with this, there's an evolving need to push the Reboa earlier and earlier in the field, leading to less time for those of us who are surgeons and put stitches in. So what do? All of us put Reboa pretty much the same way, and put a sheet, inflate the Reboa balloon, and start this cycle of distal ischemia. I have to see the latest data from Dr. Penner with the aorta study. At Penn, we're not in the top 5 contributors. I think we're number 7 when I looked at the last contributors list. I don't do anything with the the sport on the sheath. I don't monitor distal pressures. We don't have enough staff. It's always a little bit of a shit show, for lack of a better word, in the OR. So this sheath is floating in the breeze. God forbid if I connect it and confuse the anesthesiologist with what they're looking at now, has happened in our center. So I started thinking, what's the difference in size between the inner diameter of the sheath and the outer diameter of the Reboa catheter? Is there room? Turns out there is room. Corresponds to about 24, 22 gauge needle. So I'm like, all right, what if I connect something to keep, we have TKO, vascular surgeons use that to inject heparin. What if I use this to inject something else? What if I pressurize this somehow? So one day post-call, just tried it in the trauma bay. All right, yep, I can hand inject something. It goes along with the catheter in the sheet. What if I tried in the mannequin? Here's some green dye into the mannequin. Yep, below the aorta, below the balloon, it does inject. Does it reach the aorta? Sure. How far? I don't know. So we designed this pilot study to see if Reboa with distal resuscitation can infuse some fluid, X fluid, into the distal aorta when it's occluded. And will this X fluid mitigate any deleterious effects of ischemia? And can I maybe identify something that's injured in the abdomen as I'm doing my X-tap with the balloon inflated or partially deflated? So this was a pilot study. We did it in an animal model, Yorkshire pigs, anesthesia, general anesthesia with venous access. This is a setup. We did a left femoral 7-French sheath, zone 1 Reboa. It shows the balloon up, but it's just to depict that easier on the slide. When we put it up, the balloon was down. Connect the side port of the 7-French sheath to a rapid infuser. This is a prep. We did an X-lap, took the spleen out so that we don't get that, recirculation from the spleen, the 1.5 liters that it can contribute. And we slowly bled the pigs over 20 minutes. Why over 20 minutes? I don't know. I didn't want to kill a pig. I only had limited amount of money. I had money for 6 pigs. I wanted to take it safe. So it's 20 minutes, 25% or more, targeted map of 40%, stored the shed blood. Created an injury on the contralateral side, left common iliac, more than 50%, inflated those Reboa in zone 1, and started putting in 3 different things, and I'll show you the 3 arms. And this fluid, whatever fluid we're injecting, was going in the sheath, mind you, below the occluded aorta, balloon in the aorta. Every 15 minutes, split the animals into 3 arms, 2 controls, 2 that got shed blood back, and 2 that got 1 liter of LR every 15 minutes. So this is our study flow. Injury at time point 0, injected distally in the 3 arms every 15 minutes. These are our results. Question number 1, does it reach the aorta? Yeah, it does. This is our sheath. This is the Reboa with the balloon up, and you can see the contrast up here. I have this in video. Hopefully this will play well. No surprise there. Inject along the side of the Reboa into the sheath, reaches the balloon all the way up. Next question, does it reach the renals and the celiac? Yes, it does. We heard from Dr. Richards earlier that, we need to come up with solutions to aid when the patients are in this ischemic phase, and this could potentially aid this ischemia, acidosis, and AKI markers. Well, how much? So looking at this data, I split it into 3: controls, blood, and LR, and I compared the groups from percentage change from their own baselines. Lactated ringers were the most acidotic from their baseline compared to blood and controls. Mind you, these are central values from right IJ. So of course, you're infusing distally, this acidotic milieu is coming back into circulation. So you're going to see that injury that you were going to see after deflation early on. Same thing with lactate. Lactate is 1000% the starting value. Of course, it's going to be, you are starting to perfuse that ischemic bed early. Better than blood and controls, but worse than blood and controls, but I was expecting that. Here's when it gets interesting. Not as much hyperkalemia with LR, and definitely improved early markers of AKI. This is one of the graphs. This is controls with creatinine over time points. This is blood. This is lactated ringers in the distal ischemic bed. So the third question, well, what happens to that iliac artery injury? Does everything perfuse out? Turns out a lot of it perfuses out and leaks out, extravasates. That's my injury. But look at that. There's distal perfusion into that leg. So there could be an added benefit there as well. So in conclusions, DEBOA with distal resuscitation provides us an opportunity to partially perfuse or resuscitate distal organs during occlusion. This solution can potentially help mitigate early ischemic effects, and we may be able to aid in localization of intra-abdominal injury and also potentially perfuse the leg partially at least. Some solid limitations here. It's a pilot study, added a bunch of liters of volume to resuscitative overall, balance for this patient. I didn't have money to actually study the durable benefits on ischemia reperfusion injury. We did take tissue samples, but we have to see what exactly was the benefit and the actual renal pathology. And I have yet to see what the synergistic effects would be with the partial DEBOA. There are still advantages to this. There's no additional arterial access required for this. There is potential for early benefit even before you start getting hemodynamic stability. And think of the austere environments. Think of not only pre-hospital, think of forward soldier, medic, all the way out, 20 minutes before even getting to the forward surgical field. They can possibly hand inject this, whatever this cocktail is, every 10 minutes, distally on the side sheet. TKO, resuscitative fluid. That's what is it. What's the ideal solution? I'm looking at crystalloid, steam solution, renal perfusate, ALM cocktail. I don't know what that ideal cocktail is. Once I find it, I'll put it on the menu. We can all order that. How much, how often? Thank you.
That was awesome work. And that's a really cool pilot study, and I hope that you get it funded and you blow the doors off of it. I want to make a comment that hopefully will unify a couple of other things that were said here earlier. The flow around of your sheath, if you go to a 10 French sheath, then a 7 French catheter going in there, you get plenty of flow, right? So is there a role for lower profile devices? And the reason I say that is because we're starting a protocol at Wake. They called us to come think about ECMO for patients that had arrested and died and were pronounced in the ED as a way to preserve organs for an uncontrolled DCD donor protocol. I said, I don't think we need to do that. I think we need to be doing exactly what you're doing, which is occluding at the diaphragm level and perfusing organ preservation fluid while we use a multi-stage venous cannula to get all of the blood off as quickly as possible on the way up to the operating room. So we've actually, I missed our first rollout protocol training session day, but we're going to start that soon. And this would be, the stuff that you're thinking about and doing right now is like fantastic. It is in the exact same lane. So there's definitely opportunity for collaboration. And if Dr. Moore's not here, but the notion about how do we get more organs, and these are for medically arrested, pronounced patients in the emergency department. And then the other thing is too, things like that would ultimately result in more reps for our emergency medicine colleagues that are at the point of, they're the ones calling time of death for a lot of those patients. And I think that, all boats rise with the tide, right? And so the ability to get more people, more reps in a pinch could potentially be really beneficial.
That's a great point. Actually, in the journal that's printed, that's being circulated outside. There is a case report from Denver, I believe, about a patient that had arrested and was supported with the Reboa as the goal being organ donation. And we've done exactly that with the Reboa in our center as well. Thank you for great points.
What I love about this meeting is there's so many different interesting thoughts and things that I never would have thought of. So congratulations. My question for you is, why do you think this works? And the nature of the question is that you're giving back fluid or blood, but you're not going to be, the purpose of blood flow is to deliver oxygen to the tissue. And so whatever you're going to be giving is not, unless you're on a sort of ECMO pump or somehow giving blood back from the arm or whatever, you're not going to be giving oxygenated blood to the tissue. So why do you think this works?
So I've thought about this a lot. We don't think and we don't question that when we give cell saver blood back. That's deoxygenated, arguably coagulopathic blood, but we give it back and there is benefit. I think the biggest benefit here, anecdotally, these pigs made urine. With the controls didn't, and the ones that we did with LR made urine, and the ones with blood didn't. I think it's just a matter of spreading out that oxygen debt or that ischemia that's building up. Spreading out that insult of acidosis and not letting it mount to a certain point. I think just evening out that curve is what helps, I believe.
Just picking up on Greg's last point, and I have to say I've been listening to Dr. Manning, but I don't understand exactly how his gizmo works. But if you put those two things together, why not put something with oxygen distal to the balloon?
May I complete and say that this is the great thing about multidisciplinary. We use as routine perfusion with introducer. We call it endoshunts, endovascular shunts. You can connect everything you want to every part. You can perfuse a limb, a male to male contact. You can give blood from here to here. For example, in endovascular surgery, we block with introducers the femoral arteries. So we do antegrade perfusion. This is the same idea. And I think this is a great solution. It will not solve the bleeding, of course, and all this, but you maintain some flow and it's being used. That's the fine thing tuning we can do between vascular and endovascular surgery and trauma, preserve an organ by this solution. Quite simple solution, give fluids. And by the way, we use 8 French in the ER Reboa always, so we have a bit more place.
Even more room.
Yeah.
My hope is that if I get shot, whether it's near Vanderbilt and you put it down for 1 minute for the CAT scan, or if I get shot near Denver where you don't put down your your Reboa Pro at all early on, you just inject some solution distally to wash things out.
Yes. So on that point, it's just a discussion point because, you know, I know that a lot of centers would just take a patient to an operating room if they're that hemodynamically unstable and we've deployed a Reboa. Some are going to the CT scanner for a CTA, drop the balloon, leads to this hemodynamic instability and variation. How were you able to do your angiography? Were you diluting 1 to 4, 1 to half, you know, whatever?
50-50.
50-50, and you're able,
yeah.
you know, to get that.
Yeah, the first pig I did was absolutely just a trial run, and that was I hand injected straight up contrast, 50-50, 1 to 4 dilution. And I think diluting anything more than 50-50 was not giving me good images. I think, but we were doing it under fluoro, not a CT scan.
Okay.
I believe CT scan would be much more sensitive even if you dilute it. But the same technique can be used in Vanderbilt. You do not need to put the balloon down. I think Dr. Brenner's data suggested that you still get distal flow even with the balloon up. But even if you wanted better contrast to prove to your IR colleagues that, hey, there is blush, you can hand inject it or hook it up to a rapid infuser, and you don't ever need to put your balloon down. You can just inject distally, you get contrast distally, and you can get even better blush than a hypotensive patient might show you.
And I don't know if anybody's here from Reboa, but is that a power injectable site, or would that have to be something that we do hand?
No, I the very first pig, the trial one, I did a hand injected and then switched to I use Belmont, but I understand that that's a brand name. But yeah, any rapid infuser would work.
Appreciate it.
One thing to think about is custodial solution. So for organ preservation, that's what they're using for flushing, and that's actually what vascular surgeons use for open thoracoabdominals for cold renal perfusion. So the other thing is like hypothermic fluids potentially be something that be able to preserve the organs without the organ dysfunction.
Yeah, absolutely.
Although it makes them coagulopathic.
Yeah, I think there's adenosine and mannitol and those solutions, and yeah, that's the next step. All right. Thank you very much.
Sounds like you're going to need about $12 million in funding to do all those ideas. All right. Next is Dr. Neff.
It's good afternoon. I want to just thank EVTM, the program committee, for letting us share a little bit of our work. A couple disclosures here. Co-founder of Certus. Why Certus exists, that's maybe a conversation over beers. You can find me later. I wanted to start out, I was thinking about this book, and I don't know if anybody's had a chance to read this book. I would recommend it to you. It's a guy named Simon Sinek. He's a kind of a big picture thinker. He pulls together a lot of different ideas. But one of the things that he has written about recently is the infinite game. This idea of finite game mindedness mindsets and infinite game mindsets. And it just is lodged in my brain. I keep turning it over. And I'll get to a point here in a second. But you have two mindsets, right? The finite mindset is there are winners and losers, almost like an athletic competition. There's a defined set of players, a certain amount of time. At the end of regulation, if you have more points, you win, the other team goes home. And so, in some senses, that finite mindset is born out of like this idea of competition or scarcity, wins versus losses, right? And I think we can all sort of understand that. The problem is there's so many things in our lives that we apply this finite mindset thinking to that don't follow those rules at all. Nobody wins marriage. I mean, you can sort of be winning. We talk about that. Nobody wins business, right? Nobody wins best doctor. I mean, maybe there's a competition there. But so much of what we do is infinite. It's infinite. And I'm getting there in a second to where I want to say. And that's the reality of the life we live and the world we live in. When you embrace infinite mindset thinking, there's like trust, there's collaboration, there's innovation. And so I specifically want to just acknowledge the origins and the ethos behind this society, especially. And I think that really we owe Tal a lot of that. I mean, the fact that he would say that over and over again until it's beating our heads, no ego, just good science and cooperation. And so anyway, that's something I just wanted to express to you all and get out there. And I've been thinking a lot about it. The struggle is real, right? We've talked about all these different things. At the end of the day, it's about adoption. And and in my mind, I think that we should strive for as many people as possible putting that in. Has anybody seen this on Twitter? It was freaking hilarious. And, obviously everybody knows that Bilal Joseph's the biggest hater. I saw him the other day. He's going to potentially send a resident to work with us in our lab, which I thought was, sort of like a little olive branch. But anyway, adoption is real. Like it's a huge problem. And for the hemorrhage market, the use case, and I think Dr. Holcomb made this comment, the number of medical cardiac arrests versus hemorrhage. I mean, the numbers don't even match up, So there's a lot of ways in which we can really push things forward. So why automated partial Reboa? This is a video of Dr. Williams in the operating room. He was called in to help a colleague who was dealing with an aortic enteric fistula. The patient was dying. He quickly got a catheter in. He quickly had it actually took, 15 minutes to get the entire apparatus set up so he could do fluid column transduction of the sheath as well as the distal tip. And here he is using an endoflator, rotational inflation device, to target precision resuscitation. You can see, I think, the above and below pressures. And there's a lot going on here. Let me see if I can get it to advance. Can you start that video there? Is it doing? So the operative team's working, trying to save this gentleman's life. He's sitting there. All of his focus and attention is on making precision movements with a very precision syringe in an effort to titrate to effect, and all the things we've already talked about. The other thing I want to mention, aside from the infinite game mindset, is this idea of partial Reboa. I think inherently within the word Reboa, it's occlusion, right? So partial Reboa, like partial occlusion, we're talking about occlusion is occlusion. And so, it's a little bit of an oxymoron versus, maybe it's time for a rebrand, especially with all the people that just can't get their minds around all of the complications or things that are associated with Reboa in particular. Several folks in this room contributed to this paper. It was a consensus statement, just trying to get some of the alphabet soup for all these different techniques and styles codified. I would recommend it to you. And we all know, and we talked about this a little bit, but this is, I think, probably the most important thing I'll say is that aortic flow is super complex, right? There are so many things that are interrelated and happening at the same time, and it's much more complex than even this. And if you think about what you can actually leverage and control as providers, for the most part, two things: intravascular volume, i.e. the amount leaking out of the bucket and the amount you're pouring in, as well as your degree of aortic occlusion. But past that, you don't have a lot of control over anything. And that really is that's the take-home message of what I'm going to get to next. This is somebody mentioned the idea of a dimmer switch, and I think that is exactly right. This is something that we had kicked around a long time ago. I think you'll recognize some of the folks in that picture. But Dr. Williams had put this slide up there in front of folks in Vienna in 2016 to say, like, we need something better. We need a dimmer switch. We can't go binary off and on. I'm going to show you some data why that is. In 2015, Dr. Johnson, who's not here right now, and myself and Tim Williams and Joe DeBose, who we were all active duty in the Air Force, and we were sitting around and we had done a series of experiments and come across some pretty interesting concepts. We immediately, Austin wrote the methods and results, and I helped him with that. We called Joe DeBose on the phone at about 4 p.m. and said, hey, this is what we got going on. This is the data. We sent it to him. He looked at it, said, that's great. I'll write the discussion and I'll write the intro tonight. And so he did that. He was on call at UC Davis. Later that night, this is the one thing that we found out, is that when you wean from occlusion, despite your level of shock, there is a fairly linear relationship at ultra-low flow volumes. And that's of the distal mean arterial pressure. Everybody's sort of fixated on proximal. We saw that the distal mean arterial pressure was actually a control input for precision weaning from occlusion. And the reason this matters is because the return to flow, and you'll see this is on that little stair step, is actually incremental deflations of a balloon, and the solid line there is aortic flow. And you can see it's a stair function, but you get to this point, you can see it around 3.5 minutes where they deflated a little bit more, and all of a sudden the floodgates opened. And look at what happened. It went not to baseline aortic flow, but there was this hyperemic effect from the high proximal pressure head and the vasodilatation of all the downstream ischemic beds. This is a real phenomenon, and people have seen this, right? You come down the balloon, you think everything's going well, and all of a sudden, boom, they just drop. Well, that's because you just fell off that cliff right there. And so we started talking about that, and later that evening, lo and behold, Dr. DeBose, on call at UC Davis, has his first patient, and he starts to apply these principles. And even, the great Joe DeBose, trying to titrate to distal pressure, still had a really hard time. When they went to 20 minutes of partial occlusion, they were just all over the place. And the reality is he just did not manually have the precision that he needed to do that. And he was trying to guide a fellow and a resident as they not only did a thoracotomy, but also to control bleeding, but also did a laparotomy, and we're trying to get all that cleaned up. It almost took all of his attention. So why automated partial BOA? Well, because you need precision. And if you think that, like, set it and forget, it's not going to work. I mean, there's a lot going on with aortic flow, and there's a cognitive overload that happens, right? You saw that picture of Dr. Williams there sitting there with all of his focus and attention on that control of that balloon in a patient that was exsanguinating, and at the same time getting lots of vasopressor and lots of blood. And the whole thing is just a very dynamic process. This is sort of where it all began. That picture to screen right there, or screen left rather, is funny. If you notice, it's an extracorporeal circuit, and we were just talking about that a minute ago. The way that we regulated flow was actually with just a hose pipe valve. We had used ECMO cannulas and done this extracorporeal circuit and then occluded the aorta, and we sat there and we would just dial the amount of flow we wanted downstream. And then we got more sophisticated as it went on. So if you're going to do this, though, here are the core needs, right? If you are going to automate a device to partially occlude the aorta or fully occlude it, you have to have high fidelity inputs. You can't do this with data streaming into the device, telling the controller what to do if the data input is not good, right? So that's high fidelity physiologic inputs. And then you have to have algorithms that are built in for precision and safety so that you're not, having this hysteresis yo-yo effect. There's other folks that are out there doing this, and this is a paper that was presented in 2021 at WST from the folks at USIS looking at the APOC controller. And so I wanted to give them a nod. But at the same time, the paradigm shift is this, right? Hemodynamic targeting for both your proximal in the case of a TBI or not wanting to get too hypertensive, especially as you have resuscitation products that are coming down the pike, but also your distal targeting, right? And I'll get into why hemodynamic targeting is so important and what its expanded applications are. A lot of folks in the HIMSS group, actually in London, they're going straight to partial, right? They, Dr. Kochis mentioned yesterday this idea of spontaneous partial, and I thought that was a great point because we see that all the time in the lab with automated controllers. The balloon starts to inflate more after you thought you were at occlusion. You turn around, you see that, oh, there's a trickle, and the balloon's responding and inflating automatically, and that's because of that very effect, the partial spontaneous partial flow. And then the idea, and Dr. Williams mentioned this the other day, of a macrovascular pressor, a resistor in the aorta operating at ultra low volumes. We're talking 0.5 to maybe 1 cc, and that is enough to have actual hemodynamic changes for a patient that has become sort of metastable, and you're just trying to smooth out all the peaks and valleys. One of the things that I think is really important and is the next frontier and where we need to have our emergency medicine colleagues in the mix and our anesthesiologists in the mix is this idea that for cardiac arrest, for medical cardiac arrest, this is a real game changer. Certainly a lot easier than ECPR. It could be a bridge to ECPR, but it's so important because if you think about it, it makes sense, right? What's your greatest chance of ROSC is really by increasing your coronary perfusion pressure. If you have a backstop to push against, every single pump of that CPR is going to increase that. And so, getting ROSC back is one thing, but once you get ROSC back, you've got a whole new problem set, right? The balloon's inflated. How are you going to bring that down without rearresting? And I think the Norwegian experience shows us that the rearrest rate is actually really high because you don't have that precision return to flow. You don't have a balloon that's adaptive and responding to what the patient needs, especially the diastolic pressure, which we know is like what coronary perfusion pressure is based off of. So the idea of targeting the diastolic pressure with an automated controller, that's actually where the sweet spot is. I mean, we should all sort of run and start working on that. So this is something that is in development. We have no timeline at this point for when we would actually be able to introduce this to the world. We can talk about that later. But this is an automated controller. It goes in, and what it gives you automatically is a pressure above and below the balloon. Solid state blood pressure that's much more impervious to any of the artifact that you would see with traditional fluid column transduction. Put your syringe on, just like any other workflow, and then all of a sudden you pop it in to your controller, right? And so that gives you the ability to do precision titration with up and down in a manual fashion. You could pop it out and use your hand if you wanted, or you could say, you know what, I need my proximal pressure to be 120, boom. It's going to sit there and work to get you there, and it's going to move with microliter precision that you could never accomplish by hand. And that's why the other day when one of the young physicians was making that comment about how they titrated, I was like, well, are you doing it by hand or are you doing it, what sort of, you can't get the precision you need, especially if you're trying to manage 15 other tasks. I think about the HIMSS guys and gals in London that are doing this work on the back of a helicopter or, in an Audi screaming through the streets of London and trying to get it all figured out. And you've got to give them something to work with. Want to shift a little bit. So that same device that you would use potentially for, helping initially staunch hemorrhage and resuscitate that patient can certainly be a destination therapy for prolonged wean, right? There's absolutely no reason, especially if we're talking about ultra low volumes, that you can't use that as the macrovascular resistor. So, one of the things I think was lost on people when Dr. Williams was presenting this EPAC concept is it's not like you walk up to a patient and say, oh, they're on a bunch of pressures, let's put in a catheter. No, it is the thing that helps you blunt that hyperemic ischemia reperfusion injury right after you just got done using this catheter for hemorrhage control or any, automated occlusion catheter. One thing we see is, you can dial a pressure in and it stays there. And these are pretty sick animals. And more than that, and I think Dr. Williams showed this yesterday, and I'll just underscore it, when you have the right quote unquote dose, and that's all based on the algorithms and the integration of fluids and other medications built in, then you can actually improve renal blood flow. So I want to think about the paradigm shift, right? The spectrum of resuscitation. And I highlighted this part off to the left here for a specific reason. decision-making and patient monitoring. We're talking about who needs this, right? And I get that. But wouldn't it be nice if you had like a heads-up display to tell you exactly what the hemodynamics were when you put the catheter in? And then when it's time, you push the button and there you go, right? So the ability to figure out who needs it and who doesn't. Maybe you just get it. A lot of people were much more permissive with it, but then you have the ability to not only monitor and know when it's go time for providing some aortic support. Maybe you go to full occlusion, maybe you go to partial occlusion. Maybe as you get to the operating room and start to get things under control, or the IR suite, you're able to start a prolonged automated wean to maintain perfusion, and then you're off to the ICU. This is especially important in the context of traumatic brain injury. We've all been talking about that and how to manage a patient with concomitant hemorrhage and TBI, as well as neurologic emergencies of all kinds, right? Like, why stop here? So, this is nice and it's good. It's not standalone though. It needs friends, right? Let's get infinite in our thinking. Let's collaborate. What if we could sit there and use this as a EWS or a trigger for transfusion? What if you could do just in time, right volume, right rate transfusion just to get the physiologic response you need? Think about the implications for prolonged field care, in-route care. You're a ranger and you've got 2 units of Rolo or whatever, and you've got to make that last for the next 5 hours. Well, maybe this helps you do that. So what is the African proverb? If you want to go fast, go alone. If you want to go far, go together. This is the tier 1 system. It's not quite ready for prime time because some of our buddies and partners have asked us not to share that. But the idea of transfusion and endovascular resuscitation, you've got invasive, high-fidelity hemodynamic monitoring. You've got the action of a balloon based on a particular set of thresholds. What better way to trigger transfusion? So if you have a Belmont that fits in your hand that can deliver a whole lot of warm, whole blood very quickly with minimum footprint, then maybe you have a game changer, not only for prolonged field care, but just, en route. Try and push that Belmont from the trauma bay up to the operating room, is not always that easy. And so I just come back to this, the infinite game, right? I encourage you all to look at it, think about how the collaboration and the relationships and the space that Talus and all the folks that have worked so hard to create this organization have put together for us to think a little bit bigger than just what we've been talking about so far. Thank you very much.
So, Dr. Neff, as you were talking, I was getting this deja vu thing in my head. So I'm recently a pilot and now going for my instrument rating. Let's see if you can know where I'm going with this. So, the way you learn instruments is they put these foggles on you, right? Which all you can see is your instruments. And my instructors are forever telling me, Sheldon, fix yourself. The plane's caca, right? And then I get tired of them doing that. So does anybody know what I'm going to say? What do? I hit the autopilot. Right? The autopilot is a constant servo, just like your automated thing, and it does a much, much better job of flying the airplane than I do, although I'm going to learn. So I think this is the way to go.
Thank you. Appreciate that.
Thank you very much. And from the point of view of traumatic brain injury, considering the risk of clotting and all that, but if you could use a thing like this for, say, the first 72 hours to regulate the CPP or the ICP or whatever, and to treat the patient and come off